The weakness improved. The ptosis resolved for some time, uh, and there was no bulbar dysfunction. Sensory function remained intact, and no abnormality were noted in the skin, joint, and cardiovascular and respiratory system. Investigation we did. Investigations where TSH were 0.01, T4 free T4 were 3 feet. Total 3 T3 will is 879. USG thyroid, as I told, it was diffuse hypoechoic thyroid enlargement suggestive of goiter. NCCT chest was done, there was no thymoma, chest x-ray was normal, CBC, LFT, urea creatine, all within normal limit. We did MRI from outside as it is not available in our hospital. It suggests T2 weighted suggested hyperintense with mild thickening seen in bilateral superior rectus, inferior rectus, medial rectus, lateral rectus. It was seen suggestive of thyroid orbitopathy. Rapid nerve stimulation test was done. It showed decremental response. Anti-acetylcholine receptor antibody was recently done after 5 to 6 months of follow-up after the treatment, and it was negative. Management, we started him on steroid therapy. Earlier we give high dose steroid, then we shifted on low dose alternate day 10 mg steroid, and pyridostigmine was started, and also he was on azathioprine. So my case was a unique and a rare case, Graves' disease with myasthenia gravis. These two diseases can coexist because of shared autoimmune phenomena, and this case highlights the importance of recognizing the rare association between myasthenia gravis and Graves' disease, because these two are the autoimmune phenomena. They both can coexist, and we should diagnose this in early stages because two are very confusing. The epidemiology of this study is myasthenia gravis can occur in only 0.2 to 0.5% of the patient with Graves' disease. And in Graves' disease patient, there are 5 to 10% of chances of having Graves' disease. So we should evaluate a patient with myasthenia gravis for having any signs of Graves' disease or not. Okay. This is the video of the patient, which is showing the eye after hydrophonium test. Earlier, his eye movement was restricted. After doing hydrophonium test, that eye movement also improved, and ptosis also resolved. He is trying to lift his eyelids. Thank you so much. This is the reference, and I also thank you, Pankaj sir and Dr. Alappan sir, to guiding me through this case. Thank you very much.
Yes, Dr. Nihal, good presentation. Uh, you didn't tell us how you manage the thyroid part of it. Graves' disease management was mentioned?
Graves disease?
Management?
Management.
What do you do for the
What
patient?
madam is asking, you have mentioned about the management of the myasthenia gravis, but you didn't mention about the management of the Graves' disease.
Graves disease.
So how did you manage it?
Carbimazole we started, antithyrox. We started on 10 mg BD. That was started.
So now you're seeing the patient after 3 months.
Yes.
TSH is 25. It's gone up.
Yes.
What impact will that have?
We will decrease the dose of carbimazole, and it is going in hypothyroidism kind of thing, and we will check for any antibody, thyroid stimulating antibody, and we will decrease the dose gradually in follow.
So what you should remember is when you have eye disease,
Yes, ma'am.
this fluctuation will worsen it. So you should avoid thyroid going from too low to too high.
Yes,
and
yes.
you should preemptively ensure that your management is call the patient early and ensure the patient does not go into either too low TSH or too high TSH.
Yes.
Just few points with regards to your presentation. One is you said patient had blurring of vision, right?
Yes,
So
yes.
when somebody has blurring of vision, what are all the things that you should think of
Blurring of vision.
in patients with thyroid eye disease? When there is blurring of vision, are we concerned about something?
Ma'am, Graves ophthalmopathy can be there.
When will it cause? What structural involvement will cause this?
Ma'am, fibroblast is
Any
present.
other nerve involved? Any chance of any other
Optic
nerve
nerve,
involved?
Good optic nerve.
neuropathy can be happen in later stages.
So we should look for optic neuropathy
Neuropathy.
or
Edema can
maybe
occur, ma'am.
involvement
Due
of
to,
corneal edema. So these are the two things that you should look for. Whenever they say blurring, we should be cautious not to miss optic neuropathy.
yes, yes,
Right? And another comment is that your T4,
yes,
you just wrote T43. So you should always write the units because there are different assays, different units. So T43 actually looks like very low.
yes.
So it doesn't look like Graves or thyrotoxicosis.
Ma'am,
So probably it was FT4.
yes, yes.
So Nihal, how many months back you have you have
Got
diagnosed this case?
Sir, about 9 to 10 months back.
So he is on your regular follow-up, I
Yes,
hope.
yes, yes, sir.
So have you noted any improvement in
Yes,
the
sir.
features of myasthenia gravis with features of improvement of the Graves disease component? But what is your
Yes.
idea whether the myasthenia component can improve with improved status of the Graves?
Yes, sir. It can be possible if we are treating any one disease, then like if we are treating myasthenia gravis, then Graves disease component is showing like
So how are you
positive.
convinced? Have you been able to reduce the dose of pyridostigmine or steroid?
Yes, sir.
I'm not sure.
Pyridostigmine is stopped, sir, now.
So
No.
he is now without pyridostigmine.
Yes,
He is
yes, sir.
only on ATD.
Yes, yes, sir.
Yeah,
ADT and sir, low dose of prednisolone steroid series.
yeah, nice presentation, Dr. Nihal.
Thank you.
Continuing with what Belinda madam has started. So, if you are following up this patient,
Yes, sir.
so and you are ordering a thyroid function test,
Yes, sir.
what will be the component that you will be asking?
Sir, mainly T4 I will ask. Free T4.
Uh,
Free
no,
T4,
we'll be
TSH.
needing the full thyroid function test.
Yes, sir.
TSH, free T4, either free T3 or total T3. Actually, that is something I want to point out.
Yes, sir.
So, secondly, you mentioned that the patient is an occasional smoker.
Yes, sir.
So, what are your thoughts, or how will this smoking will affect this patient's Graves disease and myasthenia gravis?
Sir, smoking is one of the risk factor which will stimulate autoimmune condition and will lead to like aggravate this condition. This is one of the risk factors, sir, for which
So, any advice that you gave to the patient regarding
cessation
smoking?
of smoking we told.
Yeah, smoking is strongly discouraged. Actually, it will
Yes.
aggravate the Graves
Yes,
ophthalmopathy.
sir.
Okay. Thank
It
you.
will
Okay.
also.
Thank you,
like-
Nihal.
Thank
So I would like to invite Dr. Dharmendra Kumar.
Thank you, sir. Thank you, Judge.
Big round of applause for Dr. Nihal for the first presentation of the day.
Yes, Dharmendra, you can start.
Yes.
Dharmendra Kumar.
Yes.
You are from Purulia.
Begusara, Bihar. Purulia Medical College.
Okay, okay.
Can we have the second presentation?
Yes, sir. Sir, my name is Dharmendra Kumar, first year PhD.
Dharmendra, wait. They'll load your presentation. You don't touch the, yeah, there it is.
Yes, sir.
Yes, please, start.
Yes, sir. Dharmendra Kumar, sir, first year DNB PhD, Purulia Medical College and Hospital. Sir, my patient, 23-year-old female. Chief complaints are swelling of eyelid and diplopia for a few days. She is homemaker and informant is herself. She has no history of smoking or alcoholic, and she is non-case of hypothyroidism with 75 microgram of levothyroxine OD, and no significant family history, ma'am. We examined the patient and found out that BP is 110/80 millimeter of Hg. Height was 163 centimeter. Weight was 64.6 kgs. And BMI was 24.31 kg per meter square. Pulse rate was 68. And by examining we found out that grade 1 goiter present. Lead swelling present and visual acuity 6/9 both eyes. Color vision intact, chemosis present, gaze evoked pain present. So clinical activity score was found out was 3/7. Sorry. Clinical activity score was found out that 3/7, sir.
You just address the audience.
Okay, sir. Thanks. This case, sir, differential diagnosis was orbital tumor, which often occur unilaterally, idiopathic orbital inflammation, which was again unilateral and painful. Myasthenia gravis, fluctuating vision loss should be present, and ptosis, and carotid cavernous fistula, that is pulsatile exophthalmos will be present. We done investigation and complete blood count, liver function test, urea creatinine were within normal limits. Serum TSH was at presentation 70 milli international unit per liter. Serum TSH was serum TRAB antibody was 25 international unit per liter. We done MRI orbit, which reveals diffuse extraocular muscle enhancement and enlargement with a sparing of tendinous insertions. And final diagnosis was made thyroid eye disease with primary hypothyroidism. And we managed patient with tablet levothyroxine 100 microgram OD before breakfast, tablet mycophenolate mofetil 500 mg BDPC for 6 months, and injection methylprednisolone 500 mg for 3 consecutive days, 3 month cycles. And eye drop was given for lubrication. And after 5 months, sir, her TSH level down with 3.23, and current clinical activity score was 1/7, sir. This is some reference we have given. And thank you, Dr. Singhania, sir.
Good presentation. How often do you see thyroid eye disease with hypothyroidism? Usually we think of hyperthyroidism and eye disease, right?
Yes, ma'am.
Is it common to see with hypothyroidism? Can you talk up?
No, ma'am. Very uncommon presentation.
How can we explain? Madam is asking that. The frequency and how can we explain the mechanism?
Mechanism was, ma'am, eye muscles exhibit TSH, thyroid antigen and eye muscle antigen are similar. So antibody attack again extraocular muscles, and myofibrillars proliferation done, and glycans were accumulated in muscles.
Okay. Okay, good. You mentioned the CAS is 3/7, right?
Yes, sir. Yes, ma'am.
Can you tell me what are all the 7 points?
Yes. Spontaneous pain present, ma'am, 1 point given. Or gaze evoked response, superior or inferior gaze, then 1 point given. Or chemosis, ma'am, 1 point given. Or erythema of eyelid, 1 point. Erythema of hyperemia of conjunctiva, 1 point. And
Okay, how can we explain what I'm asking? That level of TRAB with hypothyroidism of that degree. How can we explain that level of? It is a competitive session, no? It is a competitive session. I can understand. How can we explain that level of TRAB with that degree of hypothyroidism? Usually TRAB is associated with thyrotoxicosis.
yes, TSH receptor antibodies are two types in nature, inhibitory and stimulatory. 80% are stimulatory type, that is that occur in hyperthyroidism, Graves' disease, and 20% of TRAB are inhibitory types.
So TRAB is not of only 2 types, there is another type. What is that?
I don't understand, sir, question.
Yeah, Dharmendra, nice presentation. Uh, don't you like to examine the skin of the patient for something?
Yes, sir.
What is that?
Skin, sir,
Particularly the legs.
mixed
Would you
edema.
like to examine the...
Mixed edema होता है shin shin bone.
Yeah.
Yes, sir.
Anything else on the skin? In this
Skin
background?
dry
TRAB high.
dry skin होता है ये dry skin होगा sir.
TRAB is so high, you are dealing with an autoimmune origin disorder. So anything else? Okay, so we can leave him.
Yeah.
Thank you. Thank you, Dharmendra. Big round of applause for Dharmendra Kumar for that interesting case of hypothyroidism with thyroid eye disease. I think we can have our third presenter for the day, Dr. Ramamurthy, which is the third and final PGT paper presentation from Deven Mahatma Government Medical College, Purulia. Can we have Dr. Ramamurthy?
Good morning to one and all. Myself, Dr. Ramamurthy from Tamil Nadu, doing DNB resident in Purulia Government Medical College. Today here I am presenting a case of rickets with hypokalemia due to the renal tubular acidosis. I would like to acknowledge Dr. Pangan Singhania sir for helping and guiding this case. Usually, renal tubular acidosis can present many ways like polyuria, renal calcification, bone mineral changes, and recurrent hypokalemia. And also, the rickets and short stages most common bone mineral changes due to the renal tubular acidosis. It can lead to failure to thrive, and also stunted growth in children, and osteopenia and osteomalacia in children is very common. If the patient having this kind of, we have to evaluate for the RTA cases. And rickets is nothing but is due to the defective mineralization of bone due to the mineralization of bone and overgrowth of the chondrocyte hypertrophy due to the widening of the breast. Here we have a case of 13-year girl who is born out of non-consanguineous marriage, presented with a predominant recurrent proximal muscle weakness and for 3 to 4 years. On examination, she had a protuberant abdomen, widened wrist and ankle joint. She was short and malnourished with a height of 92 centimeter and weight of 17 kilogram. On evaluation, her potassium level was 1.3 milliequivalent per liter, and ABG showed normal anemia of metabolic acidosis with hyperchloremia. This was her picture on left side, first showing the protuberant abdomen and the exaggerated lumbar lordosis. The second picture showing genuvalgum, and third picture showing widened wrist. This was her X-ray showing on left side. There is a classical features of rickets in the metaphyseal, epiphyseal, and diaphyseal changes. On further imaging, ultrasonography and NCCT showing multiple echogenic foci in the medullary renal parenchyma, suggestive of medullary nephrocalcinosis. And the X-ray showed, which I shown previously, the characteristic feature of the rickets. In the presence of the systemic acidosis, and her pH, urinary pH was 6, which shows failure of acidification of urine due to the renal tubular acidosis. Her ultrasound of abdomen and bilateral kidney and NCCT KV showing medullary nephrocalcinosis. The diagnosis, the diagnosis was distal renal tubular acidosis. We made the attempts to find out the etiology. The final diagnosis was distal renal tubular acidosis with possible etiology of idiopathic in origin. Genetic causes could not be ruled out. Initially, the patient was started on oral alkali therapy at the rate of 2 milliequivalent per kg per day, and oral potassium at the same rate, with an enriched diet and enriched protein. On follow-up, third month, patient was reduced proximal myopathy and reduced bone pain. And also repeat ABG, the acidosis will be resolved, and serum potassium came to be normal. Our height was over a period of 3 months, from 92 centimeter to 105 centimeter increase, and weight is from 17 kilogram to 26 kilogram. Over a period of 3 months, it is increased. We can see during admission, serum potassium and phosphorus will be lower on the side, and the spot urinary calcium creatinine ratio we did showed 0.3, which is suggestive of hypercalciuria. On third month, with adequate treatment, hypokalemia and hypophosphatemia is resolved, and also spot urinary calcium creatinine ratio which reduces suggestive in the reduced hypercalciuria. And also then third month follow-up, there is suggestive of metaphyseal provisional zone of calcification is seen. This on left side there is initial admission in X-ray. On right side on third month follow-up showed a provisional zone of calcification, and overall bone quality is increased. On initial admission there is genuvalgum, and genuvalgum also reduced on third month of follow-up. During admission, our weight and height 17 kilogram and 92 centimeter respectively. On fifth or 1 year period of follow-up, her weight and height is improved from 17 kilogram to 35 kilogram, 92 centimeter to 118 centimeter. We plotted in the graph in the IAP growth charts. We can see both height and weight is on below the third percentile. Over a period of 1 year, the weight is improved. It crossed the third percentile, but the height is on still on lower side. This was our last X-ray showing normal epiphyseal and metaphyseal bone alignment with proper no rickety changes. This was her last peak showing improved weight, and still the patient is on growing period. Summing up, renal tubular acidosis, renal recurrence due to renal tubular acidosis is amenable to treatment therapy like alkali therapy. If you're giving treatment properly, patient having a outcome will be as good as or even more better with rickets, nutritional rickets. So the key identification the key to diagnose and suspect the case of the renal tubular acidosis, especially in the Purulia, Bakuda and Medinipur. Renal tubular acidosis is very common, and also we didn't see the proper. We have to evaluate for all the cases of unexplained ALP elevated bone pain. It can otherwise it will lead to bone deformities, and finally patient will end up in the CKD. Thank you for the patience.
Do you have any records of urine pH?
Sir? Yes. Urine pH is 6.
You didn't mention that.
Yes, sir.
Okay. In one slide you have shown us that she had gained height of around 13 centimeter over just 3 months.
Yes.
I am surprised.
So we also surprised. We didn't never expected that much.
13 centimeter over 3 months only.
Actually, during admissions.
Can you show that slide only?
Yes. So this is our. So this was also we surprised patient growth. That's why we plotted.
No, not this slide. Earlier slide. 13 centimeter over 3 months only. No, this slide is showing 5 centimeter over 3 months, but another slide is there which is showing 13 centimeter over 3 months. Eta noy. Anyway.
Okay.
How will you assess genuvalgum? You said patient has genuvalgum, right? Yeah. How will you assess genuvalgum? And it's like how will any objective way of measuring it?
So genuvalgum, there is intermalleolar distance will be more than 8 to 9 centimeter. The patient has intermalleolar distance more than 8 to 9 centimeter for the definition of the genuvalgum. So if the patient.
Sure. I am not sure whether that lady is having family history of similar disorder.
No, sir, no family. Which lost all the histories. No family history, no.
Have you ruled out the secondary cause of Sjogren?
So we asked the histories as per the secondary root causes like SLEs and rheumatoid arthritis, but we could not find anything. So, and also patient's treatment response, no suggestive symptom at all. So we cannot, patient is not affordable also, we cannot able to do.
Yeah, Dr. Ramamurthy, that was a nice presentation. We discussed rickets, but you never mentioned about vitamin D actually. I'm little surprised.
So vitamin D, actually we did.
Yeah, obviously you did, but there was no discussion over that actually. Vitamin D, PTH, you could have put something on that.
Yes.
So what was the vitamin D status of this patient?
So initially on lower side on insufficiencies, the patient having initially 19 nanogram per ml, sir.
And what was the renal function of this patient?
It's 0.8. It normal. So patient have a renal function 0.8 milligram. Creatinine level is 0.8 milligram.
Yeah, because this was a 13-year-old girl actually.
Yes, sir.
It won't be advisable to go by that creatinine only actually. 0.8 for a 13-year-old girl. You should evaluate the renal function better actually.
Yes.
Because there was nephrocalcinosis. How was the function? That is something to be looked into.
Yes.
Yeah. Otherwise, nice presentation.
Thank you, Nihal. Sorry, Ramamurthy.
Thank you, Dr.
Kurushami.
Ramamurthy.
Thank you.
And thank you, judges. Judges might take some time to come to a consensus regarding. And before judges leave the stage, I would request them to hand over the participation certificates to all three. Dr. Nihal, please, to the side booth. Dr. Nihal, Dr. Dharmendra, and Dr. Ramamurthy in that sequence. Quickly moving on to the next session for the day, which will be on T3, one of the most discussed controversial topics in the treatment of hypothyroidism. To chair this session, I would like to request on stage Dr. Shumitra Rajok. Dr. Shumitra is medical officer at Huda Block Primary Health Center, BPHC. Along with him will be Dr. Utpal Majhi, who is medical officer at Urban Primary Healthcare Center and in Purulia. These are all very close and beloved juniors. Along with that, I would like to request on stage Dr. Alapon Pal. Dr. Alapon is consultant neurologist and also a very close associate, has been working in Purulia for almost 3 years now and helping us with neurological diagnosis and cases. And the speaker for this is none other than Dr. Kaushik Pandit. Dr. Kaushik Pandit sir currently is President Endocrine Society of India. He is a renowned senior endocrinologist in Kolkata and has always been very close to us whenever we've called him for. Dr. Kaushik Pandit sir.
Respected chairperson sirs, my respected seniors in the audience and dear friends. It's indeed a great opportunity to have myself being invited and allowed to share my views on a subject which is very close to all of us. At the very beginning, I must also put this disclaimer that this talk is not sponsored by manufacturer of T3 or anybody in the pharmaceutical industry. So it's a, so to say, an unbiased view of the subject. Hypothyroidism is nothing new. Since millennia, people knew about hypothyroidism, and this is an example of how people had known hypothyroidism over the ages. Even as early as 1473, in art by no less than a person than Leonardo da Vinci or Hans Holbein in the 16th century had clearly demonstrated the features of hypothyroidism with goiter and various other manifestations. But it was not very old, so to say, the treatment of hypothyroidism had arrived on the scene. So how do we treat hypothyroidism? If you go by the say historical perspective, it was not long ago, probably in the 1800s, we started with administration of DTE, that is desiccated thyroid extract, taken from animals and humans. And it was in the late 1800 that we had an approach of DTE, where it was a combination of course, of LT4 and LT3 that was available. But there were two issues associated with this one. Is that just because this is an unstandardized pharmacotherapy, there was a lot of changes in the biological aspect of the disease and its treatment. And that actually made possible Mother Nature and go beyond Mother Nature and go for synthetic forms of levothyroxine and liothyronine. And later on, people understood that merely giving levothyroxine probably suffices the problem, because we understood with time that in the body, levothyroxine is converted to T3, which is the most important thing for the cellular aspect of the treatment to go on. So looking from that viewpoint, levothyroxine is sort of a pro-drug, where we need to give levothyroxine not only for the sake of levothyroxine, but for the sake of liothyronine, that is T3. So we actually want to give T3, but we give T4, we know that it will be converted to T3. And that actually served all our purposes, probably even today. Now, why only levothyroxine? Do we also need to give the liothyronine? That's the crux of the issue that we need to look into. Levothyroxine, one simple answer is very cheap, low cost, but obviously what is important that we have got a long history of usage, and we have developed a lot of experience on that one, and that actually resolves almost all the symptoms of hypothyroidism, and the side effect profile is also acceptable. It is easy to administer. I mean, you can go daily or even with maybe a weekly dosage. That's also possible. Intestinal absorption is pretty good, barring a little exception that it needs to be taken in the empty stomach, obviously. Otherwise, there will be, with food, there will be a lot of interaction. And it has a long half-life. So the ease of administration is very good. Plus, coupled with that, you have got the great advantage of a low cost. So, if that is so, why do you need to think about T3? Okay, before coming to T3, let's talk about, how do we assess a person with hypothyroidism, especially someone who is on treatment? We assess or titrate the treatment on the basis of the level of TSH. TSH, which is not secreted by the thyroid, but it is on a homeostatic mechanism, and that gives a very good understanding of the internal scenario of the body and what is the status of T4, which is causing changes inside the body. So TSH probably suffices in most of the situation. But at the same time, we must also be aware of the fact that at times TSH might not represent the situation in its entirety, because in an individual patient, when we go for the normalization of the TSH, it is also important to appreciate that every human being is different. So before the person developed the disease, we do not know what was the TSH level of that person. It is only known after the person developed the disease. And we try to level up to the level of the normalization, which may not be normal in that particular person. So TSH might be sort of out of range for that person's pre-diagnosis TSH. It is also possible the person is having symptoms not only because of the thyroid problem per se, or the T3, T4 or TSH, maybe because of something else, like the autoimmunity might be causing running route inside the body. So the symptoms that is there maybe because of something else as well. So while we are trying to normalize situation at TSH, the normalization may not be, so to say, normalized in that proper sense, because we are not looking into the disease from disease angle. So autoimmunity per se can also have an impact in other aspects of life as well. We can also think of situations that the person may be having other comorbidities which are not perpetuated by hypothyroidism per se, and we are trying to normalize the symptom on the basis of TSH alone, which may not be happening because it is no way related to the hypothyroidism per se. It is also possible because of the simple fact that the symptoms of hypothyroidism are rather quite protean and very difficult to express or normalize in that sense. And that is why, by merely taking into account the normalization of TSH may not actually lead to normalization. Now let's talk a little bit about T3. So the center point of our discussion. T3 is produced and cleared by the body, produced obviously by the thyroid, but that thyroid produced amount of T3s is in a sort of minority. About 20% of the T3 that is produced daily is only from the thyroid. So where from do we get the other part, 80%? It is gotten from change of the T4 to T3 by what is known as peripheral deiodinase. So this deiodinase enzyme is present in various different cells of the body, and that perpetuates the function of changing the T4 to T3. And we must also remember that T3 is the central part of the treatment or central part of the metabolism, because it is the T3 which is the one which actually does the function inside the cells, or rather inside the nucleus. And we know that T3 is produced by the deiodinase type 1 enzymes which are present in the liver, kidney and the thyroid. There are other types of deiodinase enzymes known as deiodinase 2 which are present in the thyroid, pituitary, brain, skeletal muscle, brown adipose tissue and various other tissues. And if we look into the production of the T3 by this D1 and D2, we'll know that it is predominantly D1, though it was believed to be D2 only a few years earlier. Now we know it is the D1 which is present, and the deiodinase 1 which is present on the cell surface of the cells of the liver, kidney and the thyroid, and that transforms the T4 to T3 without needing the T3 going inside the cells or inside the nucleus at all. We do have other deiodinases which are present inside the cell, intracellular, like in thyroid, pituitary, brain and other cells, where it converts the T4 to T3 and then secretes once again the T3 into the circulation. So that's how it is produced. Now how it is cleared, because that's also important. If it is not cleared to the extent, then there will be accumulation of T3 inside the body, or if it is cleared too frequently, then there will be, so to say, hypothyroidism, that sense of the term. There are possible changes of T3 in not only deiodination, but glucuronidation and sulfation. That also is possible by this non-deiodinative pathways which are present in various cells of the body. So that's how T3 rhythmicity is maintained inside the body. In one hand it is produced and another hand it is cleared. Now if we talk about T3, we are also aware of this fact that there's some very strange situations of T3 in the sense that even in profound hypothyroidism, where the TSH has risen to a great extent, the T4 has gone down to a great extent, the T3 remains, so to say, normal. This is nature's own way of maintaining health. So the production of T3 is increased, or the destruction or clearance of the T3 is decreased. So even in situations where there is profound degree of hypothyroidism, the T3 is mostly remaining normal within the reference range. We are also aware of the fact that in situations of disease, some serious diseases, the T3 goes down very fast, keeping the TSH and T4 normal even. So the reverse is also possible, because in many situations, nature's way of protecting the body is to reduce the metabolism, and one of reducing the metabolism would be to reduce the amount of T3, and that is also possible with changes inside the body. We are knowing about this one that many people, especially children, have got high T3, especially if they are obese. And if I'm allowed just 2 minutes, I'll just tell you that an online survey showed by that American Thyroid Association that people are not happy when they are given T4 to have all their symptoms taken care of. And that has happened by many surveys that has been done in various other parts of the world. And if we take a meta-analytic view, a meta-analysis had shown that probably this is a biased sort of view, because a meta-analysis which takes the situation out of the bias and shows that there are 50% of people who are happy and 50% not really happy. And people have gone into showing whether the deiodinase changes causes this one. That has sort of been ruled out, that deiodinase changes in the genetic form really does not lead to such a situation. A systematic review and a meta-analysis on this situation shows that evaluating the effectiveness, we know that not only one, but the study after study, meta-analysis after meta-analysis had shown that probably this is an overhyped situation. Giving T3 along with T4 does not really lead to any benefit, though T3 in the long term has got no effect on the cancer or the mortality, a point that we had thought about. There are no long-term cardiovascular side effect of giving T3, but if we are to think about, approach the scientific aspect of it, giving T3 probably does not help in most of the situation. So not everyone would need, despite having the symptoms, and TSH may not be the only factor for titration that we need to think about. Really, the combination of T4 and T3 is needed to take care of the problem. Thank you very much.
Thank you. Thank you, Kaushik Pandit sir.
Hello. Thank you, sir, for this presentation. Sir, my question is, sir, in some patients, sometimes we will treat the patient as a hypothyroidism, but after treatment of 3 to 4 months with levothyroxine, some patients develop hyperthyroidism. In certain cases, TSH suddenly goes down and below the cutoff level. So, but sir, T3, T4 not corresponding to that level, what going high. So, should we stop the treatment and treat as hyperthyroidism, or should we wait and watch that patient in that case?
And that's the classic case of biological titration. So the fact that TSH has gone low suggests that the intrapituitary signal shows, or rather more importantly, maybe intrahypothalamic signal shows that the amount of the replacement probably is too high. So you just need to go down little bit to allow the TSH to normalize, suggesting thereby that there is euthyroidism in the viewpoint of the pituitary. We are not getting an output from the liver or kidney so far as this hypothyroidism is concerned. So the only factor, the signal that we can get is from a homeostatic pathway of the T4, T3 and TSH, and the normalization of the TSH, maybe in the upper zone or the lower zone, depending on the situation in which population we are serving, would serve the purpose. So TSH low would suggest that we have gone too fast, too high, so we just need to reduce and do a bit of titration. Probably that will serve the purpose.
Thank you, sir. Sir, in case of pregnancy, should we, the cutoff level of T3 and T4 will be the same in case of normal patients like that?
In pregnancy, the situation is a little tricky because of very many reasons, because of the placenta, because of the transfer of the thyroid hormones from mother to fetus, because of the resetting of the homeostatic mechanism that is present, because of various other substances from the placenta that is secreted. We know that in pregnancy, the demand for the thyroid hormone is increased, but in most situations, the mother is in a position to jack up the production of the thyroid hormone and be served with that. In some situation, some mothers may not be in a position to elevate the production of T4 to a great extent. We can go by some technologies to find out. And in such situation, they can be put on levothyroxine supplementation. And it is also possible to have hyperthyroidism, either temporary or sort of a long term in a situation of pregnancy. There also we will have to restructure the treatment strategy.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you very much. Yeah.
Thank you, sir. I request Dr. Kaushik Pandit, sir, to the felicitation area. Judges, please, chairpersons, please, to felicitate our respected speaker, current president of the Endocrine Society of India, Dr. Kaushik Pandit, sir. A big round of applause, ladies and gentlemen. Moving on to the second presentation for the day, which will be on management of Graves' disease in pregnancy. While hypothyroidism is very common in pregnancy, Graves is a little difficult to manage. And Dr. Ridish Narayan Chakravarti will help us do that. To chair the session, we have Dr. Anita Das. Dr. Anita Das is Associate Professor in Obstetrics and Gynecology, Devan Mahata Government Medical College. Dr. Kamal Kumar Narsaria. Dr. Narsaria is a Senior Consultant Obstetrician at Purulia. And is Dr. Satyajit Mahanti over here? Please, Anita Das Madam and Dr. Kamal Narsaria. Management of Graves' disease in pregnancy, Dr. Ridish Narayan Chakravarti. Ridish Da is a very popular speaker for his memes, cartoons and beautiful slides.
Should I start? Okay. So, thank you, Pankaj. You have been a beloved junior at college and also a fantastic colleague now. I would thank you initially for putting me on board on Podecon for the first time. I'm enjoying every bit of it. And when I was coming by Vande Bharat from Kolkata, the entire bogie was like a Singhania Express, because you have booked and it was like an academic picnic that I was having. So thanks for that feeling that you gave me. Here I have not put any cartoons or things here because it's a pure academic one. Usually I put in debates and all these things. So I'll go straight to the talk of the day, that is management of Graves' disease in pregnancy. So this will be the flow of the presentation, little bit of thyroid physiology, which Kaushik Da was speaking about, the other chairperson was asking. I will just go a little bit into it. Differential causes of hypothyroidism, Graves' disease, obviously, the lion's share of hypothyroidism in pregnancy, treatment monitoring, when surgery is needed, and lastly, managing pre-existing versus newly diagnosed Graves'. So, the introduction states that thyroid disease is the second most common endocrine disorder in pregnancy after diabetes. A lot of changes are going on in the system, in the thyroid gland, as also some other hormones from the placenta. So, we definitely have different cutoffs for TSH for understanding which patient is actually hypothyroid or actually euthyroid in pregnancy. So, two things happen with the thyroid. There are changes in two parameters starting with V. One is volume, one is vascularity. So, in iodine replete regions, the thyroid gland expands by about 10%. Whereas in iodine depleted regions, it might need to work even harder so that it expands to about 20 to 30% of the volume that it initially starts with. And pregnancy introduces hormonal and metabolic shifts that alter the thyroid hormone production. This graph actually sums up everything that happens in pregnancy. So, the entire scenario changes because of the grand entry of beta HCG into the picture, and beta HCG is given out by the syncytial trophoblast cells of the placenta. And the beauty of it is that it shares sequence homology with many hormones. One of them is obviously TSH. One thing to note here is that not only with TSH, it also has receptor homology with TSH receptor. So, HCG receptor has homology with the counterpart as well as the hormone. Now, what happens in the initial part, HCG just swells up. And in that part, if you see, the trough of the HCG actually corresponds with the nadir of the TSH. So basically what is happening, HCG is mimicking the action of TSH at the TSH receptor, giving out hormones, and that is causing a negative feedback. Important thing to understand from basic sciences is that the ratio of action at the receptor is to the tune of 1 by 10,000, but still it is acting. So in normal pregnancy, usually it doesn't tip the balance disfavoring the patient, but in some cases it may go to the extreme limits, and especially in multiple pregnancies and other diseases. So beta HCG is 1, and if you see how the thyroid hormones go up, the total T4 and total T3 also go up. This is obviously because of some other kirdar in the picture. Obviously, one is from corpus luteum, we have estradiol. Estradiol will increase the thyroid binding globulin. That will just suck up all the free hormones in the circulation. The total T4 and T3 will go up. So this is the graph I am going back. So gradually there is an escalation. The tan theta, or the slope of the curve, you can see it is going up and then stabilizes in the second and third trimester. Also, there are other things in the picture, as Kaushik sir was saying, iodinase, deiodinase. So D3 comes into the picture. Teleologically it can be explained. The last line in the third column is important, that it serves as a protective role by limiting fetal exposure to excessive maternal thyroid hormones. So there is a barrage or flush of thyroid hormones coming. So it is a gating mechanism. It tends to break down whatever is not necessary for the fetus. So D3 is also coming to the picture. So one is HCG, one is estradiol, then there is D3. So far we understood that normal pregnancy is a little bit of different situation from non-pregnant situation, because the TSH is actually mattering, and that is why the cutoff is changing. So if you just summarize, the cutoffs for the first, second and third trimesters respectively would be 0.1, 0.2 and 0.3. The issue important here is that if we do not recognize this part, many of the patients would be falsely categorized or overestimating as hyperthyroid. So this is the crux of the issue. Coming to the differential diagnosis, obviously Graves' disease, the topic of discussion today, but there are some other situations which can also cause hyperthyroidism, like some thyroiditis cases. MNG and toxic adenoma a little bit less. Then gestational transient thyrotoxicosis is important. I will just devote one slide to that in the next one. And there are some iatrogenic causes. Let us keep it in academic discussion only for today. So gestational transient thyrotoxicosis vis-a-vis Graves' hyperthyroid disease. Some points need to be kept in the back of the mind when we stamp a patient, whether Graves or it is GTT. So symptoms of thyrotoxicosis before pregnancy obviously would not be there, because by definition it is a gestational issue. And Graves' hyperthyroid disease, yes, often it may be present, but I do admit many patients actually come to know only after pregnancy. Symptoms of nausea and vomiting to the tune of 60% is present in GTT, and often it's not present in Graves' hyperthyroid unless the liver is also involved. Personal family history of thyroid disease, often absent. It might be just an association in GTT, but in Graves' hyperthyroid, because of autoimmune disease, sometimes it may be present. And presence of goiter, eye disease, etc. may be corroborative for Graves' hyperthyroid disease. And TRAB measurement, that is TSH receptor antibody, it's normal in GTT, whereas it is increased in Graves' disease. So we need to talk a little bit of the TRAB. TRAB is TSH receptor antibody, and it is produced by the immune cells. It works against the interests of the thyroid gland. Now what happens? Secretion of TRAB decreases in pregnancy, just as TPO antibody will decrease, just as thyroglobulin antibody will decrease. Teleologically, this is also explainable because in pregnancy, mother is hosting at least 50% of the genetic material from the father. So there has to be some immunosilence, otherwise there will be rejection of the fetus. So this 50% immunosilence is actually contributing to generalized reduction of autoimmune diseases. Having said that, there are statistics to say that 1/3 Graves patients improve, 1/3 do not improve, some may also deteriorate. But the general dictum is that autoimmune diseases do come down in pregnancy. Now, failure of this immunosuppression may indicate potential fetal problems, more so when there is orbitopathy, dermopathy, etc. And important thing is it freely crosses the placenta, so may lead to fetal thyrotoxicosis. So Shomikda was asking how many types of TRAB are there, we'll talk about it. Obviously one is stimulating, the most important, which can cause activation of the receptor. and in some cases they block, and third, Shomikda was asking, this is basically a neutral one. It doesn't do anything, but it's still present. So you can test, you can find, but actually there is no perturbation of the thyroid functions. Important thing is preconception implications. What are they? Elevated TRAb before pregnancy predicts higher risk of relapse of Graves' hyperthyroidism and failure to discontinue antithyroid drugs successfully. That means an ongoing process. It will be there. And maternal TRAb more than 3 times the upper limit of normal are associated with hyperthyroidism in the fetus and newborn. So this part is important. Now there are various cutoffs, whether you are doing second generation assays or third generation assays, that will decide whether the cutoff is 1.75, 2.39, etc. that we see in the lab reports. But more than 3 times the upper limit is something we need to scratch our head. Now question is diagnosis of Graves' disease in pregnancy. Here also there is some dilemma, because there is overlap of symptoms with normal pregnancy. Gorom lagche, feeling of heat, etc. They may be mimicked in pregnancy as well. So certain things have to be looked into. So clinical features plus the biochemical parameters plus the presence of TRAb, these 3 actually make a triad which can help us diagnose Graves' disease in pregnancy. If you try to understand the effects of Graves' disease, they can be under 2 headings. The effect on the fetus neonatal life and the pregnancy itself. So obviously when there is a stimulating antibody, there may be fetal hyperthyroidism, we can see persistent tachycardia, there may be fetal goiter as well, oligohydramnios, growth restriction may be there, and inhibitory there may be fetal hypothyroidism. Now what are the other issues? Per se, it can cause increase in recurrent pregnancy loss, preterm delivery, preeclampsia, and increased perinatal and maternal mortality risk. So these parts are important. What do we do now? So this is the ideal scenario, preconception counseling. You can draw a analogy with diabetes also. We say ki first control your diabetes, bring it HbA1c below 7, preferably 6.5 to 7, see all the target organ damages, retinopathy is there or not, they go for conception. Similar things can be mimicked here also. So we need to bring the disease under control, and the best case scenario is to get pregnant after that. But that is only the ideal scenario. The real scenario obviously, unfortunately, is that most of the pregnancies are unplanned. So we have to deal with something, half-cooked thing is already there. We have to cook up the rest of the things so that a good outcome is there. So 3 things are available, as we all know: antithyroid drugs, the radioiodine, surgery. So if radioiodine was used earlier, before the pregnancy, rapid control of hyperthyroidism, say in weeks or say months, will happen. Low risk of relapse in future pregnancy will be there. But here is one issue. Even if you have ablated the gland, permanent hypothyroidism obviously is one of the end products of using this. It happens. Still, TRAb may persist. So gland is gone, but the half-life of the antibody is still circulating. So that can still cause some problems in the fetus. That is important. Surgery, similar things. Immediate control of hypothyroidism. That means the source is gone for thyroid hormones. Again, here also the TRAb may persist, and that can cause fetal hyperthyroidism and problems. So now we come to the antithyroid drugs, obviously, that's the first point. That is the most commonly used thing we do. Low risk of permanent hypothyroidism, the gland is still functioning, we are just suppressing it below a critical threshold so that it doesn't produce a lot of hormones and flood the system. And there are some side effects which we will be talking about. So this is the algorithm which is the most important for management of Graves' disease in pregnancy. The left column, you can here again draw an analogy with diabetes pre-existing and diabetes happening in pregnancy. So the left column is actually pre-existing things is there, and the right part is actually when you are de novo diagnosing Graves' disease in pregnancy. So obviously when you are already having it, what are your options? Control the disease, continue the treatment, get into pregnancy. If it is early, change to propylthyrosol. If you have adequate time window, within 8 to 9 weeks, immediately the patient is having known that the menstruation has stopped, you test and immediately rush to the doctor for switching over. And the other option may be, one silver lining is there, that in some patients, because of the immunosilence, you may be able, okay, one more minute, you may be able to stop the treatment and follow it up. On the right hand side, what we do, when the patient is diagnosed in pregnancy, we start with PTU, then in second and third trimester, we shift to carbimazole or methimazole. So the important issues are here that there are a lot of side effects with methimazole that can happen, like aplasia cutis, choanal atresia, etc., which is called the embryopathy spectrum. But remember, PTU cannot be tom-tommed as a very safe thing. It can also cause hepatotoxicity. That part has to be remembered. So summarily, these are the 4 circumstances you can have: new diagnosis of GD, active GD at conception, previous GD euthyroid post-ATD, and previous GD hypothyroid after surgery or radioiodine. The most important thing is first start PTU, then shift second to third trimester methimazole, carbimazole. Second situation also, as soon as possible you will shift. There should not be any attempt to normalize the TSH because that is not our target. Lastly, the potency is about 20:1. So somebody requiring 50 mg PTU will suffice with 2.0 mg of methimazole. Lastly, fetus needs to be monitored. So fetal heart rate monitoring, any goiter on USG of the fetus, and fetal growth assessment has to be seen. Last part, the baby has been delivered, what do you do? This is something where you cannot draw an analogy with diabetes. Here there may be immune rebound. Because there was immunosilence, there may be immune rebound. So you cannot stop or reduce the drugs, rather you need to monitor and may even need to increase the drugs. If you find the entire presentation very difficult, always search for an endocrinologist. We are in plenty. Thank you.
Thank you for your nice presentation. It's too elaborate. You have discussed already.
Thank you.
So now I am asking you one question, that the patient suffering with this Graves' disease and the treated with the radioiodine ablation. So patient came to me when she get pregnant. She asked me. So whether it is 6 months or more, she has to wait.
So first of all, 2 things are here. One is the flush out period and second is the trap period. The flush out period is usually said to be 6 months, that you preferably get pregnant after 6 months, anytime. There is no upper limit when next, 1 year or 1.5 years. But reasonably, the trap should also be checked. Because once you are getting into pregnancy, the trap can cause a lot of problems. Because you have caused radioablation, the gland source is gone, but whatever has been secreted is circulating. That part should be checked and then the patient should go into pregnancy. So rather than fixing up the time, maybe seeing the titer of trap becomes more important.
Okay. Now my another question is that we are treating the pregnancy in first trimester with this PTU, that is thionamide. So we are changing in the second and third trimester with this carbimazole or carbimazole. So it can be possible to continue the pregnancy
Right.
with this PTU
I skipped this
only?
slide. There was a slide. Because of shortage of time, this was the slide. So, I cannot show it. So, the issue is, can you show this slide once? This one. So, switching is important. You will see in both sides the shared decision making important point is there. Because this 5th point from the left side, switching is likely to worsen thyroid control. It may happen. Suppose you have controlled on PTU 50 mg thrice daily. Now you are calculating in 1:20 ratio, as I have said. So you have given 2.5, 2.5 and 2.5. But the time of switching, it may go haywire. Just like somebody on metformin, you are shifting to some insulin. For some time, 2 to 4 weeks gray zone, transition zone, there will be a lot of problems in the sugar. Similarly, same thing may happen here. So this part has to be discussed. So should I switch or not? And these points were switching from PTU to this carbimazole, methimazole in second trimester. What are the indications? Some people say, let us continue. Patient prefers to remain. So shared decision making also comes here. Because what is the problem? Because we cannot give a definite answer. PTU can also cause hepatotoxicity.
Yes.
So I am either harming the mother or I am harming the child. So I have to go on a very tricky balance actually. So this part is important. But largely PTU in the first trimester as early as possible or before conception, because patient was originally Graves, we shift and then shift back in the second to third trimester in the way. But with the caveat that every 2 weeks it needs to be monitored.
Okay, now
Thank you, Chairpersons. I think we are running late and we can have the discussion.
Thank you, thank you.
Thank you, Ridishda, for that beautiful and illustrative discussion. Request Ridishda to please come to the photo booth and Chairpersons will felicitate our speaker. As a reminder to all delegates, Chairpersons, faculty, please do not forget to sign the WBMC the form over there for the WBMC 5 credit hours which you will be getting because of this conference, because of attending this conference. the signing of the register or the forms will start after 3 p.m. because you are being awarded 5 WPMC credit hours for the whole duration of conference. So anyone who signs the form or the attendance sheet of WPMC credit hours 3 p.m. or after will be given the certificate on the spot. Thank you so much. We now move on quickly to our next session, which is a session on thyroid swelling. To chair this session, we have Dr. Rakhi P. Puria, who is Senior Consultant Radiologist of Purulia. Madam is very close to us. Dr. Chinmay Lat, who also happens to be the Scientific Secretary of today's conference and renowned pediatrician in Purulia. Dr. Basant Rewani, a consultant surgeon and laparoscopic surgeon working with us on a regular basis, and Dr. Debashish Biswas, who is a senior ENT surgeon from Purulia. Please. And to deliberate on thyroid swelling, we have none other than Professor Shaumik Datta. Shaumik Datta is professor and head at Department of Medicine, Bardhaman Medical College, MDDM endocrinology, and he'll be talking about approaching a 11-year-old boy with a thyroid swelling. Shaumik Datta.
Thank you, Pankaj, and Dr. Puria, Dr. Das, Dr. Vishwas, and Dr. Rewani. My dear friends on the floor and dear colleagues. So, I think baby had been born, and my dear brother, Dr. Ridhish Narayan, took adequate care. And the baby had grown, now he is 11-year-old, and he is having one thyroid swelling. Parents are much worried. They have rushed to my clinic. So, after getting them assured, I have to confirm whether this next swelling is thyroid itself or something else. Our ENT specialists present here, they are dealing every day with so many neck swelling, and the differential diagnosis is very wide. It may be dermoid cyst, epidermoid cyst, lymph nodes commonly, and we should never forget about the possibility of thyroglossal cyst, which is present in the midline above the thyroid vein, and both thyroid swelling as well as the TG cyst, they are moving with deglutition. Then how can we differentiate? If the TG cyst, if it is TG cyst, it will ascend as soon as tongue is protruded, and you have to take help from our ENT surgeons. So now I am convinced that it is thyroid swelling. Now clinically, how can we judge that it is enlarged? The classical teaching is that over the years, that if the lobe is larger than the distal phalanx of the thumb, yes, I can assume clinically that the lobe is large. It is not a normal physiological lobe. It is swelling there. Definitely, the next question comes, how long it is there? And most of the times, we will not get a definite answer. It is vague, but if there is specific answer that it is of long duration like that, we have to anticipate that he or she may have florid presentation of thyroid disorder. And we should never forget to ask about the drugs he or she is taking. Maybe already he had been put on levothyroxine supplement. Maybe he is on antithyroid drugs, so that part should be taken care of. Other drugs which can interact with thyroid axis, like lithium, like interferon alpha, and we should never forget there are so many cough suppressants in the market available having lot of iodine in their composition. So that is also a very important thing to know. If it is large enough, can I have one color mic? So if it is large enough, color mic. So if it is large enough, definitely we have to ask whether there is any feature suggestive of compression. Definitely we have to ask about dysphagia, any shortness of breath, and he may have change in voice. So in case of huge goiter, we should never forget to take care of the compression it can produce. Sorry.
Yes, mental status must be observed. As you know, the brain development, it is there within first 3 years of life. And the development of nervous system depends entirely, if not totally, depends entirely on the integrity of the thyroid axis. So if one baby is having hypothyroidism and having onset in the early childhood, and if it is not detected and if it is not adequately treated, there is a lot of chance of having mental retardation in the long run. So this mental retardation or mental status can tell us about the onset of the hypothyroidism if it is there. We should never forget that congenital hypothyroidism, the most common cause of congenital hypothyroidism is thyroid dysgenesis, maybe ectopic thyroid or agenesis of thyroid. In those cases, you may not find a palpable thyroid swelling, but we should never forget that there are other causes of congenital hypothyroidism. Stature, definitely the linear growth, welcome sir. So stature, definitely linear growth of the kids depend on the integrity of same thyroid axis. So if the chronological age of the boy is same with height age, we have to take care of the growth chart of the boy if it is available. If chronological age and height age is more or less equal, then hypothyroidism may not be of long duration, but if height age is much lesser than chronological age, then definitely he is having long standing hypothyroidism. On examination of the skin, you may find hypopigmented spot which may be correlated with autoimmune origin hypothyroidism. So skin examination is very important to note here. If the boy is presenting with testicular enlargement, yes, I am afraid he is having long-standing severe hypothyroidism. I have got one kid years back having cleft palate in the context of congenital hypothyroidism, and his fathers and grandfathers, they are also having same history. We know that transcription factor 2 is playing an important role in the background of thyroid gland development as well as closure of palate, and if you are getting any such combination, definitely you have to think of mutation in that TTF2 transcription factor. Definitely you may not find a palpable thyroid gland in that condition. So coming to the examination of thyroid gland proper, we have to check whether the gland, it is diffuse swelling or it is a nodular enlargement. If it is nodular, it may be single nodule, it may be multinodular. I have to try to find out the lower border of the gland, whether the gland is tender or not. That is one important point to check. Coming to thyroid function test, in a good proportion of cases, you may find thyroid function test within normal limit, and that can tell us about euthyroid goiter, which is not uncommon around puberty and that is more common in girls than in boys. So TFT may come like this, FT4 and T3 on the lower side, TSH is elevated, that is telling us about the possibility of primary hypothyroidism. We have to initiate LT4 replacement and up-titrate accordingly. In few cases, you may find TSH elevated, FT4 and T3 within normal range, indicative of subclinical hypothyroidism, and you have to address those cases very much individually. But the parameters may come in this form, FT4, TSH, T3, both, all of them suppressed, suggestive of central hypothyroidism. If the baby is having features suggestive of central hypothyroidism, definitely we have to try to exclude, or we have to try to explore the other pituitary hormonal axis. If I am convinced that he is having primary hypothyroidism, try to get TPOB status. In a community having iodine sufficient status, autoimmune origin primary hypothyroidism is more common, but we should never forget that even the autoimmune hypothyroidism, 5 to 10% of cases of autoimmune hypothyroidism may present with TPO negative status, and the common people without having any thyroid disorder may present with TPO AB positive status. But if the baby is having primary hypothyroidism in the background of TPO antibody negative, definitely we have to think of other possibility like maybe due to iron deficiency, maybe due to some drugs which can interact with the thyroid axis, and rarely it may be due to dyshormonogenesis. Certainly, dyshormonogenesis is a condition which is congenital, but they may present in the late childhood, they may present with thyroid swelling, their presentation may be mild, and they will be TPO antibody negative. If this sort of presentation tells us about the possibility of thyrotoxicosis, it might be SABEC, it might be due to hyperthyroidism in the background of Graves or toxic adenoma or multinodular goiter. If the gland is tender and if it is of recent onset, if the boy is having features of sore throat or fever few weeks back, it may be thyroiditis. If you are confused whether it is thyroiditis or Graves' disease, you can go ahead for TRAV, though it is not easy to do TRAV even in our city. So, in those confusing conditions, you may wait for a few weeks more. Ultrasound definitely will help us if you are getting one nodule to get the status of the nodule. Madam will tell us about the thyroid score of the nodule, and based on the thyroid score, we can go ahead for cytological study. If the cytological study and thyroid score both are in favor of malignancy, we have to take them accordingly, and we have to again take care of the ENT surgeon will take care of that person. In few rare cases, you have to go for bone age with a X-ray of left wrist. You can judge bone age. We know that in case of hypothyroidism, bone age is delayed. If bone age is much lesser than chronological age, then you can assume that this baby is having long-standing hypothyroidism. Yes, in 1 to 5% cases of type 1 diabetes, you may have autoimmune origin of hypothyroidism, so that part should never be forgotten, because type 1 diabetes is much dangerous to tackle. To conclude, most of the thyroid disorders, ladies and gentlemen, are correctable disease, but individualization of each case of this age group may prevent further morbidity as well as over-treatment. Thank you, sir.
Good morning. Actually, I want to know if the patient presented to us with diffuse swelling or on this solitary nodule at a age of 11 years, what is the indication of the surgical indication? When should we perform surgery for the patient?
No, sir, if he or she is having diffuse swelling, he or she is not having any features of compression, where we are going to refer him to a surgeon. So, if the swelling is large enough, yes, definitely, he is not having any compressive features, he is having euthyroid, and the gland is not that much firm. Even in case of Hashimoto, on long run, the gland may become atrophic. If the gland is not that much, gland is responding, we can hope that the gland will respond to LT4 replacement. In case of toxic adenoma, definitely we can think of, if it is needed, if it is not responding at that age group adequately to antithyroid drug, we can think of the surgical help. If that nodule is suggestive of
That's 3 or 4.
In that condition, definitely we have to take care of surgically.
Okay, thank you.
Thank you, Shaumikta, and Madam has a question, I think.
I have to ask, now this radio frequency ablation is there for the treatment of thyroid. So can we do this colloid cyst treatment by radio frequencies in such a young boy?
For colloid cyst radio frequency ablation, I am not sure, we can go ahead for that. But for colloid cyst, there are other options available. Radio frequency ablation is available in your city, madam?
No, we don't have, but
Thank you.
Okay.
Thank you, Shaumik. Then thank you, chairpersons. Big round of applause for Professor Shaumik Datto. I request Professor Shaumik Datto to the felicitation booth, and chairpersons, please to do the honors. Going on to the next presentation for today, which will be about bone mineral disease. To chair the session, I'd like to request on stage Dr. Bikash Singhania, consultant pathologist, Care Diagnostics Purulia. Professor Falguni Chakravarti, Head of the Department Biochemistry, Deven Mahatma Government Medical College, Purulia, and Dr. Deeptesh Soren. Dr. Deeptesh Soren. Is Dr. Deeptesh around? Along with that, I'd also like to request Dr. Animesh Pal, Senior Consultant Obstetrics and Gynecology, to chair the session along with our chairpersons, to deliberate on osteoporosis in diabetes, which is an under-recognized problem. Request on stage Professor Belinda George, Professor at St. John's Medical College, Bangalore, has flown all the way from Bangalore to be with us. We are really grateful to you, madam. Thank you.
Thank you, sir. A very good morning to all of you. And at the outset, let me thank Dr. Pankaj for inviting me. It was really a pleasure to be here, particularly last night with everyone. So the topic for today is osteoporosis and diabetes. Are we screening enough? So if you look at fracture risk in patients with diabetes, whether it's type 1 or type 2, you will see that the fracture risk is increased just because they have diabetes over and above the general population. And these two diseases are linked together by fairly complex mechanisms. And we do have the traditional screening tools to detect osteoporosis. They are not enough in diabetes, like I will show you. The other issue is that when you deal with diabetes, we have so many things to take care of. We have retinopathy, nephropathy, neuropathy. So the bone part is often overlooked in management of type 2 diabetes. And whatever drugs you use for diabetes also may have an additional impact in these patients. So it's important to look at all of them together. Now, if you look at the fracture burden, this picture shows you very nicely that if you look just simple osteoporosis without added diabetes, there is definitely a fracture burden. But there is an additional fracture burden just by virtue of having diabetes. And this is the reason why patients with diabetes, it's important for us to keep this in mind and ensure that we are screening them adequately. Like I mentioned earlier, both type 1 and type 2 are associated with increased risk of fractures. In type 1, usually we will see that the bone mineral density is less compared to controls, that's what the data has shown. The reasons for why type 1 diabetes has more fracture, these are all postulated mechanisms. One, of course, is mostly it occurs in young children, and during the adolescent period, that is when your peak bone mass accrual occurs normally. So if that is not done properly or does not occur properly, then eventually it may lead to osteoporosis and fractures. Similarly, glycosuria can also lead to associated hypercalciuria, which again eventually leads to less mineralization in the bone and increased risk of fractures. Then just because of hyperglycemia, you may have advanced glycation end products, which alter the collagen and affects the quality of the bone matrix. And lastly, when they develop nephropathy, they can also have worsening of bone disease. When we talk about type 2 DM, here the interesting thing is that most of the time the BMD is not less, it's actually normal or maybe even slightly high. In spite of that, there is increased risk of fractures. And what are the reasons why patients may develop fractures in type 2 diabetes? One again is the same hyperglycemia that we mentioned, similar to type 1. The other factor is that insulin has anabolic actions on the bone, which means insulin increases the action of the osteoblast, which is a bone-forming cell, and it inhibits the action of osteoclast, which is a bone resorbing cell. And when insulin resistance is there, the sensitivity of bone cells to insulin is lost, and the exact opposite happens. So osteoclast activity is increased, and the bone formation is reduced. So this also will lead to poor bone quality. Similarly, when you have hyperglycemia, there may be low IGF-1 because the hepatocytes produce less IGF-1, IGF-1, and this again causes a deleterious effect on the bone. The other two more important mechanisms in type 2 diabetes is the chronic low-grade inflammation and the oxidative stress that we see. So these release a lot of cytokines, which eventually has deleterious effects on the bone. And lastly, you all know that diabetes is a vascular disease, so microangiopathy of the bone also leads to these complications. Three other mechanisms. One is sarcopenia, which have recently been highlighted. One is sarcopenia, which is associated with obesity and diabetes. The other one is vitamin D deficiency, which is extremely common in obesity, and also gut microbiome dysbiosis. All of them will eventually lead to the sort of wrong balance with regards to bone remodeling. So these are some pictures which show you what happens. You can see the blood vessels. When there's a lot of blood hyperglycemia, the blood vessels, they become leaky. There's also now a lot of attraction of cytokines at the local area. So then you can see that the bone formation and bone resorption gets imbalanced. And when this imbalance occurs, the patient leads to poor bone quality or osteoporosis. This is a very similar picture which shows you oxidative stress and inflammatory markers which increase in presence of hyperglycemia and hence will affect the quality of the bone. Now when we look at bone strength, it is how we assess bones, how we assess the quality of bone today in clinical practice. We look at the bone mineral density. So we look at the degree of mineralization. That is the bone mass that we talk about, but that is not the only factor, which is why in patients with diabetes, even in presence of elevated BMD, you will see fractures are happening. So there are other aspects of bone strength, which includes the micro and macro architecture of the bone, and also other properties of the bone material apart from the mineral, which includes collagen. Like in type 2 diabetes, you will get poor quality of collagen, which leads to poor bone quality and hence elevated risk of fractures. So if you look at the traditional osteoporosis screening, we usually use DEXA to assess the bone mineral density, and we also have something called the FRAX score to look at the fracture risk. So in patients with diabetes, the BMD is usually not reliable, the type 2 diabetes. Most often, even in the presence of good BMD, patients will have a higher risk of fracture. And what are the reasons? The reasons for this is obesity, insulin resistance. They can activate growth pathways, so that may be one reason why the trabecular bone is actually not reduced. The low bone turnover state, which occurs in diabetes, which basically means osteoclast activity is enhanced and bone forming activity is reduced. So this makes diabetes a low bone turnover state. And here there is increased secondary mineralization because of this. So BMD may look higher than what is expected, but the bone becomes brittle, so there is higher fracture risk. And lastly, in the presence of low BMD in patients with diabetes, the risk of fracture is higher compared to a similar BMD in a non-diabetic individual. So BMD is not the right tool in patients with diabetes. However, if you find that BMD is low, then please we have to intervene because the risk of fracture is higher than in the normal population. Coming to FRAX score, I presume everyone is familiar with the FRAX score. So this actually shows you the absolute fracture risk for any given score. So for non-diabetic osteoporosis, we have certain cutoffs, but what we want to highlight here is that for the same FRAX score in diabetes versus non-diabetes, the risk of fracture is higher. So you have to correct it because diabetes becomes like a reason for secondary osteoporosis. So at the end of the FRAX score, we have two risk scores. We obtain two risk scores. One is to predict the major osteoporotic fracture, and the other one is to predict the hip fracture. So the major osteoporotic fracture, you need to correct the FRAX either by adding 10 years to the age or by including another factor like rheumatoid arthritis, which is known to cause secondary osteoporosis. And when you want to correct for hip fracture, you will increase age by 10 years or you will lower the T-score by 0.5. So there is the newer index is called FRAX Plus. The FRAX is available free for everyone to use on the internet, but the FRAX Plus is not freely available. So you can still use the original FRAX with these corrections. So what should we do in clinical practice? Definitely we should continue to use BMD assessment. However, in the BMD, we should add two parameters. One is the vertebral fracture assessment and the other one is a trabecular bone score. And of course, we should use the corrected version of FRAX. So this is a paper from Vellore which has shown you what is the trabecular bone score. So the TBS is just another software update to the entire BMD, where it will not just look at the mineralization, but it will look at, it actually looks at the pixel gray area and tells you the trabecular bone that is present. So you can see that with loss of trabecular bone, you will see that the TBS score is falling. So a TBS score of more than 1.3 is what we would suggest that is a good score to help in detecting patients who needs therapy for osteoporosis. The vertebral fracture assessment is another tool which we can use. Again, low-dose X-ray radiation exposure along with DEXA, but they have to take a lateral view of the bones. And here it is easier for you to identify if there are any occult thoracic or lumbar vertebral fractures, which again says if there's any fracture, definitely the patient requires intervention irrespective of the T-score. So one quick algorithm for approach in patients with diabetes. If the patient has diabetes and already has a fracture, either hip or a vertebral fracture, then it's very easy. You have to treat the patient, consider that the patient has osteoporosis. If the patient does not have a fracture, then you have to look at certain risk factors, certain clinical risk factors, particularly in patients who are younger than 50, because age above 50 itself is a clinical risk factor. And what are the clinical risk factors that we need to know? Of course, the usual traditional ones are the FRAX, low BMD, and recurrent falls. Apart from that, diabetes-specific risk factors is having diabetes for more than 5 years, diabetes medications that are known to have deleterious effects on the bone, an A1C of 7% or higher, and of course having microvascular complications of diabetes. All of these increase the risk for fractures. So if the patient does not have any of these risk factors, then you don't have to intervene. You can follow them up and reassess every year to assess whether the patient's risk factors are increasing. If the patient has clinical risk factors, or if the patient has had a fracture which is not the usual osteoporotic fracture, which is hip or vertebral fracture, then we have to evaluate them. So ideally we should do DEXA, BMD, along with VFA and TBS if possible, if it's available. And then we have to take a decision as to whether the patient requires treatment or not. So commonly in osteoporosis, our cutoff to treat is a T-score of less than -2.5. Whereas here in diabetes, that gets elevated to less than -2. So if any T-score less than -2, we generally treat in patients with diabetes. And of course, I spoke about FRAX earlier, so you can calculate the FRAX score. For FRAX score, the recommendation is based on country specific. So we have data, the guidelines put out by ISBMR, which says that the FRAX score cutoff for us, for hip fracture, more than 3.5%, and a major osteoporotic fracture, it should be more than 10.5%, which is actually less than what we use in Western population. So our threshold for treatment is much higher in patients with elevated FRAX score. If it is negative, then you can repeat this every 2 to 3 years and reassess the patient. So what about medications used for diabetes and what is the impact that they have? So we already know TCDs have a deleterious effect on bone. So ideally we should not use them or use them with caution or monitor patients who are receiving them. But most of the other drugs, metformin, sulfonylureas, and incretins have either neutral effect or the incretin axis has shown to have some beneficial effect on the bone as well. And there is some data to suggest that GLP-1 receptor therapy actually improves bone mineral density. Yes. So SGLT2 inhibitors, we are not, there's not much red flags. The one study on canagliflozin suggested that it might worsen bone mineral density. Insulin, of course, even though it's a safe drug, probably because patients who require insulin are the ones who have lots of complications. So hence, epidemiological studies have shown that insulin actually increases the risk of fracture. But the good thing is that if you look at the data generated in the last 10 years, you can see that there's significant amount of activity is occurring in this field. So coming to my question, whether are we screening enough? I think the answer is something that each of you should think about. It is probably right that we aren't doing enough. But there's a lot of talk. So hopefully things will improve in the future. So I'll leave you with this picture where if you are seeing patients like this in your OPD or in the community with a significant tooth loss, the significant stooping, then these are all patients with osteoporosis that we have missed and not treated. Thank you.
Any questions?
Any question from the audience?
Anyone from the audience would like to ask any questions? Sir.
Should they, Madam?
No,
One.
just a comment.
Yes, sir.
Since we do not have DEXA in this part of Bengal, so the suggestion is whenever you have the opportunity, take a lateral spine X-ray. Ask the radiologist to get a D4 to L4 spine, and that will generate a lot of information on bone health. Thank you.
Another question, Madam. As DEXA and FRAX you have already discussed, so is there any biochemical parameter that may be helpful in predicting the osteoporosis, chances of osteoporosis?
At the moment, we don't have any biomarker for osteoporosis which has been established and is being used regularly. However, there's a lot of data on newer biomarkers which could be used probably in the future, because like Sir was saying, it's not easy to put out DEXA machines across the country everywhere for screening, but the problem and the burden is really, really huge. So till such time, maybe simple measures like taking an X-ray to look for occult fractures, or even simple clinical examinations like looking for height loss, or if the patient is not able to put the occiput against the wall when they are standing, which also suggests occult thoracic fracture. So all these parameters, including the picture I showed with somebody having tooth loss, this also risks a high chance of osteoporosis there. So these are patients that we can pick up and treat in the absence of DEXA.
And even we have to worry about the medicine itself. So what should be the base drug regarding this osteoporosis?
The treatment for osteoporosis?
Treatment, no, madam. Even the diabetic drugs we have to worry about.
So I think in women who are older, we generally don't like to use TCDs like pioglitazone, because we know that clearly there is an association with osteoporotic fractures, and history of fractures is high in them. Every other drug, so far we do not have any major red flag to suggest that we have to stop using it. But going forward, we talk a lot about precision medicine. So there may be patients who have higher risk for fracture. Maybe GLP-1 will be an ideal option for them, because it's known to have, there is some biological link which shows that it may be protective for the bone.
Thank you.
Thank you, Professor Belinda George, for that wonderful presentation. Please, madam, to the felicitation booth, chairpersons to the felicitation booth also. We are really grateful, madam, for coming all the way. For the next presentation, which we've all been looking forward to chair this session, I'd like to request on stage Dr. Kapiljeet Chakravarti. Kapilda is senior nephrologist in this part of Bengal, primarily based in Bankura, and Professor Gourango Satra. Professor Satra is a professor and head Department of Medicine, Deven Mahato Government Medical College and Hospital, Purulia. Along with that, I would also like to request on a stage as chairperson, Dr. Maharaj, Swami Nirabananda Maharaj, who is a senior physician from Purulia, popularly known as Dr. Maharaj. And for deliberating on this, we will request on stage Professor Shotinath Mukhopadhyay sir. Sir is retired professor and head Department of Endocrinology, SSKM Hospital, Kolkata, and he'll be talking about anti-inflammatory approaches to type 2 diabetes. This might seem very heavy, but I believe sir will give us the way through anti-inflammatory. Thank you, sir.
Thank you, Pankaj, for the kind invite and also for the nice words. And good morning, everyone. I have to make this talk a little lighter than it is and not heavier, because the time is also lighter. It's 20 minutes and this is actually a 30-minute presentation. So if you listen carefully to Dr. Belinda's presentation, she actually introduced chronic low-grade inflammation, inflammatory markers in osteoporosis in the setting of diabetes. So all those information are relevant when you talk about an anti-inflammatory approach to prevent or treat type 2 diabetes, recognizing the fact that obesity is the seat of chronic low-grade inflammation that fuels insulin resistance. So this is from Alison Goldfein's lab at Joslin Diabetes Center, which I had visited back in 2012. So Alison actually does a lot of work on this, and I'll be sharing quite a number of pictures and figures from her JCI paper published back in 2017. And here you can see at the hierarchy of features of obesity that are implicated as potential pathologic mechanisms for type 2 diabetes. There is inflammation at the bottom, but we have moved away from that, and if you ask me in 2025, well, inflammation arguably tops the list of risk factors that fuels type 2 diabetes. So on your left, you have healthy white adipose tissue, which in response to a surfeit of nutrients, mounts an hyperplastic response. And when you have that metabolically efficient hyperplastic young adipocytes, they're also adequately vascularized, so you do not have adipose tissue hypoxia, do not have pro-inflammatory immune cell infiltration, and you do not develop prediabetes or type 2 diabetes. On the other hand, on the right-hand side, if you see unhealthy adipose tissue, it expands by hypertrophy instead of hyperplasia. And those big hypertrophic adipocytes, they are lipid-laden, they push their nucleus to the periphery, and they are inadequately vascularized. So necessarily the adipose tissue develops hypoxia. Hypoxia invites oxidative stress and inflammation, and you have adipose tissue being infiltrated with pro-inflammatory immune cells. There are many M1 macrophage, plasma cytodendritic cells, NK cells, and adipose tissue macrophages. They all produce adipose tissue fibrosis and hypoxia, which leads to adipose tissue insulin resistance. Then by various chemokines and cytokines that are liberated from that inflamed adipose tissue, we collectively call them organokines these days, because it's the inter-organ crosstalk between adipose tissue, skeletal muscle, and liver that eventually manifests as type 2 diabetes. So coumarin is a very important pro-inflammatory adipokine, and elevated levels are seen with obesity, insulin resistance, and inflammation. So in our recent diabetes paper, we actually could unearth the mechanism by which coumarin causes inflammation and insulin resistance. In the interest of time, I will not walk you through the details of it, but if you just go to the bottom of the slide, you can see how type 1 interferon causes pro-inflammatory polarization of M2 macrophages into M1, and that drives systemic insulin resistance. So that's the diabetes paper, which has been very highly cited, both in the professional media and also in the lay media, how obesity causes insulin resistance. And there is a strong link between metabolic syndrome and coumarin. As you can see, there are a number of papers in the recent years. So we wanted to see what happens to inflammation if you have a high coumarin level in a relatively new onset type 2 diabetes. And as you all know, finding new onset type 2 diabetes is a challenge. So we fell back upon young girls with polycystic ovary syndrome who demonstrated a very high risk of prediabetes and type 2 diabetes, particularly when they're given a glucose challenge. So here's the data, busy slide, but I would just like you to focus your attention to the bottom, where you can see, as we do not have a pointer here, but bottom 3 lines, if you concentrate, you can see coumarin level. With rising coumarin level, there is a rising level of IL-1 beta and then TNF alpha, underpinning the association between chimerin and inflammation. So that's the paper in the Endocrine Society Journal, where we discuss the mechanism by which chimerin causes a pro-inflammatory state. Now, this is how liver causes inflammation and insulin resistance, the role of liver. So from adipose tissue, we now change gear and move over to the liver. At the center, you see a zoomed in view of an inflamed hepatocyte, and both glucose and saturated fatty acids, they generate phetuin A, which is a powerful pro-inflammatory hepatokine, and then phetuin A causes insulin resistance by way of being a very powerful inhibitor, direct inhibitor of insulin receptor tyrosine kinase, and it also binds to toll-like receptor 4 present on the surface of adipocytes and immune cells. When that happens through various downstream mechanisms, you get inflammation. We do not really have the time to discuss this, but you can just see on your left, you see DBDB mice which are obese, and on the right you see high-fat diet mice. They are all obese, and they produce a copious amount of phetuin A, and when that happens, at the bottom you can see how phetuin A causes NF-kappa B generation and phosphorylation. Dr. Belinda was actually alluding to this, NF-kappa B and inflammation. So this is NF-kappa B which causes inflammation, and that was the Biochem journal paper. Then phetuin A, it impairs adipocyte function. Again, you focus your attention to the bottom, and you can see how inflamed adipocytes produce TNF alpha, IL-6, and IL-1 beta. Then inflamed adipocyte also suffers from its impaired ability to pick up glucose. You know, glucose is picked up by the adipocyte through glucose transporter 4, which is insulin mediated. And here again at the right bottom, you can see adipocyte in resting condition. All the glucose transporters are in the center of the cell. They are lying idle. The moment you apply insulin, see how nicely they translocate peripherally on the cell surface. They are now in a position to pick up glucose. That's what happens in normal physiology. The moment you add phetuin A, you see all those GLUT4s, they go back into the cell cytoplasm, and they can no longer pick up glucose, and you develop type 2 diabetes. So here is the evidence, inflammation causing type 2 diabetes. To cut a long story short, free fatty acids from the circulation, they stimulate the generation of phetuin A, and the two then form a dimer which goes on to bind to TLR4 on the surface of adipocytes and immune cells. Then the adipocytes and immune cells produce a lot of pro-inflammatory cytokines that cause insulin resistance, and that's the mechanism which we actually published way back in 2012 in Nature Medicine. So that's the editorial by Jerry Elofsky's group from California, phetuin A being recognized as the missing link in lipid-induced inflammation. Then came our paper in Diabetologia, where we actually could identify phetuin A triggering inflammation by acting as an adapter protein between free fatty acids and TLR4. Here is evidence that phetuin A causes inflammation in the adipocytes directly. Also, it is produced in situ and causes inflammation. On the right, you can see high levels of TNF alpha. So that's the paper in JBC. So now, hypertrophied adipocytes producing inflammatory markers and how they cause insulin resistance. So complex mechanisms. On the one hand, you have this SAT1 cleavage. On the other hand, you have a low AMPK. AMPK you are all familiar with. Metformin works by increasing AMPK, right? And when the AMPK is low, prior to that you have low adiponectin. Adiponectin again you are all familiar with. And you have drugs like pioglitazone increasing adiponectin. You have metformin increasing AMPK and ameliorating inflammation. So when you have a low AMPK and a low SAT1, you have mitochondrial dysfunction that causes inflammation and insulin resistance, and those are the papers, adiponectin and SAT1 and AMPK paper. Then Dr. Deep Datta did this study. This was his PhD work, DM work. TNF alpha, this particular mutation in an Eastern Indian population, giving rise to significant inflammation. You can see elevated TNF alpha. Then we looked at what happens to fatty A concentration in people with prediabetes. And then again, the first perspective. This is the AMPK pathway. I will skip in the interest of time. So diabetes prevention program. So there is a Steve Hapner's paper. They also looked at inflammation in the cohort. And metformin was actually shown to reduce CRP level in the DPP program. Pioglitazone, like I said before, reduces inflammation by reducing fatty A levels. Presentation, so adipose tissue dysfunction initiates inflammation, insulin resistance. Bioactive lipids, particularly diacylglycerol and ceramide, they have been recognized in recent Nature Reviews Endocrinology paper, promote inflammation and inhibit insulin secretion. So, like I said before, organokines play a role in inflammation, insulin resistance, and pancreatic beta cell dysfunction. Intermuscular adipose tissue has been recognized recently to be a rich source of bioactive lipids that cause inflammation. Nature Reviews Endocrinology, last year's publication, and novel anti-inflammatory approaches are needed to prevent and/or treat type 2 diabetes. I think I'll stop here. Thank you for listening. We'll be happy to take questions. Yeah. The question was, hydroxychloroquine has been approved for treatment of type 2 diabetes in India, not in the rest of the world. Well, we looked into the data, and this is still not strong enough to suggest that it should be used as independently as an anti-diabetic medication. It only causes lysosomal membrane stabilization, so as an add-on. But watch for retinopathy. It can worsen retinopathy.
Yes,
Thank you.
Continuously used in SLE. Retinopathy is not very prominent.
Yeah, SLE with diabetes, they're already on HCQ anyway. So check their retina every 6 months. Yes. And okay, they can continue.
Another side effect profile. Some drugs, anti-inflammatory drugs, can lead to hypoglycemia on prolonged use, like colchicine or tofacitinib.
Absolutely.
They are not useful for treatment, but their side effect as hypoglycemia is important.
Yeah, true. Agreed.
Thank you. Thank you, chairpersons. And thank you, Shodhinath sir, for that enlightening presentation. And that shows the volume of research that you have been involved into till date, sir, to the felicitation booth. Requesting chairpersons to please felicitate our honored speaker, Professor Shodhinath Mukhopadhyay, sir. Moving on quickly to the next presentation. To chair the next presentation, may I request Dr. Manojit Mandal, Senior Consultant Gastroenterologist from Purulia and President IMA Purulia. Dr. Santosh Kujur, Chief Medical Superintendent of Rail Hospital Adra, Southeastern Railway Hospital Adra, to be on stage. And for this session, we have as speaker none other than Professor Shubhankar Chaudhary, sir. Sir is a professor and retired professor and head SSKM Hospital, currently working at Medica Hospital, Director of Endocrinology Department. My teacher of many endocrinologists in this gathering, and we've learned the A to Z of endocrinology from sir. Sir, please. Thank you so much for coming, sir.
Thank you very much. It's a wonderful occasion to be with you all. Right, so I suppose all of you here are conversant with the term MASLD. Now, this is the next big sort of epidemic that we are facing. It has been there, but the realization has been relatively recent. So, metabolic dysfunction associated steatotic liver disease, which once again is possibly part of the spectrum of disorders, lifestyle disorders, where again inflammation, adiposopathy are important players. And how do we treat this condition is what we shall try and look at, what should be the indications or or what are the available pharmacotherapy. So why we need to worry about this? Of course, it's very common. Even if you look at the overall global population and adults, at least 30–40% possibly have some evidence of this condition. And if you look in subgroups like diabetes, it's much higher, 60, 70, some studies show even higher percentage of people with diabetes type 2 have got this condition. And in diabetes, the condition tends to have more sinister connotations, tends to have more severe forms of the disease, not just simple fatty liver, but with inflammation as well. And it is suggested, we know that the change we shall soon see from simple normal liver to fatty liver to inflamed liver to fibrotic liver to cirrhotic liver and then to hepatocellular carcinoma. In diabetes, possibly, you can straight away go to hepatocellular carcinoma even without going through frank cirrhosis. And then what we do not realize is that it is not just a liver disease. The term is associated with liver, but it is a cardiovascular disease. People with MSLD die more often from a cardiovascular event than from liver failure per se. If you look at it from the other end of the spectrum, people with MSLD, they are again at least double the risk of developing diabetes than individuals who do not have MSLD but have comparable levels of obesity. Right. Having said that, now again, this, I think you cannot read it from the back at least, but that tries to tell us the definition of MSLD has been made relatively simple internationally. This is from the American Diabetes Association latest recommendations. So if you have fatty liver and if you have any one cardiometabolic risk factor, which could be obesity or overweight, which could be pre-diabetes or diabetes, which could be hypertension, which could be hypertension on treatment, which could be dyslipidemia, I mean raised triglyceride and low HDL. All of these could be now diagnosed as MASLD. Now we do understand that in our country, in this state particularly, there are several individuals with non-obese individuals but have fatty liver disease. So how do we put them in this MSLD? I'm not sure, unless they also have got hypertension or dyslipidemia or pre-diabetes or diabetes. So quickly, in terms of investigations, in terms of trials, we often like to look at data looking at whether it helped to improve liver fibrosis on histology. But in routine day-to-day practice, it's clearly not possible. We cannot do liver biopsy on every individual who has got this condition, especially as we have seen that it is such a common condition. So we need to have non-invasive measures, reliable measures of liver fibrosis. And one of the commonest, easiest way is this fibrosis-controlled transient elastography type of ultrasound, commonly known as the FibroScan. And that helps us to classify the liver fibrosis stage as F0, F1 is minimal or no fibrosis, F2 is maybe slight fibrosis, and you look at the kilopascals there, going up, maybe up to 6 is normal, we can say 8 maybe early fibrosis, 10 could be more advanced fibrosis, and if you go beyond 14, I'm just trying to put them as whole numbers rather than the decimal points, then it's possibly a level of cirrhosis. And what is important to remember, even I, maybe 5 years back, would have believed that I used to tell my patients that now you're in the stage of just fatty liver, but soon you'll develop fibrosis. And if you develop fibrosis, that's an irreversible phase. But the good news is that even up to stage of fibrosis F3, there is enough evidence that you can go back to F2 or F1. Beyond that, if you go on to cirrhotic phase, of course, you cannot go back. So that is sort of the natural history. Not all individuals go all the way down. We still do not know exact reasons why some individuals progress faster than others. It will be good to have some sort of biomarkers so that we can concentrate our efforts on those individuals who are more likely to progress. So this is a two-way dynamic progress, we need remember, and majority, of course, do not progress. So the management would involve reduction of fat in the liver itself. There is excess fat in the liver, so you should try to reduce the fat in the liver. You should try to reduce the inflammation. We should try to reduce the progression of fibrosis, or we should try to regress the fibrosis actually. All these would translate directly into less risk of progression to decompensated liver disease. But at the same time, we need to address the metabolic derangements very importantly. Even if we cannot protect the liver straight away, we should still be concerned about treating the metabolic abnormalities and reducing the cardiovascular outcomes, improving cardiovascular outcomes. So the treatment, the pharmacotherapy of MSLD is of course directed at the liver, but also should be more holistic so that we can protect the individual as a whole and reduce the CV outcomes. And in that treatment, though the brief is for pharmacotherapy, I think still we need to harp on the fact that lifestyle measures are extremely important, and what is the degree of weight loss that we can hope will lead to improvement. Maybe even 5% weight loss can help to reduce the liver fat. If you want to reduce the liver inflammation, you need to go a little bit more, maybe 7%. And for reducing fibrosis or preventing progression of fibrosis, definitely you need to have a bigger weight loss of about at least 10% or more. So in terms of pharmacologic agents, once again, you cannot read this, but this I thought was a nice review in our own JAPI not too long back recently. So it looks at drugs reducing liver fat accumulation, drugs improving insulin sensitivity, drugs reducing liver inflammation, and drugs having anti-fibrotic effects. There are some drugs which are seen probably through all these groups, especially SGLT2 inhibitors, GLP-1 receptor analogs. So let us now come to what is the reality, what is available, and again this timeline, we do remember that the earliest studies were with vitamin E and pioglitazone. That's 2010. Then the omega-3 fatty acids, the most commonly used still. So how many of you would use an ursodeoxycholic acid for MSLD? Please. UDCA for MSLD, no one uses. Very selective audience here. Right, good. Right, so that has come 2011, 2012. Then we had studies with liraglutide, one of the GLP-1 analogs. That's quite early in 2016. And then if we go down, we have obeticholic acid, which is an FXR receptor agonist. We have some newer names, silofexor, which we shall mention at the end. Semaglutide, we all know about this name. Saroglitazar, we know about this name. Lanfibranor is like pioglitazone, a pan-PPAR agonist. Then SGLT2 inhibitor. Then there are some newer agents which are FGF21 agonist. And then pegozafermin and efruxifermin, they are of that class. And then in 2024, we have a number of trials coming out, of which based on phase 3 clinical trials with resmetirom in 2024 and with semaglutide in 2025, they have sort of found the pride of place in the pharmacotherapy of MSLD. And in 2025, I have mentioned vitamin D, come back to vitamin E. So this was the original study with vitamin E, which suggested that it's okay to reduce steatosis at a dose of vitamin E 300 milligrams, which will translate in 50 units of vitamin E. It suggests, if you look at the bottom, that liver histologic improvement in 29% versus 14% in placebo. Now, this did show improvement in inflammation in our country as well, and tirzepatide and all, we can go ahead. And saroglitazar is the one drug which is approved already. And I must say that we all do complain that it does not have enough big study, liver biopsy proven studies, but at least based on FibroScan results, I have seen several individuals going back from F3 to F2 and F1 over the years on saroglitazar. So at least on these surrogate markers, I think saroglitazar still seems to be a good choice for our country. So finally, before winding up, let us do remember that drugs which are used, have been used, but have not been shown to help are metformin, ursodeoxycholic acid, DPP-4 inhibitor statins, and silymarin. Silymarin is a widely used, anything to do with liver silymarin. So these are drugs, please do not use for MSLD. So the other point I needed to sort of harp upon is this. Maybe US FDA may have approved a couple of agents, but that's based on histologic improvement. But we have to look at the patient as a whole. So whether it's actually leading to better liver outcomes, better CV outcomes, those are the data based on which we need to select in the long run, and hopefully we'll have better agents, or these agents would have proven their efficacy in these aspects as well. Thank you very much. Sorry for overstepping the time limit.
Thank you, sir. Chairpersons.
Hello. Sir, beside FibroScan, what are the biomarkers or bioaccumulative test which shows that there is a progression of this disease?
Yeah, so biomarkers are important, and probably the most talked about is the FIB4 index. And of course, many labs still do not know FIB4 index as a test, and they would say that we don't do FIB4 index, but they do all the component thing, ACPT, SGOT, platelet count, and the age of the patient. They can calculate. So FIB4 index is definitely something that we should be advising more often, absolutely correct. And if the FIB4 index is either borderline or significantly high, maybe then we go on for the FibroScan. Yes.
Thank you, sir. From audience side, if any question?
Shotinath sir has a question.
No, I don't have a question. This is just a comment. You highlighted the role of lifestyle modification, which remains the sheet anchor. So last week, there was a paper in Journal of Hepatology which showed non-inferiority of intermittent fasting over calorie-restricted eating in terms of reducing body weight, reducing liver fat, and reducing liver inflammation. So that is reassuring. Both are equally effective. That is number one. And number two, Arun Shandal from Richmond, Virginia, was actually actively involved in this naming conference, the NAFLD to MASLD, and our own Avijit Chaudhary was there also. And it's an excellent document in hepatology, I think you should all read. And there is a heavy presence of endocrinologists, which is very interesting for us. So the hepatology meeting, a lot of endocrinologists. Kenneth Kushi's paper you referred from Orlando, Florida. Kenneth Kushi was leading the endocrine group in that classification. Thank you.
Right. So in between intermittent fasting and calorie restricted, I think the jury is still out. Whether finally it does not rest upon the calorie restriction, I'm not sure, but of course that's a paper that we should pay heed to. Thank you.
Thank you, sir, for providing us many new information.
Thank you.
I think FibroScan is far more important investigation for the diagnosis of this MSLD. Sir, do you think only vitamin E high dose is sufficient enough to treat this MSLD?
As I said, that we do not have the evidence that it arrests fibrosis. Earlier stages, yes. And there are questions raised about the long-term safety of vitamin E, because vitamin E in large doses, instead of being anti-inflammatory or antioxidant, can also become pro-oxidant. So I think we should not be using long-term.
Type 2 diabetes since last 2 years with an HbA1c at present of 8%, non-hypertensive.
Hi everyone, my name is dietitian Ankita Kundu. Right now, currently I'm working in Horlicks, Hindustan Unilever Horlicks, and also I'm practicing in my own clinic from last 3 years in Purulia. So let's come to the topic where the first question is how to. So here, as per the Asian BMI index, so this person BMI is 29. So this is coming under grade 1 of obesity. This is one thing. Another thing is right now we are practicing in 2025, so we must include in our practice the body composition analysis. That means where in our body there are 5 types of compounds, 5 types of body weights: muscle, fat, water, the organs weight and the bones weight. Where in this person we need to see how much is the fat, how much is the portion of muscle in their body, and what is the water weight, and then we should proceed the treatment.
What should you think? Which should come first? Should he start with the tirzepatide or should he go for the medical nutrition therapy? Should he refer to your
That's what, yeah.
So what do you think? Yeah.
The first thing is medical nutrition therapy.
Yes.
So 70-30
Yes.
ratio, as I mentioned.
Always.
Yes.
In all grades of obesity, it should come first.
Yes, yes.
Then
Along-
only,
then
then only
we-
assess that further the tirzepatide like GLP-1 analogs or other anti-obesity medications are needed, or in case of morbid obesity whether bariatric surgery is needed.
Yes.
But in all cases of grades of obesity, as you can see, medical nutrition therapy is the first choice.
Yes. And also the comorbidities
Yes,
we need to
yes,
see.
definitely.
Thank you.
So I would now move to Ms. Shushmita Sen, that what should be the total calorie intake. I think Ms. Ankita Kundu has already highlighted. Anything you need to add here? Exact calorie intake here?
Yes, sir. Thanks for this inviting me as a panelist. Hello, I am Shushmita Sen. Now I am a consultant dietitian at Arogyam Healthcare with Dr. Pankaj Singhania sir. And my question is, what should be total calorie intake? According to dietary guidelines, we always suggest the patient cut down your kilocalorie 500 to 750 kilocalorie in your daily intake, in your daily kilocalorie food intake to lose weight.
Yes, yes. So what should be the ideal calorie intake in these patients, you think?
This case, patient height is 171 centimeter.
yes.
This already said Ankita di, and weight 86. So appropriate weight her 7.
You need to exactly calculate here. It's more or less around 2,500, 3,000 kilocalories it's coming. So you'll restrict from that first. So not the ideal scenario here. So later you will gradually reduce to that. Okay. So I will now move on to Ms. Suchishmita De for the next question. That which type of food should we focus? We have discussed about the total calorie. Now what kind of food you should advise?
Thank you for the question, sir. I am Suchishmita De. I am working, now I am working as a dietitian in Rotary Club of Hospital, Purulia. The question is the most fundamental question when we discuss the treatment of obesity. The diet should be low in carbohydrates and fats, adequate protein, and most importantly high fiber foods like whole grains, whole fruits, vegetables, and pulses should be included in the diet. The the obese patient should restrict processed food and fried foods, and the foods giving empty calories also.
So we cut down the sugar first. The carbohydrate intake
Yes.
should be low,
Yes,
and
sir.
also the processed food you have to avoid.
Yes, sir.
Okay?
And
I'll go
here-
into the details, the macro and micronutrients later.
Okay, sir. Okay, sir.
So again, coming back to Ms. Ankita Kundu, what should he prioritize, macronutrient or micronutrient, or it's the both?
Yeah, it's a very interesting question. So while coming to the, it's a challenge when it is coming to obesity or overweight, most of the time we focus on the macronutrient. So that is definitely needed, I'll first come to the carbohydrate. In obesity,
So again, coming back to Ms. Shushmita, what do you mean by plate model? Do you advise that?
Yes, sir. First off, plate model is an important question because we are always selected wrong plate model. I always suggest a patient, it's a simple rule. Your plate is divided in 3 sections. Half section always intake variety of fruits and vegetables, and 1/4 of protein and a good source of fat. Like if you are vegetarian, then protein sources are dal, soybean, paneer, tofu, etc. And if you are non-vegetarian, then also included chicken, fish, eggs. Always, and good source of fats are like nuts and seeds.
So it's an easy way to calculate the calories or restrict the calories. You advise it regularly,
Yes,
right?
restrict the calories. And one second, sir, question please.
So do you advise it regularly to your patients who come for dietary advice?
Yes, sir, calories always cut, but we are carbs cut down and intake vegetables increases.
So the patients get a rough idea about their calories by this plate model, right?
Yes, sir.
You cannot individually calculate the calories of each and every
Each
food.
and in every food.
So next is that.
Ronil,
Okay,
sorry.
yes, sir.
Sorry to interrupt. Actually, see, you
Yes, sir.
prescribe something and the patient rarely follows that. So that's why your diet chart doesn't help anyone. What you need to do is to modify whatever he is already taking and make it more healthy, right, in terms of your macro and micronutrients, whatever. So Ronil, if you could go back to the food intake pattern, this patient, and just by looking at your breakfast, lunch and dinner, and you could easily tell us where protein is deficient, where carb is more, where fat is more. Modify this so that he can, accept your diet plan more positively, right?
So what do you think you should
Yeah,
prefer
actually,
this patient?
sir was saying this, and since I'm also one of the moderators, I would like each of you to pick up one meal. Maybe Ankita can take up the breakfast, Sushmita the lunch, and Suchishmita the dinner, and modify. Let's do with that. Start with that.
So is the breast
And the evening snack maybe deleted altogether.
is the breakfast right?
Ankita, how would you like to modify the breakfast in terms of calorie, etc.? Let's not go with the presentation. Let's make it more practical.
okay, sure. So, yeah. So, as if we can see, the breakfast is usually 2 parathas, the typical breakfast pattern, 4-5 slices of bread and a big bowl of poha with tea. So, in this scenario, directly the person who have been taking this diet for past 20 years or 30 years of his life, we cannot directly tell them to omit all those things. Rather, we can do that is the customization, as respected sir was telling this. So customization as in let's come to the parathas. So when we are suggesting parathas, definitely we are Indians, we can go with the parathas, but again it should be stuffed parathas. So instead of taking the normal chapati one or the ghee one parathas, we must go with the mooli paratha or the stuffed beetroot paratha or any kind of mix this millets. So this we can prepare and suggest the parathas. It's coming to the bread culture. So I am not very supportive to the bread culture. Instead, bread, if someone is taking again, they can go with the bread, but again, there are a lot of controversies because there are brown breads as well. But those, if you see the ingredients, those are not made up of the things. The ingredient list there, the maida will become first. Yes, and the coloring agents, because if you see, I must highlight this, when you're seeing the brown bread, people get fooled by the color. But if you see, if it is made up of atta, so then it should not get that color, brown color. No, the ideal culture of brown bread, it will be definitely not staying more than 24 or for 2 days. So definitely bread culture, I'm against of it, but sometimes if someone is incorporating with eggs or the other vegetables, definitely they can go with this. Last, the poha and the tea culture. So I am fed up of listening to this, please add tea. So we should not omit the tea totally, but instead we can exchange it with the herbal teas like manjishta or any kind of herbs or spices is present in your kitchen, like cinnamon, black pepper. You must take the infused teas.
So the poha is okay with you? Poha
And,
is okay
and
with the
what about the protein in breakfast? How would you like to stuff your parathas with paneer maybe?
Yeah, paneer again, it's a bit controversial, but we can go with the paneer, homemade paneer, what we call chena.
And paneer sandwiches with those maybe slices of bread.
Yes,
Reduce the
can be.
slice to 2 and maybe fill it up with paneer.
Can be done. Also, tofu is very good nowadays, and it's available in Purulia as well.
And
So,
adding up, reducing the rice content of the poha, increasing the vegetables in the poha,
Yes,
increasing the
yes.
soya, maybe adding some soya bean and again paneer and nuts.
Yes, yes,
Yeah,
yes.
next I think
Shushmita, for
will
the
tell us about the lunch.
Lunch is adequate?
Yes, sir. Sir also included one sabji and one fish and one bowl rice. I only suggest a small quantity of salad, not much food, and one quantity of salad. Also, first we take and you start your meal. Start your meal with a salad, then one bowl of rice or with sabji and fish.
And what protein is adequate?
What is the size of the bowl?
Amount?
How much amount of cooked rice or uncooked rice?
Sir, if you take salad, then one plate of salad always, and with one bowl, one small bowl of rice. What is the volume? Always you 15 gram of rice included. 50 gram, yes sir.
50 or less.
50 gram of rice included, and 80 to 100 gram fish included in your daily lunch item.
Now you are saying 50 grams, so they will weigh 50 grams every day. What will they actually do? This is for the benefit of the audience. They don't have access to dietitians, most of the practicing physicians here. So for their benefit.
How do you tell the patient? How do you tell the
Sir, always we are example.
Ankita can
tell us about the bati or the bati size of the bati.
I'll tell. This is actually very much difficult for a layman to classify. So let's forget the bowl culture. Let's start with the hands. In earlier days, there was no this culture and weighing machine. So that time, our mother, all the grand nannies and all, they used to measure it, and approximately they measured the accurate one. This is the 30 gram. So let's start with this much, 30 gram, 30 to 50 gram. Let's stick to that. So the bowl size will be 30 to 50 gram. Also, when coming to the countable sizes like roti, chapatis, all these things. So then we must stick to one. It's like one chapati and a bowl, as my co-colleague already described, one bowl of paneer or egg whites along with vegetables. Thank you.
যেটা অনেক সময় বলা হয় এক মুঠো ভাত, one fistful of rice is what you're talking about. And about the dinner, can Miss Suchishmita tell us about the dinner?
And also before the dinner, what do you mean by a healthy snack? Patient is hungry in the evening, but he is snacking outside anything, so fried foods like that. So how do you advise that?
Yes, sir.
What can be advised in healthy
In
snacks?
dinner, the patient is taking outside foods like pasta and pizza. আমরা এই খাবার মানে বাইরের খাবারের বদলে আমরা বাড়ির খাবার খেতে ইনসিস্ট করব, যেমন 1 থেকে 2টো রুটি, সেটা 25 গ্রাম ডো হতে পারে, তার সাথে একটা প্রোটিন আইটেম কিছু ইনক্লুড করব, সেটা ডাল হতে পারে, সয়াবিন হতে পারে, পনির হতে পারে, তার সাথে সবজি রাখবো অবশ্যই, স্যালাড রাখতে পারি আমরা, এবং খাবার শুরু করার আগে আমরা স্যালাড দিয়ে খাবারটা শুরু করতে পারি।
Also, and what about the snacks? So he's hungry at the evening, but he's taking fried foods outside. What do you advise?
So healthy snack is something we can take between the meals, and it should be nutritious.
One more thing I want to highlight.
Yeah, sure.
Again, it's not always the quantity or the quality. Again, the timing matters a lot, because our body follows circadian rhythm. So the type of dinner, before discussing this, we need to fix the time. the early dinner is the key to good and sustainable weight loss. So before starting with the quantity and quality, let's not debate about this first. First, go with the timing. Thank you.
So do you think any role of intermittent fasting here nowadays?
Yeah, so it's very much controversial.
Sarah has already raised the topic earlier.
Yes. Past 1 decade, 1 or 2 decades, it's been very much controversial in the diet sector. So intermittent fasting, I'm not saying it's totally baseless or not, it's not scientific, but again, let's stick to the simpler ways. Before going to any kind of time restricted diet, let's stick to the holistic approach. As my co-colleagues already described, that small sizes, as the respected sir already told, that this particular patient is taking around
Tell me whether intermittent fasting is beneficial or not. Will you advise patients to do intermittent fasting?
Again, sir, as I was
risks are
saying.
there also.
Yes,
Recent
so
studies have shown that increased risk of cardiovascular risk
That's
is
what,
there.
sir.
So do you not recommend that?
I will not recommend for everyone.
Okay.
I will only go
So
with
one last questions for the panelists.
I think Obrunil will
what
wrap
is
up with the
summary
could
slide.
you tell us about the
What are the
summarize?
steps to be followed to maintain weight loss? As the panelists have already discussed, first you have to go for the daily calorie requirement, that is by the 24 hours dietary recall. Then according to that, you cut down the sugar first, and the total calorie should be restricted by 500, almost by 500 kilocalorie. Okay. Then after that, distance for food environment is also necessary, like that the shopping from a list or storing foods out of the sight, out of mind. So that's important. And one important thing is healthy snacks, as we have already discussed. And then ultimately the monitoring. The patient should be counseled regarding the initial monitoring of the weight at least weekly, and side by side also the exercise is important. That initial activity goal of 150 minutes per week is recommended. Okay, so
thank you.
Thank you, our
Thank you, our panelists, and Obrunil, a big round of applause for these young nutritionists and our young endocrinologist, Obrunil, for taking us through this discussion. I request them all on the photo booth for the felicitation. And moving on to another interesting session, which will be a debate on the type of insulin. We have a number of fancy insulins, newer insulins, designer insulins now, the so-called analogs, and we still have the conventional insulins available to us, including regular insulin and all. So obviously cost is a factor, availability is a factor. Let us learn from our esteemed panel, which will be moderated by Dr. Soham Tarafdar. Dr. Soham is consultant endocrinologist. He was with us at SSKM Hospital a little while back, currently practicing as a consultant endocrinologist in Kolkata. And for the panel, we have Dr. Uttiyo Gupta, another consultant endocrinologist and a very close associate from Kolkata, and Dr. Sunil Kota, consultant endocrinologist from Odisha. Uttiyo will be speaking for the motion. Please. Uttiyo will be speaking for the motion, and Dr. Sunil Kota will oppose the motion. The motion for today's debate is analog insulin should replace conventional insulin.
Okay. So thank you, Pankaj, for helping me moderate the session. I would like to call upon Dr. Uttiyo Gupta first, who is speaking for the motion, analog insulin should replace the conventional insulin.
Thank you. And thank you, Dr. Pankaj, for inviting me in today's debate. So, we are today discussing analog insulin should replace the conventional insulin. This is the topic, and I am talking for the motion. So, if we look into the timeline of insulin development, you can see that NPH insulin, the intermediate acting insulin, is available since around 1950 or 60s, and subsequently in 1980s we have recombinant human regular insulin that is available. But from 1996 onwards, all the newer upcoming insulins are some form of analog insulins. And if we look into the insulin options nowadays, you can see though conventional is there, but the list is majorly occupied by the analog insulins. So the obvious question comes that why analog insulin if so much conventional options are there, which is apparently cost effective, and also apparently useful. If it serves the purpose, then why analog? And the answer lies in the question itself. Because definitely there is a need and there are limitations of conventional insulin that we have to understand. And why newer insulins are coming? Because our goal is to try to simulate the beta cell mediated insulin, natural insulin secretion profile, that is maintaining a basal insulin within meal and post meal insulin release after a certain food intake. And to overcome the pharmacokinetic and physiological challenges of peripheral insulin administration, in contrast, where beta cell mediated insulin goes directly into the portal circulation, and the utmost goal is to ensure the tight glycemic control without expense of hypoglycemia and weight gain as much as possible. These rapid acting analogs we are discussing, it has an early onset, as you can see. The peak concentration is twice than the regular human insulin, and the offset is also early. So it mimics the physiological insulin release from pancreatic beta cells. And the basal insulin also, it has longer duration of action and less variability, less hypoglycemia, all of us know. If we talk about the type 2 diabetes in particular, there is an apparent notion, and meta-analysis have shown that okay, both conventional and analog insulin can go for a comparable glycemic control, and we are very happy with that. But there is a pinch of salt that we love to see the apparent result, to read the summary and abstract, but if we go into the depth of the studies, we will find that most studies that compared this rapid acting analog to human insulin, these are not powered to show a difference in HbA1c, as those are treat to target studies, and the target was to achieve a similar glycemic target between the treatment groups. So how it will show the difference? And many studies were performed without basal insulin optimizations, and there were confounding factors which can influence the HbA1c. Looking into the data in type 1 diabetes, study from our own country, it has shown that glycemic control is better if we use analog insulin. HbA1c is 7.6% in analog versus 9.3% in conventional insulin. Regarding nocturnal hypoglycemia, again studies have shown that the risk and incidence of nocturnal hypoglycemia is far less when we are using analog insulin in type 1 diabetes. And if we exclude the first 2 hours post dinner time, where there can be chances of hypoglycemia due to pre-dinner insulin administration, then also the result is similar. So hypoglycemia benefit is there when treating with conventional analog. It is far better in terms of nocturnal hypoglycemia in comparison to the conventional insulin. Regarding the postprandial glucose also, glucose control in type 1 diabetes, meta-analysis have clearly shown that glucose control is far better due to obvious reason when we are using analog at the cost of less overall hypoglycemia and less overall and anytime nocturnal hypoglycemia. This is the statement from ADA 2026. If we read it carefully, it has mentioned that in people with type 1 diabetes, treatment with analog insulin is associated with less hypoglycemia and weight gain and better HbA1c control compared to the regular human insulin. So ADA is talking that, it's not my personal opinion. And this is again from ADA 2026, the list of options for type 1 diabetes control. You can see it is very obvious that analog insulin are in the top of the list given preference, and conventional insulins are much lower below the list due to obvious reason we have discussed so far. Coming into the basal insulin, I need not to explain, insulin glargine is associated with less glycemic variability and hypoglycemia in comparison to NPH insulin, which is conventional one. And in newer generation glargine also, to achieve a same HbA1c, the risk of nocturnal hypoglycemia is far, far less, and the difference is even more marked if we compare with NPH. Regarding premixed analog, this is opinion by Dr. Sanjay Kalra from our country, that analogs premixed have better associated with have better outcome regarding lower hypoglycemia level and better postprandial glucose control and quality of life. Regarding pregnancy diabetes, again study from our own country, it has shown rapid acting analogs are safe. It can use efficiently bring down the postprandial glycemic control, and longer acting analogs are doing the same thing. When we are talking about insulin pump, the insulin of choice is, again, as it is shown here, all of us know it is analog insulin that we introduce when you give insulin pump. So in today's conference, Dr. Pankaj Singhania has chosen the best possible option in the mode of transport and in the mode of the conference venue. So why we would refrain ourselves for offering best to our patients when Dr. Pankaj is offering best to us? And to summarize, in type 2 diabetes, you can debate among the choice of insulin, because here analog is not inferior to conventional insulin. Regarding type 1 diabetes, clearly shown, ADA has also mentioned that it is better. Hypoglycemia benefit, needless to mention, premixed insulin pump, everywhere analog insulin is better. And we need to understand, I will take one more minute, we will need to understand that this analog insulin is the upgraded version of the conventional insulin. It's like software upgrade. Though we love to say old ways are the best and we make fun and mockery of the modernization, whatever we do, but you cannot deny all the persons sitting here, nobody would prefer to use the older version of software in terms of his or her laptop or mobile use. So it's a matter of choice. Like this is the most famous debate in the history, where Duryodhana has chosen the apparent conventional cost benefit options, but Arjuna was the wise enough. We all know what he has chosen and it worked. So today's debate was whether analog insulin should replace the conventional insulin. In extremely resource poor setting where 100 rupees do matter for the patient, you can think of conventional insulin, but from scientific point of view and in all practical purpose, in probably all the scenarios, due to obvious reason, from practically and from scientific reason, analog insulin should replace the conventional insulin. Thank you.
Thank you, Dr. Uttya, for the wonderful deliberation. Now I would like to call upon Now I'd like to call upon Dr. Sunil Kota sir, who requires no introduction. He will be going against the convention that the analog insulin should replace the conventional insulin.
Thank you so much. Very good afternoon to the respected chairpersons, to the audience, and thanks to the organizer, especially Dr. Pankaj, for having invited me to this podium and asking me to talk against the motion. Before I, can we have the slides? Before I start with the presentation proper, let me recollect what Elliot Jocelyn way back in 1947 said. Any advancement in the field of diabetes should be about new discoveries rather than suggesting some mere 5 to 10% improvement in the existing form of insulin. So with this preamble, I'm going to start off with my topic proper, and I would be talking against this wonderful motion presented by Dr. Uttya. Let me introduce you to a new term, Luddite. I'm not a Luddite. I'm not against technological change, but whatever was being pointed out, that was talking more about convenience rather than any clinical outcome orientation. So I reserve the right to defend my points and present my points rationally in this insulin war. So how does he look in his conventional avatar? Brilliant, handsome. And when he becomes more dashing and more stylish, whether he's going to be more acceptable, that's what I would be talking to you about. And it's a friendly banter, and I would be taking you through the points mentioned in the slide. What do we understand from the existing landmark trials? So the evidences that we need are benefits in terms of mortality, safety, macrovascular complications, and the phase saver comes up that we are improving HbA1c, that we are giving rise to more of hypoglycemia reduction. It is stated that to the man with a hammer, every nail seems to be a problem. So similarly, a man with a new drug, every problem in pharmacology seems to be a problem. So I need not highlight this slide much. We all understand that the the regular insulins have proved their mettle, the human insulins rather, all these landmark studies, DCCT, UKPDS, Kumamoto. I think you all might be recollecting that ad where even after purchasing a yacht, he says, kitna mileage deti hai? So we all are mileage conscious country, and as far as HbA1c is concerned, the analogs versus the human regular human insulin, the pump 0.2%, the MDI 0.06%. In type 2 diabetes, the difference gets obliterated. And this meta-analysis of 68 RCTs in Canadian Journal in 2009, rapid-acting analogs in type 1 give 0.09 to 0.13% A1C reduction. In type 2 diabetes, no difference. The long-acting versus NPH in type 1 diabetes, 0.06 to 0.11. In type 2 diabetes, only glargine gives rise to additional 0.05%. This Cochrane review in 2016, the analogs versus the regular human insulin, only there is a 0.15% HbA1c additional reduction, which gets obliterated again in cases of type 2 diabetes. This is bit wonderful in Diabetes Care 2014, a meta-analysis of 64 studies comparing both the long-acting and the rapid-acting analogs with that of the human insulins. Only 15 studies, that means 23% of the studies tell us they give us additional A1C reduction. Look at the paltry 0.09% average reduction. Now comparing the NPH vis-a-vis long-acting. This again is a Cochrane review in 2006. Glargine and detamir pitted against NPH, and the bottom line is that there is no clinical difference. There is no difference in severe hypoglycemia, but overall hypoglycemia gets reduced. This is a meta-analysis of 20 RCTs, long-acting versus NPH. HbA1c gets additionally reduced by 0.07%. Detamir has less weight gain. Yes, as he has already stated, nocturnal and severe hypoglycemia get significantly reduced, but overall hypoglycemia we do not have any advantage. This is again a study in type 2 diabetes where glargine vis-a-vis NPH, no change in basal glycemic control, no change in nocturnal hypoglycemia as well. So you all must have heard the word utopia. It is an imaginary place where everything seems to be perfect. Probably that's what the picture is being pointed about. Now comparing the premix insulin, human versus the premix analog, as far as the postprandial glucose control is concerned, premix human is better than the premix analog. You can look at the values. As far as HbA1c is concerned, both are same. As far as fasting plasma glucose is concerned, some of these studies have suggested insignificant better reduction of fasting glucose in favor of the premix human. This is again a switchover study. When you switch over from premix analog to premix human, 0.14% additional A1C reduction is there. Now coming to the point of hypoglycemia, Cochrane review 2006, rapid acting analog versus human insulin. Type 1 diabetes, there is no change in overall hypoglycemia. Similar is the situation with type 2 diabetes, there is no change in hypoglycemia. Premix insulin analog versus premix human insulin, there is no change in incidence of major or minor hypoglycemia. This Canadian article in 2009 says that both the rapid and long acting insulins are almost equal as far as the glycemic control and the hypoglycemia is concerned, but they say good number of studies have suggested nocturnal and severe hypoglycemia is getting reduced. So the primary clinical argument that switching everyone to analogs is basically defeated here. This is a Harvard paper in 2018. They say the long acting analogs reduce severe and nocturnal hypoglycemia. The rapid acting analogs do not reduce major reduction in severe hypoglycemia. So the benefits are not that dramatic. This again is something not very past one in 2021. The nocturnal and severe hypoglycemia, which is being touted to be lesser with analogs, is being defeated over here. And in type 2 diabetes, when you use long acting analogs, the ED hospitalization due to hypoglycemia is not that much affected. So we are not against this tide of innovation, but when it is a matter of advertisement over substance, we all need to take a call. Cost again is important. So he has already shown one very important slide. But I have traveled, all of us have traveled in this conventional trains. I have traveled by Purushottam. I was not offered Bande Bharat. Jokes apart. This Canadian article in 2009 tells us that apart from rapid acting analogs in type 1 diabetes, none of the other cases present a picture where you are using efficiently the finite healthcare resources. Again, the Harvard paper in 2018 tells us the insulin analogs are 5 to 10 times more expensive, provide marginal clinical improvement for most of the patients, so it would not be probably a wise option to replace everyone. In this 2020 survey, where it is stated that about 25% of the patients miss insulin or go for underdose, and which actually translates into negative patient care related outcomes, which again is reiterated by ADA in 2024. Now coming to weight, we do not have much of evidence as to suggest significant difference in weight gain due to different kinds of insulin. CV studies, type 2 diabetes, JAMA 2020, insulin naive adults with type 2 diabetes treated with human versus analog had no difference in major CV events, mortality due to cardiovascular disease or overall mortality. Emergency situations, DKA we know hospitalized in hospital management of hyperglycemia, when we require intravenous insulin, there is no point of preferring analog, rapid acting analogs over human insulin. That's what is being alluded to. Other issues, this is a JCM recent paper for patient needing very large doses, more than 500, cost constraint setting and humanitarian crisis setting. Human insulins are the only practical affordable option. This is the IDF 2019 statement, where it is stated that the human insulin vials can be stored for 28 to 40 days versus 28 days for majority of the analog insulins. We have some aberrations in the form of detamir and degludec. This is interesting. Type 2 diabetes, the regular human insulin, even if it is given 20 minutes before meal or immediately before meal, the glycemic outcome doesn't change, though it is not a very large scale one. As far as global access is concerned, the human insulins are older, the many national procurement systems, donation programs and cold chain arrangements revolve around them. So WHO recommends it is an essential component, and complete analog replacement is unrealistic for low middle income countries. Lastly, about some of the expert comments, I would just briefly touch upon this is a very wonderful review article which touches upon the Canadian, UK, WHO and ADA, and it tells us that type 1 diabetes, rapid acting analog is definitely good, long acting analog preferably can be used, and in type 2 diabetes, you have a subset of patients where you need to go for the analogs. So blanket treatment of everyone with analog is probably not justified for all patients. I would be summarizing, and with these kind of arguments, I think again Dr. Utio would be back to his conventional form, and the C in convention also stands for care with compassion. So lastly, I have talked about HbA1c, I have talked about the hypoglycemia benefit, and also the cost and access issues. Till I think the old is gold. Yesterday we all danced to the tunes of Rafi Sahab and Kishore Kumar Sahab, so I would definitely suggest old is gold, and Jai Jagannath.
Each presenter will get 2 minutes for their replies.
Thank you. So, as a rebuttal, regarding HbA1c, the jugglery of facts, the HbA1c, the values, we have said also that in type 2 diabetes there was heterogeneity of study design. If we agree the fact that it is equivalent also, okay, but in type 1 diabetes analog insulin is superior, we all know that. Regarding hypoglycemia, all of us know from factual and in practical experience, from studies also, we need not to explain that hypoglycemia benefit is far better in analog insulin, and that is a major concern to patient and physician when we start insulin. Cost, yes, analog insulin are a little bit costlier than conventional insulin, but the cost issue is apparent. The same person who is fighting for 20 rupees with a sabji vendor will buy a ticket of 10,000 rupees for an IPL match and will spend 10,000 rupees to see a glimpse of Lionel Messi, and will come back to you and will argue with you for 600 rupees for a doctor's visit. Lastly, we also see physicians as patients or other doctors as patients. I have not seen any doctor who are coming to me and saying, Dr. Saab, I am happy to have some form of regular and NPH insulin. Please give me some NPH insulin. So ask yourself, place yourself in the chair of the patient, and if you have diabetes and you have to come to another doctor, whether you would ask for NPH insulin or some form of glargine or something else, you will get the answer. Thank you.
I'm not going to rebut whatever Dr. Utio has already stated. I would just reiterate what the guidelines have recommended. Yes, for type 1 diabetes, rapid acting analogs in all, long acting analogs in good number of cases is definitely wonderful. but the title of the debate was analogs should replace insulin. That's what is the point of contention, where I would strongly suggest good number of patients would still do with the human insulins with the number of evidences that I have pointed. Thank you.
Thank you for the wonderful presentations, and we'd like to have a show of hands who are in favor of the initial point that analog insulin should replace the regular insulins. Human.
So the motion is analog insulins should replace
Who are in favor
conventional.
can raise their hands.
Those in favor of the motion, please raise your hands.
Okay, we don't see many hands. So
Those
who are,
against
the motion, yes.
please raise your hands. So your resource constraint setting. A resource constraint setting goes with Jai Jagannath. Thank you. Thank you. Thank you. I request the moderator and the speakers on the photo area, please. Which will be deliberated on metabolic bone area. We have Dr. Apurva Mandal. Apurva. Dr. Shubhro Pandey, who is a faculty at Department of Medicine, Deven Mahato Government Medical College and Hospital. And to talk about this topic, screening and evaluation of osteoporosis, a very, very important but ignored topic, we have Dr. Ayan Rai, who is head of the department endocrinology at AIIMS Kalyani. Dr. Ayan Rai.
Shall I start? So thank you for the invitation here. It has been a wonderful journey till yesterday afternoon. So my topic here to discuss is on screening and evaluation of osteoporosis. We have touched upon this in the morning session with Dr. Belinda George was speaking with diabetes and bone health. So many other things we know. But here I'll discuss on few things which will be almost take-home points so that we can implicate all those things, all those knowledge in day-to-day practice. So until and unless we are doing, so it's not going to benefit the patient. So let us see what we can do to screen and evaluate the osteoporosis. So by definition, it means that the bone has become porous. So what do you mean by porous? It means that the mineralization has come down. Not only that, which is usually detected, we call it as bone mineral density. Simultaneously, the total bone volume is also getting decreased, particularly in postmenopausal women. So as a whole, there is a both qualitative and quantitative reduction in the bone. So osteoporosis is not only a disease of mineralization, it is a disease of the bone that we have to, remember. And this is most important in postmenopausal women because after menopause, they start losing their bones because of lack of estrogen mostly. So the question comes now, this is the crux of the discussion of today, how common it is. Osteoporosis is pretty common as whatever patients we see postmenopausal, you can see up to 20% of patients who are having, after the age of 50 years. That is, if we have somewhere around 25 crore of population after 50, so 20% of them. Actually, recently in Indian Express, there was a headline that roughly 6 crore women are there with osteoporosis. So this is as common as we see any other diseases. So don't have this kind of idea that possibly this is very rare or this thing, we don't need to treat this kind of patients. This is a pretty common disease, as common as some diabetes or cholesterol. And and see the hip fracture rates. In 2015, it was estimated roughly 4.5 lakh hip fracture throughout India. 2020, it is somewhere around 6 lakh. And you see in 2050, it will be 10 lakh women who will have hip fractures
just because of osteoporosis. Huge number, and many of these fractures are preventable and treatable. So if we treat osteoporosis, we are going to prevent a fracture. And remind you, all of my friends here, that one hip fracture carries roughly 12 to 20% mortality in 2 years. So someone who has had a patient of hip fracture will know better. So this is a pretty common disease and pretty devastating disease. So, so there are specific guidelines which tells us whom to screen. So once the patient enters, we know whom to screen. This is the International Society of Clinical Densitometry that is worldwide almost accepted. So most important is women aged 65 and older. If we can remember this, I think many of the osteoporosis patients will be screened. So women aged 65 and older. What about men? 70 and older. Okay. And any women less than 50 year, less than 65 year, or men less than 70 year who has a wrist fracture. Most important risk factor, having a recent fragility fracture. So remember, fracture is the most important risk factor, and which we want to actually prevent. Another important risk factor is high dose of glucocorticoids. Many patients, particularly who comes from the suburbs or rural area, I see inadvertently they are using some or other forms of glucocorticoid, be it be topical, be it be oral, or some other things. Somebody who is on glucocorticoid, you are alert. I mean, we should be more alert that this patient should be screened for more. So, but problem with India is that this 65 and 70 years doesn't hold good, because our menopausal age is much earlier, and we lose more bone compared to our Caucasian counterpart, and we have a higher chance of fracture. So for that we have come up with our own guidelines, where there are suggestions that women more than 60 years of age and men more than 65 years of age, we should go for screen. And one important point has been included here is the fragility fracture. So what do we mean by fragility fracture? That I'll discuss it here before I further go to this thing. So, so fragility fracture is very simple. The patient has fallen from a standing height, or the clinician thinks that this much of trauma should not result into this much of fracture. That is more than enough. So if a clinician asks, how did you fail, or how did you break your bones, that is more than enough that these are fragility fractures. And the usual sites are spine, hip, proximal humerus. And we do not include skull, face, or finger and toes fractures for a fragility fracture. So just asking fragility fracture in a patient, elderly lady, will give us much more idea about the osteoporosis than I think even doing BMD. So, so how do you screen? We can do many things, but I will mostly focus on the DEXA and FRAX, which is usually commonly done. And I was discussing with few of my colleagues here. I could understand that there is no DEXA facility till here. So, okay, this I'll skip. What are the skeletal sites that are usually measured in a DEXA scan? That is usually posterior anterior spine, that is L1 to L4, and hip. And in certain cases, forearm BMD, when we are thinking that our measurement might be wrong, or the cortical bone in the forearm might be more affected. But spine and hip is usually measured. So this is a standard DEXA report from our institute. So it carries many of the things, and like the interpretations are, I am going to discuss what is the interpretation for that. So for postmenopausal ladies, we have a score called T-score. So what is that? That is what is the patient's BMD that we subtract from a healthy 30-year-old reference database, and that is divided by healthy. Why this is? Because a 65-year-old lady, if we compare with another 65-year-old lady, the difference will not be that much. And this is related to some concept called peak bone mass, because we are achieving the highest bone mass during our 30s. So this is the T-score we will generate from DEXA. And in less than 50 years of age, or like in children, we use a Z-score where we compare with equal age group. Okay, this I'll skip, this I'll skip. So what is the definition? So if we get a T-score of less than minus 2.5, that will tell us this patient is having osteoporosis. Minus 1 to minus 2.5 is osteopenia, and it's normal. One important caveat here is that many of the fractures do happen in the osteopenia range. That is because of two most important factors. One is majority of the patients, the number is more in this group. And second thing, possibly DEXA is not that sacrosanct instrument to detect BMD. That's why many things are coming, TBS and all those things. There are certain drawbacks of DEXA is also there. Particularly, we have to correct whenever a person is having diabetes and glucocorticoid. In those cases, BMD is like underestimated. And in routine clinical practice, we have a very wonderful tool that can be used, is called FRAX. That is Fracture Risk Assessment Tool. And there is a recent revision of it called FRAX Plus. So what is FRAX? In all studies, it has been seen that if you use DEXA-derived BMD plus clinical risk factors, we should never ignore the patient itself. How is the patient on several factors? This is a better predictor of fracture compared to a BMD alone. So this already we have discussed. So this is like last night I was just checking on. These are the simple parameters which is freely available. We can easily go to the website. We have an India-specific FRAX score also. And these are the simple 11 parameters, starting from age, smoking history, alcohol history, glucocorticoid, family history, fracture, all those things. Here you see the femoral neck BMD measurement is optional. So even if we do not put the BMD measurement, we'll get a FRAX score, which is like in Caucasian group, if the fracture risk is high, that is 20% and 3%, then earlier we used to treat. Now we have a revised guideline, our own, that is 10.5 and 3.5%. So if that risk is also high, then we'll tell that this lady is also having very high risk of. So what I'll insist from, what I can tell from this topic, if you do, please do assess with patients of yours, even if you do not have a DEXA facility, with all this risk factor, and then we can nicely see what are the things. These are the FRAX plus adjustment. But last but not the least, we should always look for a secondary cause of osteoporosis. So what can be the commonest secondary cause of osteoporosis? Commonest may be, from an endocrine perspective, usually this is thyrotoxicosis, hypogonadism, hyperparathyroidism, and most importantly, as I told you again, this is the glucocorticoid-induced osteoporosis. That's pretty common, which I find in my practice here. Type 2 diabetes, obviously, again, it's coming, diabetes-induced osteopathy in a big, this thing. So once we have a patient and we think that possibly a 50-year-old lady has a very poor bone on forearm, usually we do like that, but spine and hip is relatively preserved, we suspect that more cortical bone loss is there. So possibly let us do some investigations and all those things. These histories we can easily take even in a primary setting also. So if we can have this kind of suggestive history, our examination or investigations can be tailored to this. So we can do a complete blood count, we can have serum calcium, phosphorus, IPTH, all those things, and a 25 hydroxy vitamin D. So these are the standard 4 or 5 parameters which ideally should be done. But I would prefer that if we have this kind of history, then we can do this kind of, screening to identify what is the underlying cause. So that's what is from my point is that osteoporosis is pretty common. We can screen by clinical feature itself. If we had DEXA facility, it's pretty good. We should do BMD. And simultaneously, as earlier Professor Mukherjee has told, that do a D4 to L4 X-ray to find the vertebral fracture. If there is any vertebral fracture which can be easily graded by grading called Genan grading, which is nowadays available. So that can be easily, so if any fracture is there, that patient is already having indication for treatment. Even I find that some form of, unidentified low back pains, people do x-rays. In those x-rays also sometimes you might find a vertebral fracture in somewhere L1, L2. So if those kind of things are there, they will give us more idea. So thank you, that's all I think from my end.
Thank you all for excellent presentation.
If there are any questions from the audience regarding this very important topic of osteoporosis, I think it's primarily talking about postmenopausal osteoporosis, screening and possible diagnosis. And he's touched upon both DEXA and with and without DEXA choices, though obviously DEXA remains the gold standard. So.
Again, this is just a comment.
Yes, sir.
Wonderful presentation. See, radiologists are known to miss fractures on X-ray report unless you specifically ask for fracture. So you ask for a pelvis X-ray or spine X-ray for some other indication, osteoarthritis. The radiologist will say OA changes plus or minus, but there is a fracture. No mention. And there is published study showing in what percentage of cases they miss those fractures.
Yeah.
And sometimes they see fractures. They report it as compression or collapse and not fracture because they think we'll scare the patient if we mention the word fracture. But they have to mention the word fracture. This is osteoporotic fragility fracture. Thank you.
Thank you, sir.
Just a quick comment. That's our calcium intake in this part of the world is generally abysmally low. We have to diagnose, we have to treat pharmacologically in many cases, but we have to prevent. And so in whatever capacity we are practicing, I think we should try and increase the intake of calcium in different forms amongst our patients. That's very, very important, I feel.
Yes, and that is possibly one of the major contributing factor apart from low muscle mass why we are fracturing early or at a less BFD. Thank you, sir.
Thank you. Thank you, Ayon, and thank you, chairpersons, for that wonderful session to the felicitation booth. We quickly move on to our pre-inauguration last session, which will be on thyroid function tests. To chair the session, we can have on stage Dr. Mrinal Kanti Rojok, MK Rojok, who is Block Medical Officer of Health at Kustar BPHC, a very enterprising fellow and very close to me. Dr. Aswini Majhi, Deputy Secretary, Department of Health and Family Welfare, Government of West Bengal. And Dr. Sabyasachi Mukherjee, Consultant Radiologist at Deben Mahato Government Medical College and Hospital, Purulia. And to present us on weird thyroid function test, that is abnormal ones. What to do when you get a thyroid function test looks abnormal. We have Dr. Khushbu Agarwal, who has traveled all the way from Christian Medical College, Vellore. Khushbu is Assistant Professor in the Department of Endocrinology at CMC Vellore. She'll take us through weird thyroid function tests. Thank you.
So, good afternoon all. At the outset, I would like to thank Dr. Pankaj and his wonderful wife for a very nice hospitality, and I have had great fun for the last 2 days that I've been here. And my topic is interpretation of weird thyroid function test. So what is weird? So before we discuss what is weird, let's go back to the regulation of thyroid hormone synthesis. So we know that the thyroid gland is under control by pituitary, which is under control by hypothalamus. So hypothalamus secretes TRH, which again stimulates the pituitary to have action on the thyroid gland, which secretes the hormone, and these hormones in turn have a negative impact on these glands. So this is how normal gland functions. So a person is considered euthyroid when you have normal TSH and you have normal T4 hormones. So these are the various permutations and combinations that we really see in our practice day to day. So most common is primary hypothyroid when you have high TSH with low T4 hormone, or primary hyperthyroid, that is low TSH with high thyroxine levels. Sometimes you can have secondary hypothyroid, so this is low TSH with low T4, or you can have secondary hyperthyroid, that's very rare with high TSH and high T4. We'll be discussing few cases of that. And then you have subclinical cases where the T4 hormones are normal, but TSH can be low or high. And then you have non-thyroidal illness. We'll be discussing this one in detail, or if the patient is on thyroxine for some other reason. So just to summarize, this is how we evaluate a patient of thyroid disorder. Whether when the TSH is high, with low T4 it is called hypothyroidism, and when the TSH is low with high values, this is called hyperthyroidism. To discuss why the weird thyroid functions sometimes appear, you really need to understand that small changes in FT4 can actually lead to marked excursions in TSH and over a short period of time. So that's the reason why sometimes the TSH can be up and down. So I understand that in a resource constrained setting, TSH is sometimes the only test that we do, but it can actually lead to missing of certain other cases of hypothyroidism, very specifically central hypothyroidism. If the patient had recent treatment of thyrotoxicosis, I think it was discussed in morning's presentation, if the patient is having resistance to thyroid hormone, or if the patient is having a TSH secreting pituitary adenoma. In addition to that, TSH, while it's a very common test, it's not without its faults. So there can be pre-lab pitfalls, laboratory pitfalls, and post-lab pitfalls. So when the test is ordered without any clinical context, so we may miss the pregnancy changes, if the patient is on thyroxine, if confounding medication is present, if the patient is having non-thyroidal illness, if the assay limitations are not analyzed properly, in the cases of heterophile antibodies or other antibodies. And if we don't know, or we have missed a rare genetic disorder such as resistance to thyroid hormones or a TSH-OMA. So my first case is a 61-year-old male. He is in ICU. He's diabetic for last 5 years, and he had a TFT done with a TSH of 0.2 and FT3 of 0.3 nanogram per ml. So he is having low TSH and low FT4. So this is a case of sick thyroid syndrome. It's a relatively common finding. So I would ask you guys not to do the TSH test in the setting of ICU unless and until absolutely mandated. There is no problem with the HPT axis. This is actually body's own mechanism. And thyroid hormone replacement is usually not needed, and TSH is rarely very, very low. So why does this happen? Because there is decreased D1 and D2 activity and augmented D3 activity, which results in higher level of reverse T3 being produced, and because RT3 clearance is reduced, and so T3 levels are reduced in the body. So at the level of cells, the metabolism comes down. So this is body's defense mechanism actually. Doesn't require treatment. Thyroxine replacement doesn't have any mortality benefit in these cases. So up to 20% of hospitalized patients and up to 50% of patients in ICU can have low T4, and it is because of reduction in thyroid binding globulin, transthyretin and or albumin, and you have to be careful in treatment. Some of the analytical considerations you have to consider are antibody interference, macro TSH, cross reactivity and platform variability. So this brings me to the second patient, very common again. You have a patient with history of hair fall. She has gone to a normal doctor, normal physician. They have given biotin without testing for thyroid hormone, and she was then evaluated for possible causes of hair fall and found to have markedly elevated TFT. Background history revealed that she was on biotin. So she was previously normal and she had no clinical features of thyroid toxicosis. B12 was also more than 1400 picogram per ml. So suggesting that this is probably not, this is probably an assay interference. Biotin is an assay water soluble vitamin. So single test can result in very high variations, and multiple mechanisms are present. Streptavidin, aggregose column and niobutinated assays are now available, but the simplest thing to do is to stop biotin for a day and then retest. That is enough. So this is how this assay actually interferes. This is a very nice presentation. So it's a sandwich assay, and that is why it results in falsely decreased value of TSH as well as falsely increased value of T4 or even TRAB. So patients without any hyperthyroidism profile can sometimes be mistakenly called hyperthyroid because of this. So then we stop the patient biotin for 24 hours, and after repeat evaluation, the values were found to be normal. And there are multiple other antibodies that can cause this. This is a patient who had mouse antibodies that were positive, which resulted in wide fluctuations of her TSH values, and any escalation of her dose resulted in hospitalization with tachycardia. So this is one case. The second patient which we had a problem was, this patient was 56 years old, and total T3 was reported to be very high on 2 different assays, and he was ultimately diagnosed to have multiple myeloma, and the assay interference was because of paraprotein immunoglobulin. Now they are very, very rare cases, so if your clinical context doesn't match the patient, go back and maybe repeat the test or maybe evaluate for other causes. So the incidence is somewhere around 0.05 to 6%, and human anti-mouse antibodies or heterophile antibodies or immunoglobulins can cause false elevations of TSH, and it often leads to unnecessary treatment. So other antibodies are patients with rheumatoid arthritis, paraprotein related biotin. There are some rare genetic causes which are also associated with these false elevations. So what is the solution? Simplest solution, repeat the test with a different assay. You can use blocking reagents in your lone lab, or you can do serial dilutions to reduce the impact of the antibodies, and you can use kits to detect these heterophile antibodies if the patient is, if that is also available for you. So this is an interesting patient. Again, you get multiple calls like this from ICU. So this is a 77-year-old patient who had a fracture, was in ICU. Because of a fracture, this lady was on heparin, and her FT4 was 35 picomole per ml, and it resulted in high FT4 because of heparin. So is the solution to stop heparin? Obviously not. She is a patient of femur fracture. So the best thing is to ask the sample to be, because when you use low molecular weight heparin, their half-life is 12 hours. So what you can do is maybe ask them to skip the morning dose, take your sample, and maybe right after that dose you can ask for the sample again. That's the simplest way to go about it before you go looking for a cause or treating that patient. And I would especially want to tell the physicians when we go into ICU, we look at the medications, we look at this because she's a young, she is a patient who had atrial fibrillation, she had a tachycardia, so it's very easy to make the diagnosis of thyrotoxicosis in this patient. So you please go back, look at the medications, maybe ask for a repeat sample. So multiple drugs have interference with thyroid function, then lithium, amiodarone, SSRIs, estrogens, somatostatin analogs. Then you have drugs that interfere with thyroxine absorption. Then you have drugs which interfere with uptake via deiodinases or inhibition of T4 to T3. And then you have drugs that interfere with thyroxine action. Not all of them need to be stopped, but you have to take a call in case your thyroid function test is not matching your clinical profile. This is another patient. So this is a 69-year-old lady. She was following up for a thyroid study, and she had a TSH of 5.4 with mildly high free T4. She had TPO antibody positive, ECG at atrial fibrillation present. So what's the diagnosis? So TSH high with T4 high. So in these cases, once you've ruled out other causes, you're probably dealing with a TSHoma or resistance to thyroid hormone. They are very, very rare diagnoses. Please rule out other causes before we think of this. So resistance to thyroid hormone, you will have a family history present. Now, they have hypothyroid symptoms at the level of the body, but they have hyperthyroid symptoms at the level of cardiovascular. So they may have tachycardia, they may have hyperkinetic behavior, they may have goiter, emotional disturbances, and recurrent ear or throat infections. T3 has been found to be some beneficial in these patients. TSHoma, again, a very, very rare diagnosis. They are microadenomas usually. They come with invasive features. Goiter may or may not be present. And suppression, you may have, depending on the size of the tumor, other anterior pituitary hormones may be involved. So how to differentiate? Clinically, TSHoma may give you a history of pituitary, other signs of pituitary tumor like visual field disturbances, headache. With resistance to thyroid hormone, family history is the most common clue that you are likely to find. Otherwise, what you can actually do is you can either do a TRH stimulation test or a T3 suppression test. So TRH stimulation test, because it will not work in a TSHoma. So when 200 microgram of TRH is given and the sample, you see the sampling for TSH at 0, 20 and 60 minutes, RTH will have an exaggerated response while TSH will not have a TSHoma will not have a response. Similarly, T3 suppression test will not result in any suppression of TSH and TSHoma. It basically works in endocrine. Everything is, you look at the suppression mechanism and the stimulation mechanisms to understand. So, okay, my last case, I'm sorry, this is the, second last case. This is, okay, this is not that interesting. I wanted to discuss this patient first. So this is a patient who is clearly hypothyroid. How come the TSH is only 6? So, yeah, so this is something that you have to understand. So there's something called hook effect, which is very, very common. And in case you strongly suspect high dose hook effect, you please repeat the test in dilution, and we found the TSH to be 346 micro international units per ml in this patient, which resulted in the diagnosis of hypothyroidism. So to conclude, assess the patient clinically, review the medications, and don't test in a critical illness time. And always correlate your reports with the patient, and in case you have a doubt, reach out to a person, Dr. Pankaj, for further evaluation. Context is always the key. Don't treat the numbers for hypothyroidism. Thank you.
Thank you, Dr. Khushbu. And are there any questions regarding any difficult thyroid function test that you have faced?
Thanks, madam. A good presentation indeed. Any question from audience? Any comments, sir?
Sir.
I don't know whether you agree, though it's generally recommended the first test you do is a TSH. I personally feel that we should do a T4 or free T4 and a TSH together in order to interpret the values better. Of course, you can go back after looking at the TSH, but that harasses the patient more. I thought the extra cost that's involved is worth it, doing the two together, despite the general recommendation that you should do only TSH and then the other tests.
Actually, it does happen that we often get referrals with abnormal TSH values, and then it is sometimes questionable when we ask the patient to do another test rather than just treat the report they've come. Sometimes they come with a T3, T4 TSH. We ask for an FT4, but it is justified in asking them to do those tests. Especially patients like those patients who come with gestational thyrotoxicosis just with a suppressed TSH. No T4, no FT4, and then we sometimes have to find out whether we are dealing with a true case of Graves' disease or just gestational thyrotoxicosis based on that TSH of 0.01.
I've actually had a case who was treated because of TSH of 0.01 and FT4 was normal, and that girl was treated for more than 6 months with carbimazole with a normal FT4. So it's in these cases it's so much more worth maybe angering the patient maybe for one more test. So TSH alone is not a good test to be done.
We've seen so many patients being treated only with a TSH of 0.1 or 0.01. Thank you, Dr. Khushbu, and thank you, chairpersons, for that wonderful session on thyroid function test, a day-to-day affair, to the photo booth. And this brings us to the inauguration for this Purulia Obesity Diabetes Endocrinology Conference 2025. For the inauguration ceremony, I would like to request on stage Professor Sabyasachi Das, Principal Deven Mahato Government Medical College and Hospital, Purulia. Sir has always been extremely supportive and he is always at a call away. Dr. Manojit Mandal, President IMA Purulia branch. Dr. Akash Panigrahi, organizing chairperson for this Podecon 2025. And Shubhankar Chaudhary, sir, Professor Shubhankar Chaudhary, a teacher of teachers and the endocrinologist that we have learned endocrinology from for the inauguration ceremony. Along with this, though busy, I would like to also request this program, as you know, is being done under the aegis of a not-for-profit organization, the Healthcare Foundation of Purulia, which we floated 2 years back for organizing various academic, non-academic, educational awareness programs in Purulia. And Dr. Priya Singhania happens to be the president of the Healthcare Foundation of Purulia. So I'd like to request Dr. Priya Singhania also on stage along with the dignitaries. To begin with, I'd like to request all dignitaries to please light the lamp and declare the conference open.
या कुन्देन्दु तुषारहा या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
To invite on mic Professor Sabyasachi Das, Principal Purulia Medical College, our guardian of medical education in the district, to address the gathering. The welcome note, please. The welcome address.
Good afternoon. On behalf of Podecon, it's my privilege to welcome all of you, particularly the stalwarts of this field, who repeatedly come to our call, and it's a great privilege from all of us. আমার বক্তব্যের শুরু আর শেষ দুটোই পঙ্কজ সিংহানিয়া হবে। তো এটা শুনতে না চাইলে আপনারা অন্য কিছু ভাবুন। তো পঙ্কজ অবভিয়াসলি আমার অনেক জুনিয়র, উই আর ফ্রম সেম ইনস্টিটিউট, কিন্তু ওর এখানে কর্মকাণ্ড যেভাবে ছড়িয়েছে বা অল্প দিনের মধ্যে, সেটা যারা পাশ থেকে দেখেছে তারা না বললে বিশ্বাস করা যায় না। ওর অর্গানাইজেশন স্কিল আমাদের সবাই জানেন যে এই অল্প সময়ের মধ্যে 3টে ভালো সিএমই ও অর্গানাইজ করেছে। প্রতি শনিবার ও আইএমএ স্পন্সার্ড একটা একাডেমিক কারিকুলাম করেছে এবং সে রেগুলার সেখানে অ্যাক্টিভ পার্ট নেয়। তারপরে ও গ্রামে গ্রামে গিয়ে আউটরিচ এরিয়াতে গিয়ে ওদের অ্যাওয়ারনেস ডেভেলপ করে। রোববার দিন ওর চেম্বার বন্ধ থাকে সেদিন। এছাড়া যেমন ধরুন পুলিশ একাডেমিতে যারা আছে পুলিশের লোক, তাদের একবার 600 জন তারা ইনভেস্টিগেশন এবং ক্লিনিক্যাল এক্সামিনেশন এই ধরনের বা পদযাত্রা, ডায়াবেটিস ডে পালন করা এবং সমাজের সব লেভেলের লোককে একসাথে নিয়ে। তো এটা আমার কাছে খুব বিরাট কাজ বলেই মনে হয়েছে। আর আরেকটা হয়তো একটু ভালো খবর দিতে পারবো যে সম্ভবত ওকে আমরা কিছুদিনের মধ্যেই অ্যাসিস্ট্যান্ট প্রফেসর মেডিসিন করে পুরুলিয়ায় আনতে পারব। এটা আর সময়ের অপেক্ষা। এবং আমি জানি যে প্রতিটি লোক বেনিফিটেড হবে। এই মুহূর্তে ওর এমনিতে যারা পিজি স্টুডেন্ট আছে আমাদের দেবেন মাহাতো গভর্নমেন্ট মেডিকেল কলেজে, তারা ওর সাথে থাকে, পড়াশুনো করে, এবং সেইটা আরও বেশি ভালো হবে যদি ওকে আমরা অ্যাসিস্ট্যান্ট প্রফেসর মেডিসিন করে পাই। ব্যাস এইটুকুই বলার ছিল। এছাড়া ওর ওয়াইফ ডক্টর প্রিয়া অসম্ভব হেল্পফুল, এবং প্রত্যেকটা ইভেন্ট ওর পাশে থেকে সেইগুলোকে সাকসেসফুল করে। তো আশা করি আপনাদের এতক্ষণ প্রোগ্রাম ভালো লেগেছে, এবং বাকি যেটুকু আছে নিশ্চয়ই আপনাদের ভালো লাগবে। থ্যাংক ইউ।
Thank you, sir, for those kind words. We have instituted a Lifetime Achievement Award on behalf of the Healthcare Foundation of Purulia to felicitate senior exemplary physicians of this soil. And today we are happy to be conferring the Lifetime Achievement Award to popularly known as Dr. Maharaj. Also, his original name is Dr. Swami Niravananda Maharaj. I'd like to request President IMA Purulia to read out this citation to honor.
This is the Lifetime Achievement Award to Swami Nirmanananda, popularly known as Dr. Maharaj. He is one of the senior physicians, a sadhu and an adherent clinician for his exemplary selfless service to the sick and allying over more than 5 decades. We wish him a healthy life ahead. We are privileged, sir, to honor you.
This year we've also decided to institute 2 awards to be given to healthcare institutions of the district who have been providing continuous medical care at an affordable price. We do not have many institutions in this district, both private and public. So 2 awards are being instituted this year. The Healthcare Excellence Award, the first award, there are 2 awards. The first award is being given to Lokesharananda Eye Foundation, Pada, Borandanga Pada. We all know it as Pada Eye Hospital. It's Lokesharananda Eye Foundation. And I'd request the representatives, the Dr. Saab and his colleague, to please come on stage to receive the award on behalf of Lokesharananda Eye Foundation, Pada, the Healthcare Excellence Award on behalf of Healthcare Foundation of Purulia. The citation reads, Healthcare Foundation of Purulia on this Podecon 2025 proudly presents the Excellence in Healthcare Award to Lokesharananda Eye Hospital, Pada, for lighting up the lives of thousands of people of Purulia and bringing eye care within the reach of the poorest of the poor. 14 December 2025. Ladies and gentlemen, the Healthcare Excellence Award. Thank you, sir. Thank you so much. The second and another Healthcare Excellence Award this year is being instituted to Rameshwar Lal Singhania Seva Pratishthan, also popularly known as Singhania Hospital. It's my birthplace, so I proudly present this award to the trustees of Singhania Hospital or Rameshwar Lal Singhania Seva Pratishthan, Mr. Rohit Singhania and Mr. Akash Singhania. The citation reads, Healthcare Foundation of Purulia on this Podecon 2025 proudly present the Excellence in Healthcare Award to Rameshwar Lal Singhania Seva Pratishthan. Many of us over here have been there, we work there on a daily basis, for serving the people of Purulia for over 4 decades. Your contributions in shaping the health landscape of Purulia will be ever etched in the history of this place, 14 December 2025. Ladies and gentlemen, put your hands together. Thank you so much. We had a wonderful PGT paper presentation today morning, and I was very proud when faculty and endocrinologists from far and wide praised the paper presentation to our naive PGTs. They are DNB PGTs working in a very, very resource constrained setting, and 3 of them presented wonderful papers today morning. We had to decide one winner for the paper presentation, and it was a consensus among the 3 judges who decided that the best paper presentation this morning goes to Dr. Nihal Ade. Dr. Nihal, please on stage. And this paper presentation, this prize carries a certificate and a cash prize also. Professor Shubhankar Chaudhary sir, to please felicitate this young physician from Purulia. Thank you, Nihal. And the others also did excellently well, Dr. Ramamurthy and Dr. Dharmendra. We just had to select one winner. That does not mean you aren't winners. Everyone is a winner. And before we end this session, I would like to, I think I have my son around. Is he? He has a poem for endocrinologists, a poetry for endocrinologists. And let's see whether he tells we are good or we are bad or we're just okay. Siddhant Singhania, he'll be reciting a small poetry on, and it's in Hindi for people who appreciate Hindi. Siddhant.
शरीर के अंदर रोज मीटिंग होती है, हर हार्मोन अपनी दुख भरी रिपोर्ट लाता है, एंडोक्रिनोलॉजी वाले बाहर खड़े सब ड्रामा बड़ी शांति से लिखते जाते हैं, कभी ग्लूकोज रास्ता बदलता तो इंसुलिन गुस्से में कहता मेरी भी तो लिमिट है, डायबिटीज़ वाले मुस्कुरा कर कहते मैं तो बस मीठे से आई थी, तुम सब ने मामला बिगाड़ा, ओबेसिटी तिरछी नज़र से कहती मैं धीरे आती हूँ पर हटती मुश्किल से, मान लो डॉक्टर सब सुनकर बस अपना बीपी चेक करते रह जाता है, मरीज़ एक हाथ में दवाई और दूसरे हाथ में डाइट चार्ट लेकर परेशान फिरता है, सब मिलकर शरीर को समझाते थोड़ा संयम रखो, कम ड्रामा करो, शरीर मुस्कुरा कर कहता कोशिश करता हूँ पर मूड पर डिपेंड करता है, और बस यही निष्कर्ष निकलता एक विज्ञान, अनुशासन और थोड़ी कॉमेडी तीनों साथ हो तो यात्रा आसान हो जाती, बाकी काम हम और आप मिलकर संभाल लेंगे। धन्यवाद।
Thank you, Siddhant, for putting endocrinology into poetry. And that is the MSVP of Purulia Medical College, Sukumal Bishoy sir, congratulating. Thank you, sir. Thank you. I take this opportunity to thank Healthcare Foundation of Purulia, its members, all its members, both executive and non-executive, Indian Medical Association, President, Secretary, all members, all the faculty who have traveled from far and wide, delegates who have taken this pain getting up early on this winter morning and making it to this wonderful place, Kushal Palli, the venue, and Shudiptoda in particular, who is the CEO or all in all of this place. Our sponsors from the industry, without whose support and active support this wouldn't have been possible. Our printers for bringing this wonderful mementos, gifts. My team at Arogyam Healthcare, Mr. Sandeep Sharma, who happens to be my right hand, Tayyab Ali, Hemanto, and everyone else over there. My family, my mother, father, my son, and Almighty God above, for bringing us together and helping us shape this program. And the audio-visual team also. I'm really surprised by their wonderful doing. Last time we had a lot of glitches with the audio-visual, but they've done a wonderful job. We now break for lunch and assemble at 2 p.m. sharp. Lunch is right behind you. And we have some very wonderful sessions lined up immediately after lunch. And please, all delegates who have registered and signed, do not forget to take their WBMC credit hour certificates. Delegates as well as chairpersons, the signing of the WBMC credit hour certificates will begin after 3 p.m. Thank you. Have a wonderful lunch. We have lined up some Santhal cuisine for you, and see you again at 2 p.m. right here. Thank you so much.
ওই আরে কারো কারো ফোন ফোন লাগেনি
Individual's homeostatic state point, which is determined by the diet-induced thermogenesis and non-exercise activity thermogenesis. So this is a simplified view of the homeostatic energy system and its inputs and outputs, and this funny cartoon represent when the stomach is empty, the ghrelin is secreted, it acts through the paraventricular nucleus of hypothalamus to lead to a food-seeking behavior. And on the other end, when our stomach is full, the GLP-1, insulin and CCK through PMC and PVN leads to the satiety. So coming back to the case, why is that the TSH elevation was there? Because obesity leads to increased leptin, which stimulates centrally the transcription of TRH, and a consequent increase in TSH and therefore T3 could be interpreted as a defense mechanism of the body against the weight gain. And obese children, usually simple obesity, are usually taller, and when short stature in an obese child actually suggests a pathological cause. So a quick through the evaluation, we have on one side is exogenous obesity, on the other side is endogenous obesity. The endogenous obesity could be from monogenic causes, from genetic syndromes, and from endocrine causes. So first to simple obesity, the most common cause of childhood obesity in outpatient departments, that is diagnosed on history and examination. Normally they are slightly tall stature, they are developmentally normal with no dysmorphism, but may have family history of diabetes and obesity, and we could identify some modifiable factors in their lifestyle that leads to obesity. And there are host factors and environmental factors which determines the nutritional obesity, and there is a crucial role of nutrition, especially the first 1,000 days of a child's life. These are the risk factors across different stages, from maternal exposure to infancy to childhood and adolescence, which can lead to obesity. So what are the pointers which alerts us that some pathological causes may be there? One is discordant growth, as rapid weight gain and faltering in height, disproportionate fat distribution, presence of dysmorphic features, and developmental delay. And of course, if we do a hand radiograph, we will get a delayed bone age. So these are the points we should take during history taking, what is important are the red alerts, which prompts us that probably we are dealing with a case of pathological obesity. That is a very early onset, below 6 months of age, rapid progression, presence of developmental delay or the seizures, neurodevelopmental deficits, hypotonia, and hyperphagia. So on examination, these are the points one should note while examining a obese child. And here also there are some red alerts like growth discordance, presence of delayed or precocious puberty, presence of dysmorphism, Cushingoid features, undescended testes or the AHO phenotype. These are the red alerts on examination. So depending on these red flags in history and examination, we may have some idea what could be the possible etiology of this this obese child. So to simplify the approach, if there is a very early onset obesity, then probably we are dealing with a monogenic causes. If no, then check for a growth failure. If there is growth failure, to look for the dysmorphic features and cognitive delay. If present, probably we are dealing with some genetic syndromes. If no, the majority of the causes will be endocrine causes, and if initially there is no growth failure, the probable causes will be PCOS or a post-pubertal hypothyroidism, and of course hypothalamic obesity should be considered. So we can differentiate between a monogenic and syndromic obesity with these points. Like if the age is less than 5 years, presence of congenital abnormalities, history of developmental delay and multi-system involvement points towards an underlying syndromic etiology. And the red flags in history or examination may also guide us for the probable etiology of monogenic non-syndromic obesity. So coming to case number 2, a 13-year-old boy with a severe obesity, complication screening showing fasting hyperglycemia, elevated triglyceride and transaminitis. So this child 2 months later presented with morning in the limb and left hip pain, so he diagnosed with a slipped capital femoral epiphysis requiring an orthopedic referral. So while in investigations the important points are on thyroid function test, often the result, it will be the result instead of the cause of obesity. And regarding insulin level, it is not indicated even with the clinical features of insulin resistance. And for pathological obesity, one may require to check for calcium, phosphorus and ALP if HO habitus is there, a MRI of brain, and of course last but not least a clinical exome or the mutation study. And while interpreting the lipid parameters, one should check the pediatric thresholds regarding acceptable borderline and high lipid parameters. And as that boy is having a slipped capital femoral epiphysis, the symptoms may guide us that what comorbid conditions it could be. And presence of these parameters should prompt us to screen for metabolic syndrome, and in this context, one may use the IDF definition of metabolic syndrome in children. Coming to the last part, management, both dietary and lifestyle important, but what is most important is the compliance and monitoring. For weight related goals, 2 important points are weight maintenance is the key, and slow and gradual weight loss should be attempted. So regarding medical nutrition therapy, important points being reduction in sugar sweetened beverages. The child should avoid skipping breakfast. On this side, to reduce the sedentary behavior, at least 60 minutes of daily of moderate to vigorous physical activity. And regarding screen time, above 5 years it should be parent monitored. Up to 2 to 5 years should not be more than 1 hour. Last case is a 14-year-old boy to endo clinic against the severe class 3 obesity. It failed to reduce the weight. What could be our plan of action? So for pharmacological treatment, there is no standard pharmacological treatment. So again, the cornerstone is lifestyle management. The only approved drug is Orlistat for use in more than 12 years of old, limited by the bothersome side effects. Remember, metformin is not indicated for obesity. It is approved for use in type 2 diabetes with insulin resistance. And of course, last but not least, we should treat the comorbidities. There are many options, but regarding the pediatric use, Orlistat, we have GLP-1 receptor agonist like exenatide or liraglutide, and most recently semaglutide has been approved for obesity in children and adolescents 12 years or more. And this MC4R agonist, these are for specific etiologies like monogenic obesities, and other drugs are mostly not well studied in pediatric populations. And for pediatric metabolic surgery, there are specific criteria set there. So for prevention of obesity, on one side, we should avoid consumption of junk foods. On another side, important is growth, physical activity, as well as the nutrition, which I have already mentioned. The first 1,000 days of a child's life is important, including maternal nutrition. So for prevention, we need community-based intervention, including diet and physical activity. One should note the recommended sleep durations as laid down by AAP. So the rule of 5-2-1-0 is important. So 5 or more fruits and vegetables, 2 hours or less of recreational screen time, 1 hour or more of physical activity, and 0 sugary drinks. The best beverage being the water. That should be followed, 5-2-1-0 rule. So the key takeaways. Obesity goes beyond BMI. It is not only the increase in weight, probably it is the increase in body fat that is more important. So it's beyond BMI. And pearls towards etiological diagnosis should be borne in mind, what we have discussed. Organic causes of obesity account for a minority of cases, that is usually less than 10% in various series. Behavioral modification by means of motivational interviewing and intensive lifestyle behavior therapy remains the cornerstone of management. Pharmacotherapeutic options are limited for children. Most drugs are not approved, and no drug approved for age less than 10 years. And bariatric and metabolic surgery is a viable treatment modality if the defined criteria are met. So, thank you for patient hearing.
Not in India. So, Amitabh, I don't think it's approved in India. Semaglutide is not approved below 18 years in India for any indication whatsoever. So practically in terms of drugs, probably we only have Orlistat.
Orlistat, only Orlistat.
Above 12 years of age. If there are no questions, thank you, Sayantan. Dr. Sayantan Rai, please come to the felicitation area. Moving on quickly to the next session, chairpersons, please, which will be on young hypertension, from obesity to hypertension. They are sisters in a crime. Dr. Shubham Pal is the chairperson for this session. Dr. Shubham Pal, medical officer at Masgod Medical College. Dr. Shudipa Banerjee. She is the medical superintendent of Raghunathpur Super Speciality Hospital, comes under Purulia district. And Professor Sabyasachi Das, We all know him. He, professor and principal, Purulia Deben Mahato Government Medical College and Hospital. To deliberate on this, we have none other than one of my mentors and favorite seniors, Dr. Rana Bhattacharya. Sir is currently associate professor at Medical College Department of Endocrinology, and we'll be talking about type 2 diabetes in young specifically. It's now a pandemic, and sir will tell us why.
Thank you, Pankaj. A very good afternoon to all of you. So I will discuss briefly regarding the management of type 2 diabetes. I will focus on children and adolescents because this is, I feel, is a bit less discussed topic, and there are some confusions regarding approvals and use of different drugs. So the first thing is that when we say that a particular patient or a child or adolescent has type 2 diabetes, we should ask ourselves whether it is really type 2 diabetes, because there is a lot of overlap between other forms of diabetes like type 1 or monogenic diabetes. Like all of those can present in childhood, can have some family history, can present with ketosis. Even type 2 diabetes can present with ketosis. So this is not an absolute criteria for type 1 diabetes. So there are many overlaps. Even with antibodies also there can be some confusion, because some type 2 diabetes young individual can have anti-GAT65 positivity. So we have to diagnose first. Sometimes what we do for all practical purpose, we treat the patient, let the patient stabilize, and then we decide about the subdivision of type of diabetes, and then we treat accordingly. So this is one of the registry from northern India mainly, which shows that type 2 diabetes is young. The proportion is quite high now. And we also looked at our data in IPGMIA few years back. Again, type 2 diabetes and type 1 diabetes, the numbers are almost similar when you consider age less than 30 years. Now, what's the difference between type 2 in adults and adolescents? Are they kind of just an age difference, or there are some other difference as well? Well, it has been seen that in childhood and adolescent diabetes, there is rapid progression of beta cell function decline. So this is in contrast to most of the adult type 2 diabetes patient, and therefore they are rapidly progressive. Sometimes the complications, they usually tend to appear early in young onset diabetes. And of course, the treatment durability with a particular drug seems to be a bit lower. That is, OAD failure is more common with young onset type 2 diabetes, and there are some approval status regarding the confusion status regarding the approval of different anti-diabetic drugs across different countries. So I won't go into this rising prevalence. How young onset type 2 diabetes present? Most of the young type 2 diabetes present in an asymptomatic condition, and there are some typical symptoms as well in about half, like typical osmotic symptoms, mainly weight loss, polyuria, nocturia, and polyphagia. However, as I was saying, that around 5% of type 2 diabetes in young can present with DKA. So after treating for DKA, please re-evaluate the patient for type 2 diabetes. Coming to treatment, what is the goal? Just like adults, for most young individuals, A1C target of less than 7% is reasonable, and in some appropriate situation, we can target as low as 6.5%. Of course, we should identify and treat hypertension and dyslipidemia. Those are not extremely uncommon in childhood and adolescence. This is very important. We often tend to ignore this in that age group. And of course, the vascular complication, as I was saying, is even higher if we compare the duration of diabetes between young onset and adult onset type 2 diabetes. Regarding non-pharmacologic therapy, I won't go into detail because Shayantan has just now discussed the lifestyle changes in obesity. It's broadly similar. So I'll skip that part. Now, regarding the approval in India, this is, I mean, the approval status, if you look at the statements there, unlike FDA or EMA, there is no clear-cut statement regarding a particular drug. It's very difficult to find. So we have to rely partially on FDA. And clearly the FDA says the approved drug include metformin, some GLP-1 receptor agonist, some SGLT2 inhibitor, and of course insulin. Insulin is approved more or less across the board in adolescents, but in children there is some variation, although many a time we tend to ignore it, and sometimes we rather have to ignore it because of cost and other practical issues. Metformin is a first-line therapy in most of the individuals. It's a approved, as I said, typically in just like adults, we start with 500 and the maximal dose is 2 grams per day. And standard contraindications of metformin is just like adults, so I am going to detail of that. There are some clinical trials with metformin as well. I won't go into detail again for want of time. Second, insulin. It's very important, particularly in presence of decay. And when the blood glucose level is very high, we often tend to start with insulin along with OADs. If A1C is very high, then again we may start with insulin. Very importantly, as I was saying, that if we are unsure about diagnosis, whether it's type 1 or type 2 or some other type of diabetes like MODY or some pancreatic form in young, we often start with insulin to be on safer side. And then we shift to oral drugs only if we feel the patient is having type 2 diabetes. And of course, presence of severe infection, any other severe illness, we give insulin. Now, if we look at the approval status of different analogs, degludec is approved beyond 1 year of age, detemir beyond 2 years, and glargine beyond 6 years. However, we often ignore these rules, particularly say if a very young, say neonatal diabetes present with you and in your hospital, glargine is the only available long-acting insulin. Despite we know this is not approved, we often have to use it. So this is the practical part of it. For rapid-acting analogs, aspart more than 2 years, lispro more than 3 years, and gluricin more than 4 years. Rapid-acting or rather I should say ultra-rapid acting versions of aspart and lispro, again more than 2 years and 1 year for fiasp and liumjeb respectively. Regarding sulfonylureas, it is not approved, but sometimes we do use it in children, in adolescents, mainly off-level. Problem we all know regarding some weight gain and hypoglycemia. Coming to SGLT2 inhibitors. There is a study of SGLT2 inhibitors in type 2 diabetes children and adolescents aged between 10 and 17 with a 25 milligram of empagliflozin and 10 milligram of epagliflozin vis-a-vis placebo, and it has been seen that there is improvement there. And in this particular study, linagliptin was also tested in this age group, which has been found to be of no benefit. And therefore, empagliflozin has been approved in young onset type 2 diabetes beyond 10 years, not linagliptin. There is a data with dapagliflozin as well. However, it was found to be not effective. Why there is a difference, we do not know yet, but the data that is available to us, it says this. So therefore, we use empagliflozin, young onset diabetes, type 2 diabetes, not dapagliflozin, not DPP4 inhibitors like linagliptin. So this is FDA approved as well. No clear approval status in India. Regarding GLP-1 receptor agonist, there is a study with liraglutide and dulaglutide. Both are approved. Semaglutide is approved for obesity by FDA. However, it's not approved for diabetes. This is important. So this is approved for obesity beyond 12 years by FDA. Again, in India, there is no clear-cut approval status. And that is true with many of the drugs that we use. That's the problem. Now, if we look at briefly at the guideline or flowchart, it's quite similar. I won't go into detail. Metformin is the mainstay, as I've said, and then we'll use other drugs. But if the patient is antibody positive to begin with, which ADA recommend to do in all patients in young onset diabetes, again for cost conference, we may not go for it, but please remember, even if a patient is having typical type 2 diabetes features, but antibody positive, even if you give oral drugs, please monitor very closely because they tend to have a quick beta cell failure. So something like LADY like presentation. A case, an 11-year-old boy with typical osmotic symptoms, given lifestyle changes with sulfonylurea, metformin and insulin glargine. After 1 month, blood glucose get well controlled. C-peptide was positive, preserved, and he was continued with metformin only, was doing well for 2 years. Now, beyond glycemic control, he also, I have said, has to look for CVD risk because these patients later in life has a very high CVD risk. So there are studies looking at CVD risk of this patient which showed that that is much higher than the non-diabetic individuals. Again, I won't go into detail of this complicated charts, just I will highlight few of the important points. If there is dyslipidemia, type 2 diabetes is considered as a moderate risk by itself. But if there is some additional factors, like if there is some dyslipidemia, if there is some hypertension, if the BMI is high, all those things make the patient or shift the patient to the high risk. So for all practical purpose, all young onset diabetes particularly have a high risk for CVD. So they are in the tier 1 category. And what is the target for tier 1? Keeping LDL less than 100. For that, we'll try with lifestyle changes. But if that fail, particularly if it is more than 130, we should start with statin with a target of less than 100. There was a fear regarding statin use in adolescents, but now it can be used. This is by both ADA as well as by American Heart Association. There are a few words regarding prevention. There are controlled trials in this age group, particularly those with obesity for progression towards diabetes. And it has been shown that lifestyle changes is extremely effective. So whatever Shantan has discussed regarding lifestyle changes in obese individual, it helps a lot in this particular aspect. To summarize, type 2 diabetes in children and adolescents is increasing rapidly. It's all over the world and particularly so in our country. Key risk factors include obesity, positive family history, female genders, there is a typo, low socioeconomic status and maternal diabetes. We should start screening at the age of 10 or at pubertal onset, whichever is earlier, and we should repeat every 3 years in these high-risk individuals. We should treat those individuals, as I've said, for most the goal is less than 7%. For others, glycemic goal is less than 6.5%. Lifestyle management is extremely important in this age group. So we should follow that and we should involve the family in this particular decision making and changes. Pharmacotherapy, I'll just summarize: metformin, EMPA, Lira, duraglutide and insulin. These are the approved drugs by FDA and regular monitoring is important. Thank you for your patience here. Thank you.
Hello. Thank you, Dr. Rana. Wonderful presentation.
Thank you, sir.
I have a small query. In young people, particularly I'm talking about those who are studying in 7, 8 or these people. Do we measure BMI as we measure in adults?
So the measurement of BMI, the technique is similar. However, we should put that value to the graph provided by IAP, which is freely available for the physicians. You can download it from the net, or if you have the chart printed, that's also okay. And there you should put that BMI and there is a percentile value. And as Shantan has just discussed, depending on that we'll discuss, we'll kind of mark this patient as obesity or overweight, depending on the percentile values.
Okay, okay. Thank you. Any question?
Yes, Divajan. Yes, extremely common. Yes, yes, definitely. We do. Whenever an obese child comes to us, we definitely screen for diabetes and dyslipidemia and hypertension. This is a routine. You must, because they come to us with weight, not with diabetes, not with others. So obesity, every children should be screened.
And liver function test also.
Yes, definitely. At least ALT, AST and platelet, yes. Hmm.
Below 30 people, age less than 30, and the C peptide is not very low.
Right.
All antibodies will you check?
See, it depends on the clinical phenotype. Okay. So in a young individual, C-peptide you usually do not less than 30, maybe less than 18. Less than 30, of course, you may, particularly if you are unsure about it, it's a type 2 diabetes, right? Like if the patient is lean, there is no acanthosis, family history of type 2 diabetes is not there. So there you have to remain very vigilant. And even in, I'm saying a patient around 30 years, they are also in the very beginning, after initial control of blood glucose, you can test for C-peptide. If the response is good, you can start OAD, or you can continue with OAD, whatever. But antibody again can be variable. Anti-GAT65 is less specific. But if multiple antibodies are positive, like ZNT8 which is available now and anti-IA2, definitely the patient has a very high risk of progression towards type 1 diabetes like feature, what we call LADY. It's a young counterpart of LADA. Okay?
I have a question.
Yes.
Sir, please. Being a public health person, I am asking from my field only.
Yes, very important here as well.
Yeah. It is a very important topic for present public health scenarios. But if you see, present public health programs, actually cutoff age is 30 and above. So if in the near future it will come in the public health programs, so what type of screening you suggest it should become, or how it will affect this next generation?
Absolutely. This is extremely important because if you go to any school now, you will see the obesity is rampant there. And type 2 diabetes, as I was showing the data from IPGMR, we had the data that's around 10, 12 years back. Now it has even worse. I mean, the proportion of type 2 diabetes is quite as high as type 1 diabetes now possibly, if not higher. So, of course, we should address that by modifying their diet and improving exercise in school as well as outside, which is also extreme. So government should definitely address that part as well.
Rana sir is available for discussion off stage. Sudeepa, Rana sir is available for discussion off stage. We have to move with the next session.
Not for long though. Thank you so much.
Thank you so much. A big round of applause for Dr. Rana Bhattacharya for the felicitation. Moving on to the next session, which will be chaired by Dr. Abhishek Maji, pediatrician from Raghunathpur Super Speciality Hospital, Dr. Asima Moi, Block Medical Officer of Health at Kolloli or Kashipur Block Primary Health Center, and Dr. Shubhankar Mukherjee, physician from Asansol. This will be about approach to short stature in children. That's another area in pediatric endocrinology. And to speak on that, we have one of my favorite juniors, Dr. Obronil. Obronil will be talking us quickly through approach to short stature in children and when to identify it as pathological and therefore refer to it for treatment. Obronil.
Thank you, everyone. And thanks once again to the organizers for inviting me. So let us straight go to the topic. So approach to short stature in children, I should start with some cases first. So our first case is a 14-year-old boy, height of less than 3rd percentile with a normal birth history. Systemic examination was normal. Puberty has just initiated. Routine investigations were normal as well as the thyroid function test. The growth chart showed that the midparental height was 150 centimeter, which is below the mean target height. And also the bone age is not very much delayed. It's almost normal, that is 13 years. IGF-1 is in the normal range, 176 nanogram per ml. Next, coming to a second case, which is again a 14-year-old boy. Again, the birth history is not significant. Now, in this case, the puberty has not initiated and there is similar history of family history of delayed puberty. Father also had history of delayed puberty. Routine investigation was normal. Thyroid function test was also normal. In this case, midparental height is in the normal range, that is 166 centimeter, but the bone age is delayed at 10 years and IGF is in the low normal range, that is 86 nanogram per ml. Our third case is a 6.5-year-old boy with history of poor height gain. He has a history of polyuria, polydipsia, and recurrent hypokalemic periodic paralytic ileus with a history of renal stone. On examination, genu valgum was noted, as well as bilateral wrist widening was there. So this is the X-ray pictures, which was suggestive of rachitic features and widening of the wrist. Bone age is delayed. IGF-1 is in the low range, that is 56 nanogram per ml, and potassium was in the low range. The fourth case is basically a 15-year-old, 10 months old child, and with a height SDS of minus 5.8, weight SDS of minus 3.09. So height age is more affected than the weight age. The puberty is delayed, testicular volume is only 2 ml, and bone age is also severely delayed at 8 years of age. So investigation revealed not only a low IGF-1, but the gonadotropins were also in the low range, and cortisol, the post-ACTH cortisol was normal, but there is evidence of secondary thyroid deficiency, that is TSH is inappropriately normal in the background of low FT4. Clonidal stimulation test was suggested and it showed a low growth hormone response. MRI HP axis showed a partially empty cella with a pituitary stalk interruption. I'll go to our final case, which is a 15-year-old female presented with short stature and primary amenorrhea, and the puberty is delayed. There is Tanner staging of B1 and characteristic phenotypic features of wide carrying angle with multiple nevi over the face, and short 4th-fifth metacarpal was found. Investigation showed high LH-FSH suggestive of primary gonadotropic deficiency, and with USG suggestive of small streak ovaries and uterus. And a thyroid function test showed a primary hypothyroidism. So how do we approach such cases? First, the definition of short stature, which is the, as we know that the height of a child follows the normal Gaussian distribution of a general population, and so the height less than minus 2 SD, that is for that age and sex, is defined as short stature. Severe short stature is defined as the height SDS of less than minus 3 SD. But the single, so coming to some of the common etiologies, it may, due to the affection of the growth hormone IGF-1 axis, or it may be outside the growth hormone IGF-1 axis. The growth hormone IGF-1 axis involves at the level of hypothalamus or at the level of pituitary. It may be congenital, some transcription factor defects, or it may be acquired due to some cellular supracellular masses. Or it may be due to the growth hormone may be adequate, but the growth hormone receptor or the subsequent signaling pathway may be at defect, so growth hormone insensitivity can also be a reason. Diseases outside growth hormone IGF-1 axis like systemic illnesses and malnutrition may also affect and cause a low IGF-1, like it may be a severe malnutrition, CLD, CKD, or any hemolytic anemias like thalassemia, sickle cell anemia can cause this thing. And also in 10% cases of small for gestational age, the child may not get the adequate catch-up growth. And lastly, it's the idiopathic short stature, which includes familial short stature and also the constitutional delay in growth and puberty, and intrinsic short stature where there is an inherent defect in the chondrocytes and the growth plate, like the syndromic short stature, namely the Turner syndrome, Prader-Willi syndrome, Down syndrome, etc., Noonan syndrome, etc. So how do we assess growth? Length up to the 2 years of age, thereafter the height. You have to be careful about the height measurement, that is at the level of Frankfurt blend. I am not going into the details of that. But rather, before going to a single height, it is a growth velocity which is more helpful, because if the height velocity falls below minus 2 SD over 2 years, then we can say that there is severe growth deceleration. And as you have to keep in mind that the prepubertal period, that is 3 years to puberty, the height velocity should be 5 centimeter per year, with a pubertal growth spurt in boys of 9.15 centimeter and in girls it is 8.3 centimeter. 3 important terminologies you have to keep in mind, that is the projected adult height and also the midparental height and the bone age. Projected adult height is the extrapolating the child's growth along the growth chart to the 18-year mark, and midparental height depends on the height of the father and the mother. The bone age is assessed by the Gruelich and Pyle method or the Tanner Whitehouse method, but currently the automated bone expert, the AI-based technologies are also available. So the most important part of the assessment is the use of growth charts. What we currently use a combined WHO IAP GOAT chart that is available for 0 to 18 years of age, which also includes mid-parental height and a quick assessment of BMI up to 8 to 18 years of age. So what do we see in growth charts is basically if the weight is more affected, it's more of suggestive the malnutrition and systemic illnesses. Now, if we see the height is more affected, then endocrine illnesses are more preferable. That is like growth hormone deficiencies. And next is if you see a pathological obesity, that means the weight age is more than the chronological age and height age is severely affected, then it's a more of the cause of Cushing syndrome, hypothyroidism, etc. So coming to some of the historical clues which will help us to cleanse the diagnosis, like if there is a history of severe intrauterine growth retardation, some drug intoxication or infection during pregnancy, it is more of suggestive of small for gestational age. If there is a family history of short stature, it is more of favor of idiopathic short stature or familial short stature. If the father has similar history of delayed puberty, then it is suggestive of constitutional delay in growth and puberty. And some of the features are suggestive of growth hormone deficiencies, like the history of birth trauma, breech presentation, and also some midline abnormalities like midfacial hypoplasia, frontal bossing, cleft lip, cleft palate. These goes in favor of growth hormone deficiency. And lastly, some of the risk factors like history of childhood brain malignancies and cranial irradiation also can be risk factors for growth hormone deficiency. US-LS ratio is important to classify under proportionate and disproportionate short stature, which we'll discuss later in the summary slide. So this is the thing, first you assess whether there are some dysmorphic or syndromic features or not. If the dysmorphic features are there, then these are in favor of Turner syndrome, Prader-Willi syndrome, and Russell-Silver. If dysmorphic features are not there, we will classify it under the heading of proportionate or disproportionate short stature. Disproportionate short stature can be short trunk or short limb. Short trunk means mucopolysaccharidosis or spondyloepiphyseal dysplasias are the cause. Short limb, mainly the rickets or hypothyroidism are at the cause. Regarding the proportionate short stature, we will see whether the bone age is severely delayed and height age is more affected, then it is endocrinological causes are there. But if the bone age is not much delayed, if the chronological age is equivalent to bone age, more or less same, then it's more in favor of idiopathic short stature, that is familial short stature or intrinsic short stature. But in constitutional delay in growth and puberty, the bone age is delayed. And lastly, if the weight age is severely affected, weight is more affected than the height, then systemic diseases and malnutrition are at the cause. Short limb and short trunks I have already mentioned. So the first line investigation should include complete hemogram, LFT, RFT, thyroid function test, calcium profile, and the celiac screen and arterial blood gas analysis, and later IGF-1. In less than 5 years of age, IGF BP3 is preferable. Second line investigation will depend upon the suspected causes. Like for hemolytic diseases, we will go for the hemoglobin electrophoresis. For RT, we have to go for the urinary anion gap and ammonium chloride loading test. For growth hormone deficiencies, we will go for the next step, that is growth hormone stimulation test. In child, clonidil and glucagon stimulation test are preferred. Insulin tolerance test is the gold standard, but there are some risks, so we usually do not prefer it. Imaging, that is the MRI for the hypothalamic pituitary causes like empty cella or any stalk interruption is there or not, we will identify that. So back to the cases, the first case clearly shows it's a case of familial short stature because mid-parental height was low. The second case where there is a similar history in the family and bone age is delayed, similar history of delayed puberty. So it's a case of constitutional delay in growth and puberty. And coming to the third case, where there is a clear-cut history suggestive of rickets, which is secondary to distal RTA, as the ABG arterial blood gas analysis is showing a high urine pH in the background of metabolic acidosis. And in the fourth case, where the multiple pituitary hormone deficiencies were there because the MRI was clearly showing a stalk interruption, and where the multiple pituitary hormone deficiency in the name of growth hormone deficiency, gonadotropin, and secondary thyroid hormone deficiencies were present. And lastly, the picture of that girl, which was the phenotypic features were classical of Turner syndrome. So, and the karyotype was done, which was suggestive of 45XO karyotype. So coming to the take to the clinic message, that is the proper anthropometry and growth chart, use of growth chart are the key to success for a successful diagnosis of short stature. The age of insight is important. Growth velocity is more important rather than a single measurement of height. Bone age is particularly important, and the second line investigation should be done based on the suspected cause on the first line investigations. And growth hormone stimulation test is essential for the patients to confirm the diagnosis of IGHD, that is isolated growth hormone deficiency. Thank you for your patient hearing.
Thank you, Dr. Abdonil. It was a very nice presentation. The one takeaway that I should tell from this session and also the previous one, that whoever seeing the pediatric patient should always have a growth chart with us.
Yes, sir.
Because if we cannot spend 2 minutes extra for every child, then all these cases can be missed. So this is a very important thing, that proper measurement and also the proper interpretation of the growth chart.
Yes, because the single measurement of height is not important, rather the height growth trajectory is more important, which you can be evaluated only by the use of growth charts.
Yes, for that case, the pediatrician may have the growth chart profile for this child, how the child is, the height is increasing and how the weight and BMI is increasing. So keeping the record is also important for that.
Yes. Thank you. Thank you, chairpersons. And we often talk among our endocrinologist circles that pediatricians make excellent growth charts. We endocrinologists often skip making those growth charts, but obviously you people are masters of growth charts. Thank you, chairpersons and Obronil, for that wonderful and educative session. For the next session, which will be on adolescent PCOS. It's not a very fairly new entity, but it's a more discussed entity, a difficult to diagnose entity. To chair the session, we have Dr. Deepak Chaudhary, sir. Dr. Deepak Chaudhary is very senior obstetrician of Purulia, and he's the treasurer of IMA Purulia branch. Dr. Chinmay Lat, Dr. Sumanto Das, Dr. Sumanto Das, another senior pediatrician from Purulia, and Dr. Palash Mojumdar, faculty at the Department of Obstetrics and Gynecology, Deven Mahato Government Medical College Hospital, Purulia. And to do the deliberations, we will have Dr. Piyash Gargari. Piyash just completed his senior residency in endocrinology, also passed out from the same place at SSKM Hospital. He was a beloved colleague, currently practicing as an endocrinologist in Kolkata and suburbs. Piyash will quickly take us through adolescent PCOS.
Thank you. I would like to first thank the organizers for inviting me and to give me this gracious occasion to present in front of this August gathering, and especially to the Pankaj Da. And I also must thank to the chairpersons for making my task simple, for supporting me. So first of all, what is, adolescent PCOS, right? So adolescent PCOS is a term which is often used, but we don't know what is the mechanism. Feed us, Thank you. So I will give you just two pictures. The first one is a 14-year-old girl with menarche around 1.5 years back with the irregular periods and USG showing polycystic ovaries. And case 2 being a girl who is excessively concerned about pimples and who went to dermatologist with high testosterone levels and regular menstrual cycles. Now, which one of them do you think is having PCOS? Any guesses? So we'll see it later. So first of all, I would like to point out the definition of adolescence. You can see, as per WHO, adolescence is the phase of life where the age is between 10 to 19 years. It is a unique stage of human development for laying the foundations of pubertal and good health. Like it is often equated with puberty, which is the cycle of physical changes culminating in reproductive maturity. Now, coming to puberty, what happens exactly in puberty? There are some changes in the adrenal axis, there is some changes in the hypothalamus pituitary gonadal axis. In adrenal axis, due to various mechanisms, there is increase in adrenal androgens. As per the hypothalamus pituitary gonadal axis, there is activation of the HPG generator, followed by increase in the LH and FSH, followed by estradiol and testosterone. I am not going to details due to the time constraints, but this is somewhat the pattern that is seen in the gonadotropin levels during puberty. You can see in the picture that the LH level is going pretty higher, whereas the FSH level is pretty stable. And from other point of view, there is increase in GH and IGF-1, and there is insulin resistance as well. Now, as per the latest 2023 ASRM recommendations, PCOS affects almost 1 in 10 women. That is 10 to 13% of the general population is having PCO. Although there is higher risk in obese or overweight, but there is this concept of lean PCO. But today, our topic of discussion is not about PCO, it is about adolescent PCO. So we'll see what is making it unique. So the core components of polycystic ovarian syndrome is 3 things: hyperandrogenism, chronic anovulation, manifested by irregular periods and all, and there is polycystic ovary morphology. Each of them has got a unique definition. I will not go into the detail of polycystic ovarian mechanism because that's something common to all. And regarding some clinical features, we all know that there is happening hirsutism, there is excessive acne, there is menstrual irregularities, there is acanthosis nigricans associated, there is metabolic syndrome, sleep disorder, breathing, and whatnot. Now, what happens in case of adolescents? For adolescents, the definition is not uniform. Number one, there is menstrual irregularities, anovulatory cycle, and PCO morphology. This can be normal. It's a absolutely normal finding in adolescents. And the complications are similar to adults. And what is more concerning is that adolescents are more prone to the psychosexual development, that is the psychological manifestations are more concerning for the adolescents. Now, as per the ASRM recommendation, irregular menstrual period are defined as normal in first year post-menarche, but 1 to 3 years post-menarche, the duration of menstrual frequency is either 21 days less or more than 45 days. This is what it makes unique, because that is exactly the definition of irregular menstrual period. Now, in adolescents, the adolescents often surpass this menstrual frequency. Greater length of menstrual cycles and greater degree of menstrual irregularity are very common due to higher frequency of anovulatory cycles. Although if there is family history, if there is obesity, if there is family history of PCOS, this frequency can be a continuum. Now, these are the abnormal uterine bleeding that can be found in adolescent PCO. I am not going to bore you with this. Now, regarding hirsutism, the hirsutism is characterized by excessive hair, terminal hair, more than 5 millimeter, which is pigmented in androgen dependent distribution. That is actually accounts for the hirsutism, not just any sort of excessive hair which can be perfectly normal hypertrichosis or vellus hairs, right? Now, these are the how we usually grade the hirsutism. There is a modified Freeman-Galloway score. Now, regarding acne, what is important is seeing the comedonal acne, not just the routine acne that we see in almost all adolescent girls, right? Now, when you should consider workup, the menstrual abnormality, abnormal degree of hirsutism, and focal hirsutism. Each of these terms qualify for its own explanation. Now, there is biochemical evidence of hyperandrogenism being the higher total or free testosterone, where the total testosterone more than 55 or free testosterone more than 9 is consistent with hyperandrogenism. Now, there is a concept called free androgen index, where total testosterone more than into 100 by SHBG is important. Why? Suppose a patient comes to you with a comedonal acne, with a menstrual irregularity, and you get a normal testosterone. What you should do next is the SHBG, because that suppressed SHBG is going to give a free androgen index, which if high is perfectly okay for that patient to qualify for hyperandrogenism. And in most adolescents, androgen levels reach adult range at 12 to 15 years. Now, there is a word of caution. Why? Not every hyperandrogenism accounts for PCOS, because there are some etiologies that you can see in this picture, some being ovarian hypertrichosis, some being adrenal carcinoma, some being simple congenital adrenal hyperplasia. They are also a close mimicker of PCO. Now, current specific guidelines, I am not going to bore you with this. Now, what we said concentrate that 2023 ASRM recommendation. In adolescents with irregular menstrual cycle, diagnosis should be discussed with the patient and not just stamped. And those patients who are having not the florid features of PCO, like if the Rotterdam criteria is used, 2 amongst 3 should be present. But those adolescents who have the features of PCO but do not meet the diagnostic criteria, an increased risk should be considered. Because to have that diagnosis stamped, we need at least 8 years post-menarche, right? Now there is a role of AMH, but the role is debatable. Although serum AMH typically peaks at the age of 20 to 25 years, there has been various cutoffs, but there is no uniform defined criteria. Yeah. So there is a role of LH and FSH? Yes, there is a role. If LH is to FSH ratio is more than 2.8, according to 3, some says 2. If it is more than 2:1, it can be told as the patient might have PCO, if and only if the clinical features corresponds with it. Not just any Tom, Dick and Harry goes for an LH FSH and that more than 2.1 does not mean anything. Now, regarding ultrasound, polycystic ovarian morphology in ultrasound is to be defined because there are some recommendations called the FNPO, FNPS and ovarian volume. What are these? FNPO is the follicle number per ovary, which should be available in higher quality of machine. But the machines that we are typically working with are more habituated with the two-dimensional thing, that is the follicular number per section. So there are two things, ovarian volume and follicular number per section. Ovarian volume among them is the better suited for follicle count. Now, regarding although there is no definitive criteria for defining PCOM in adolescents, it is not recommended. Again, and any role of measuring insulin levels or HOMA-IR, insulin resistance is characteristic, it is all very good, but there is no definite cutoff. So, why the diagnostic criteria of PCOS in adults cannot be applied? Because the same mimickers that adolescent face. Because any test if you use, it's typically involving 95% of the adults, but 5% is typically staying out of the tract. And the same 5% rule applies for the adolescents as well, because the common signs of hyperandrogenism in adults are less reliable, and the measurement of testosterone concentration is adolescents are problematic because the serum concentrations in adolescents rise during anovulatory cycles, and there is lack of reference data. So these are the International Consortium of Pediatric Endocrinology data. So suppose if coming to the first case, the first patient was considered at risk. Why? The patient had a menarche between 8 years. So the patient was considered at risk. Sorry. So the patient was advised lifestyle advices, and the second patient who was having oligomenorrhea, who was having a high testosterone level and who was having a high ovarian volume was seen having two features. So the patient was suspected of query PCOS. Why? Because again the cutoff of 8 years. Now additional what evaluations can we do? We can go for the glycemic indexes, lipid parameters, LFT and USG. Obviously that thing that we all forget is the psychological well-being, and the other thing is OSA screening, obstructive sleep apnea. Management that you all know that the lifestyle advices, weight reduction, sometimes metformin, sometimes pioglitazone, and regarding the menstrual cycle is the concern, then estrogen, progesterone pills. If the hirsutism is the concern, anti-androgens, sometimes surgery. These are all those things. But those patients who are wishing for pregnancy or not recommended for adolescents, the ovulation induction protocols are there. Now regarding adolescents, the lifestyle modification, hormonal contraceptives, insulin sensitizers, androgen receptor blockers sometimes can be used. The principle is always to be discussed with the caregivers, the cornerstone being the weight loss and the increased physical exercise. Metformin, sometimes given standalone, could improve the menstrual irregularity. Anti-androgens are having spironolactone most commonly used. Sometimes COCP can be used, but with a word of caution. Lean PCOS, again, there is a matter of concern where lifestyle advices has shown its promise. Sometimes myoinositol has got a debatable role, although in favor of positive. It prevents weight in BMI. Psychological figures should be concerned, should be addressed, and the mood disorders should be corrected with the proper counseling and cognitive behavioral therapy. Preconception advice typically should concern about glycemic benefits and obviously stopping the anti-androgens as well as the statins and RAS blockers. So the diagnosis of PCO in adolescents, the diagnostics are obviously messed up. The therapy is dubious. All which is thing to be relied on is your clinical acumen. If you feel this thing to be a patient with a PCO, you should rule out the other causes and followed by your treatment. That's it, I think. Thank you.
Thank you, Piyash, for that last moment arrangement. Actually, this topic was given to another speaker who could not come because of an illness at home, and Piyash rescued me in the last moment with his wonderful presentation.
So, you presented the things in a very good manner. The take home message is, every day we are dealing with these persons. You change your lifestyle. আমরা বাংলায় বলি সময়ে খাবে সময়ে শোবে আধ ঘন্টা ব্যায়াম করবে ব্যালেন্স ডায়েট মা যা দেবে তাই খাবে বাইরেরটা আনাবে না আর থার্ড হচ্ছে কি রিডিউস ইওর স্ক্রিন টাইম স্পেশালি মোবাইল ওকে থ্যাংক ইউ
Thank you, sir. Piyash, please, for the photo.
Just,
Sir, please.
You have mentioned that the incidence is just 1 in 10. I think.
Yes, sir.
1 in 10, that means only 10% of people. But Sad already has said that every day, every patient we are getting, I think it is an epidemic now.
Yes.
The PCO is an epidemic. Every patient with the girl that you have already mentioned that it is a psychosexual problem. It is very much psychological problem to the mother also. The mother is coming with their children with the complaint that my daughter is not having regular menstruation, number one. And number two, ultrasound mentions that she is having cyst in the ovary. So whether these cysts require operation or whether she will have pregnancy in the later period, how she can marry. So these are the basic two problems with the mother, whether she can have pregnancy in the later period or she requires any surgery for the ovarian cyst, whether that is mentioned in the ultrasound, because every patient will come with the result of ultrasound with the polycystic morphology. I think it is an epidemic now. Will you please comment on this?
Yes, sir. So I will just take 1 minute from Pankaj, nothing else. So the thing is, that thing I want to reiterate it more. Not every polycystic ovary is a polycystic ovary syndrome. There are 3 diagnostic criteria, of which Rotterdam is the most commonly used. The first thing is you need to define what is polycystic ovary morphology. If it is FNPO more than 10, it is polycystic ovary morphology. Follicle number per section that accounts for 2 to 9 millimeter ovaries are not every follicles, 2 to 9 millimeter follicles. If they count for more than 20 in TVS or more than 10 in TAS is accounting for the polycystic ovarian morphology, supported by the ovarian volume. If the ovarian volume is at least 10 to 12 ml in each ovary, you cannot qualify it as polycystic ovarian morphology, number one. Number two is, even if it is satisfied in presence of normal menstrual cycle and otherwise without any clinical features of hyperandrogenism, you cannot call it a polycystic ovarian syndrome. Although you can call it the patient is at risk, you can obviously give lifestyle advices, but there is no need to give any undue psychological stress to call it as this patient as polycystic ovarian syndrome.
Yes,
I would like to I'd like to mention, sir,
Yes, sir.
that please do not be misguided by the USG reports which
That's
said
right,
polycystic ovary morphology or whatever,
Yes.
with an ovarian volume of 7 cc and 8 cc, no counts given, no thecal echogenicity shown. It's very surprising to have polycystic ovary morphology with a 7 cc ovary.
Yes, sir.
So please don't go with that. And the most important thing in adolescents is that a transabdominal USG has its limitations. We cannot do a transvaginal ultrasonography in unmarried females, so probably diagnosing itself is difficult.
Yes, it is very difficult, and counseling is the most important.
Yes,
Better
sir. Not to
Another
diagnose.
is that the lifestyle modification.
Yes,
It is very difficult because the student is their student. Most of them are student. They are studying for the higher studies. Everything are stress. They are going preparing for NEET, everything for JEE. So it is very difficult to go to body exercise or any other things.
Thank
It
you.
is also very difficult for them to maintain the lifestyle modification.
Thank you, sir. Thank you. Thank you,
Sir, it's
Piyash.
150 minutes per week of exercise.
Yes,
only.
Piyash, to the photo booth. For the next session, we have another session on reproductive endocrinology. To chair the session, we have Dr. J.K. Chandro, Jayantoda, who is a senior obstetrician. Dr. J.K. Chandro. Jayantoda, please. Dr. S.K. Hasda, Shubodh Hasda, who happens to be a senior as well as another very senior obstetrician from Purulia. And Dr. Shilpa Khaitan. Dr. Shilpa Khaitan is another popular obstetrician in Purulia. They will chair the session on early GDM. That's another controversial and a new entity, relatively new entity. We all know GDM, we all know pre-gestational GDM. Early GDM, that's happening before 20 weeks of pregnancy or even earlier. To deliberate on that, we have Shoham Tarafdar, who happens to pass his DM endocrinology from the prestigious IPGMER. He currently practices in Kolkata and the suburbs. He was a very beloved colleague when I was there. Shoham for early GDM. Thank you.
Thank you, Pankajda, and thank you to the organizers who have which created this very wonderful event. And I'd like to thank Pankajda again for giving me this topic. Okay, so we're going to handle what is early GDM, diagnosis, and the management. So this is the outline of the presentation I'm going to present today. Okay. So, definition of gestational diabetes mellitus. Traditionally, diabetes diagnosed in second or third trimester of pregnancy that was not clearly overt diabetes prior to gestation. That is the traditional diagnosis. Early GDM is a newer entity, generally refers to gestational diabetes mellitus diagnosed before the standard screening window, which is 20 weeks or to 24 weeks. Early GDM basically is a type of pre-diabetes which we call in a non-pregnant status. So that is the definition of the early GDM. So I'll just go through briefly the glucose regulation during pregnancy. During the first trimester, there is actually physiologically a decrease in the fasting glucose levels. The insulin sensitivity remains intact. In the second and third trimester onwards, the insulin sensitivity decreases. There's increased insulin resistance, and in the pathophysiology of the GDM, where there is a patient, the mother is having insulin secretion which is deficient, they are not able to compensate for the increasing insulin resistance, they will ultimately have the gestational diabetes. To the classification of the DM in pregnancy, there are different bodies and there is different terminology used. There is no general consensus. In the IDPHG, the hyperglycemia, there are two groups, the overt diabetes mellitus during pregnancy, the overt diabetes and the GDM. In the WHO, there is diabetes in pregnancy and GDM. In the ADA, there is diabetes complicating pregnancy and the GDM. So is there any need to differentiate GDM from overt DM? Definitely there is. In a patient who's having pre-existing diabetes, they are having the higher risk of microvascular complications, they're having high risk of hypertension, and most significantly, embryopathy, spontaneous abortion, IUGR, and intrauterine death. In the gestational diabetes, the complications are a bit different. There is pregnancy-induced hypertension, macrosomia, difficult labor, and a future risk of maternal or neonatal diabetes. In the prevalence, if you see the data, there is a high prevalence, 17% in the urban, 13% in the semi-urban. Even in West Bengal, there is data is 14 to 15% in the urban population and 11% in the rural population. There are some definite risk factors for GDM. The risk factors are the prior gestational diabetes, pre-pregnancy obesity. We are currently the high risk group, okay? And there's a prior macrosomic baby, more than 4 kg, maternal age is a factor, the PCOS is a factor, family history of diabetes, history of multiple gestation, and previous history of impaired fasting glucose. The diagnostic criteria of GDM has evolved over a time. So initially, the historical foundations laid by the O'Sullivan-Mahan criteria, this criteria, the rationale behind it was they were validated by their ability to predict the onset of diabetes in the future, 8 years postpartum period. So they used the 3-hour OGTT protocol, and this was in the future modified due to the improvement of the enzymatic tests, and the values decreased by 10. But this actually, it is having the limitation that it is not able to predict the development of fetal or maternal problems during the current pregnancy. So based on that, there was a resulting shift, and we have the landmark HEPO study, which again recruited a large number of patients. And in this category, the HEPO outcomes, we can see that there's a continuous graded relationship between higher maternal glucose and increasing frequency of primary and secondary outcomes with no obvious thresholds. So we had to have a consensus, and the IIT PhD conference was held, and the values they have selected, these values actually demarcate the average glucose value at which odds of more than 90 percentile of the adverse outcomes. These values came out to be a fasting plasma glucose of 92, 1 hour OGTT 180, and 2 hour 153. So this is the origin of these values. Okay, the problems, there were some problems with IIT PhD also, because after the advent of this, compared to the previous data, there was a marked increase in the prevalence of this GDM, and definitely the more cost of treatment, increased need of medical infrastructure, so they will have to get treatment. More importantly, the effect of treatment in terms of improvement in these parameters was not yet known at that point of time. So the professional organizations vary in the adoption of this criteria. The WHO recommends the 75 gram OGTT and the 1 hour and 2 hours. The ADA recommends either a single step or a two-step strategy, though the IDPHG strategy, the single step is still preferred in the ADA. We have the combination of these guidelines in the DIPSI guidelines, who have highlighted that using the universal testing is recommended in the first trimester. Single test using 75 gram glucose irrespective of the fasting state, that this is important, and we can use the plasma sunrise glucometer for checking the glucose levels. The screening should be done at the first available visit. So this is very important to reiterate that at the first available chance, we are going to catch hold of this early GDM. So ideally, in 12 to 16 weeks in the first antenatal checkup only we'll get these tests done. Next, the screening can be done 24 to 28 weeks, and again 32 to 34 weeks. Here the categories are a bit different. Overt diabetes after 75 gram glucose 2 hours, more than 200 is overt. More than 140 is GDM, and more than 120 to 140, this category is decreased gestational glucose tolerance. So here is a combination of all the guidelines we are having, the ADA, WHO, DIPSI guidelines together. So the initial screening part, they are all suggesting the first antenatal checkup should be the first point of the blood test. And the standard window again comes at 24 to 28 weeks. The Indian guidelines specifically mention a late screening, 32 to 34 weeks, since there's a late onset of hyperglycemia in Indian patients. So where does the concept of early GDM come? There have been reports that up to 60% of these patients can be caught if we do an earlier test. So why not do it? And definitely the most international guidelines are now recommending early antenatal testing for women at high risk to identify the early GDM. So the early GDM diagnostic criteria, it varies all over, it is all over the place, but still IDPH is the most easiest to remember, fasting 92 to 125. Also we can use the WHO, the OGTT thresholds remains the same. In the DIPSI criteria, again, the 75 gram 2 hour window of more than 140. So is there any benefit to treating this early GDM? This question was originally the question asked in this study. So the treatment of gestational diabetes mellitus diagnosed in early pregnancy, the study definition was that they had to select 4 weeks to 19 weeks gestation patients, and the criteria was the WHO criteria, and they divided into 2 groups for comparison. One who had received the immediate treatment, one who received treatment later. So the primary outcome, the neonatal composite outcome was that in the immediate treatment group, there was lesser number of complications compared to the deferred treatment group. And even in the maternal outcome, the hypertension, the immediate treatment group actually had a better outcome compared to the deferred treatment. So coming to the complications of GDM, there are some neonatal and the maternal complications. The perinatal complications, as we all know, is a macrosomia and respiratory distress syndrome. I won't go into details of this. The long-term complications in offspring is very important. The future metabolic syndrome, childhood obesity, hypertension, and again the GDM maternal outcomes like preeclampsia, gestational hypertension. Okay, so we're coming to the management aspect of the GDM. So lifestyle management, medical nutrition therapy, exercise, that comes as the mainstay, one of the first steps for management of GDM. So in the medical nutrition therapy, there were some initial concerns that if we restrict the calorie, restrict the carbohydrate, probably the fetus will not get enough fuel for their brain development or fetal growth. So the current dietary practice aims to modify the carbohydrate quality instead. The guidelines recommend a range of carbohydrate intake up to 35 to 55%. There are different guidelines available. The ADA recommends the dietary intake of 175 gram carbohydrate, a minimum 70 gram, 1 gram protein and 28 gram fiber. Emphasis on mono unsaturated and polyunsaturated fats while limiting saturated fats and avoiding trans fat. Another important point to note is the ideal weight gain. That is very important in the patients who are undergoing treatment for GDM. So in the Institute of Medicine, there is a definite guidelines of, according to the BMI, the pre-pregnancy BMI of the patient, how much weight one should gain during the pregnancy. Just to give an idea, there is a systematic review and a gestational weight gain of 5 to 9 kg recommended in class 1 obesity, 1 to less than 5 kg in class 2 obesity, and probably the best outcome would be with no weight gain in class 3 obesity. Along with that, we should promote physical activity. Many of the patients come, they say, we are having this GDM, so we are having this illness, so we will not go into any physical activity. There is a fear of the pregnancy loss. But still, all the guidelines recommend 30 minutes of moderate intensity aerobic exercise, 5 days per week, or a minimum of 150 weeks per week. And simple exercises, walking and 10 to 15 minutes can suffice after each meal. 80 to 85% of GDM cases can be managed with dietary and lifestyle interventions only. So coming to the pharmacological therapy, I'll just go through fastly. Again, ADA, current guidelines, insulin is the first line. Among them, the regular insulin, the analog insulins are approved. NPH, datamir is approved. Glargine, there is still no data till date. In the degludec part, we have some data available with us right now in the EXPECT trial, and compared datamir, no additional safety concerns were observed. Insulin initiation, again, we should start with a lower dose and again titrate accordingly. Among the oral pharmacotherapy, metformin and liberate has been used in the past, but they are not recommended as first line for GDM because they are known to cross placenta. Data on long-term safety for offspring is of concern. Sulfonylurea we should definitely avoid. Metformin, there is some conflicting reports are there. There is some conflict in that remain. So there is some systematic reviews. Meta-analysis have shown no difference in risk of small gestational age, and they have shown there is some risk of small gestational age, and the ongoing trials will probably give some answer. I'll just like to reiterate the ADA's current recommendations to be used in patients who have not been able to use insulin safely. So metformin can be used due to cost saving and language barriers and all these things. Okay, but in our Indian scenario, if you follow the WHO guidelines, the latest guidelines, in Indian setting, we are in a lower middle income country group, so metformin should be used. Metformin should be used in GDM as it is cheaply available, and most patients with initial GDM would actually be well controlled with metformin only. So I think I can end it here.
Thank you.
Just go to the take-home message. So
thank you, Shoham, for that wonderful presentation on GDM, or maybe early GDM. That's a little difficult entity to understand. We understand GDM better. And metformin is a clear go-ahead with metformin, whether you were on metformin or you want to be on metformin. Another interesting, difficult, controversial area is glargine insulin. Probably we use it left and right. What do you say?
The thing is that if the patient is already known diabetic who is already on glargine, we'd probably let it continue. We won't interfere with the treatment regimen. But if the patient is not on glargine, we won't introduce it for the first time during pregnancy.
As a long-acting, what would you prefer? NPH twice daily?
NPH can be used. Generally, what we are doing in clinical practice, we are using premix twice
Insulin
daily. So that
twice.
is a better option. If it is not well controlled with premix, and metformin will go for the basal bolus, so multiple subcutaneous injection. So any questions?
Chairpersons.
Thank you, sir, for this very informative session. And yes, it is very important to differentiate between over diabetes and GDM, especially the early onset GDM. With proper first antenatal checkup, with doing the fasting insulin and the fasting blood sugar levels at the first antenatal checkup, we can definitely go for better diagnosis and better management.
I just
Thank
wanted
you.
to know, do you do routinely HbA1c in all the patients of antenatal? Because it is not a part of antenatal
No,
checkup.
we usually don't do. Yeah.
Probably
They
we
don't do this.
can-
They send
if
it. They
we
send
can
those to
improve,
me.
that will be a good thing.
They send to me, and I don't do.
So the first antenatal checkup, so it is there in the guidelines, but we are in the low income country, so
But
we
I
cannot
think
afford
for
it.
all those patients in the first and trimester before 20 weeks, till we are very clear about early GDM, we would brand them as pre-gestational diabetes mellitus for ease of treatment, I believe. They are pre-gestational or gestational. Thank you, chairpersons, and thank you, Shoham, for that wonderful presentation. Ladies and gentlemen, big round of applause for our lovely batch of chairpersons. Dr. Joyanto Chandra, Dr. S.K. Hasda, and Dr. Shilpa Khaitan to the felicitation podium. Moving quickly to the last topic on reproductive endocrinology. Another very interesting topic, galactorrhea or white milk discharge from the breast. Dr. Sanjay Chatterjee, Senior Surgeon, Purulia. Dr. Amrit Khaitan, Senior Surgeon, Purulia and Laparoscopic Surgeon. And Dr. Shamul Kanti Das. Dr. Shamul Kanti Das, is he around? Dr. Shamul Kanti Das is coming. BMOH Pada Block Primary Health Center will be chairing this session to be deliberated by Dr. Amitabh Soor, another junior from Medical College and a wonderful person. He is a consultant endocrinologist, I believe, at Peerless Hospital, Kolkata, right?
Yes.
Yes, Amitabh, on galactorrhea.
So at the outset, thank you Podecon organizing committee, especially Pankaj Da and Priya Bhabhi for giving me this platform. So I will be quickly moving to my slide sets. So my topic of discussion is approach to galactorrhea. So what is galactorrhea? Galactorrhea is milkish discharge which comes out from nipple of a non-pregnant, non-breastfeeding adult. That's the basic definition of galactorrhea. So galactorrhea can happen in both men and women. Galactorrhea, just like fever, it is a symptom. Don't consider galactorrhea per se as a disease. Now, let us begin with a case discussion. A 34-year-aged female with 6-month history of bilateral milky nipple discharge comes with symptoms, apart from this, of menstrual irregularity from last 1 year. She is worried what it could mean. So how should we investigate this patient? First of all, we need to confirm that whether we are dealing with galactorrhea or not, whether the discharge is milky or not, or colorless sometimes, bilateral or not. If it is a unilateral discharge coming from a single duct, or if the discharge is bloody in character, reddish, bloody in character, then remember we might be dealing with papilloma or maybe breast carcinoma. In that case, we might have to send patients to our distinguished chairpersons. Now, apart from that, we need to rule out some physiological conditions like pregnancy and lactation, and then quickly we have to do a baseline prolactin. Prolactin is the hormone responsible for breast development as well as milk secretion from the breast in general. Now, after this, we have to identify what can be the causative reason for the galactorrhea, or after documenting the baseline prolactin. Pharmacological reasons for rise in prolactin is more common than any other reason. So drug-induced hyperprolactinemia has to be ruled out. Various classes of drugs like antipsychotics, antidepressant, antihypertensive, etc. are responsible for increasing the prolactin level. Apart from that, some organic pathological causes like macro prolactinoma, non-functioning pituitary adenomas, situations like hypothyroidism, PCOS, chronic renal failure, CLD, etc. and physiological reasons like chest wall stimulation, exercise, stress, even sexual intercourse are responsible for increase in the prolactin level. Coming to the most common reason, as I mentioned, drug-induced hyperprolactinemia. Now, antipsychotics, antidepressant, GI motility drugs, antihypertensive, as I mentioned, these are all responsible. Usually, the drug-induced hyperprolactinemia, the prolactin level is somewhere around 25 to 100 nanogram per ml, but there can be exceptions like antipsychotics like risperidone, tricyclic antidepressants like clomipramine. Then there are some motility agents like levosulpride. These are very notorious and they can push prolactin upwards even beyond 200 nanogram per ml. Usually when the prolactin level is more than 200 nanogram per ml, we more of think about dealing with prolactinoma, micro or macro. Now, following this trail, we also have to check for, now if the prolactin level has not come high, it has come normal, we may be dealing with normoprolactinemic galactorrhea. This is also a very common entity where the prolactin level is normal, still patient is having galactorrhea. This usually, there is no clear explanation, but breast tissue in these patients are more sensitive to prolactin. Some rare causes of normoprolactinemic galactorrhea, apart from what this benign entity which I described, can be acromegaly, where you can have normal prolactin but still have galactorrhea. That is something which is very rare. Now, if the prolactin level is elevated, we have to search for what is the cause of this hyperprolactinemia. Now, what should be the ideal threshold when we order for an investigation, particularly in imaging investigation? MRI is usually commonly done, hypothalamic pituitary area. When we are suspecting a microprolactinoma, we add a dynamic contrast because it is more likely to pick up the prolactin level then. Now, after ruling out drug-induced and other reasons, as I mentioned, hypothyroidism and PCOS, etc., if the prolactin is still coming high, then most likely we will be needing imaging to find out what's going wrong. But then earlier there was no, there was no evidence that at above what prolactin level we should ideally offer MRI. Recently, some evidences have come. One of them was a multi-center retrospective study published from Saudi Arabia, which suggested that now we have a cutoff of 38.71 nanogram per ml, beyond which if the prolactin is persistently coming high, then definitely we have to go for an MRI. But anyway, there are other factors which should also be taken into account. Hypothyroidism is very important. CKD and CLD is very important. TRH is a very strong stimulator for prolactin secretion. Now, after you look for, after you do an MRI, you have to see whether the patient is having micro or macroprolactinoma. If the adenoma size is less than 1 centimeter, it is suggestive of microprolactinoma. If the adenoma size is more than 1 centimeter, it is macroprolactinoma. Usually in macroprolactinoma, the prolactin level is more than 250 nanogram per ml. Usually, sometimes in non-functioning adenoma, what can happen is because of stalk effect, because of stalk compression, the prolactin level goes high, and therefore for non-functioning pituitary adenoma, you may get prolactin somewhere around 100 nanogram per ml. Usually because of hook effect, the prolactin never goes beyond 150 nanogram per ml. Now, sometimes in presence of macroprolactinoma, also the prolactin level can be falsely low. That can be because of hook effect, because of increased number of prolactin molecule. It may be saturating the capture and detection antibodies, and therefore you may get falsely low prolactin, which has to be taken care of by doing 1:10 or 1:100 dilution. Macroprolactinemia is also an entity that happens because of the presence of aggregates of the prolactin. Prolactin is usually a monomeric molecule, but when they get aggregated to each other, the molecule becomes larger. That is, functionally they are inactive, and you can do a PEG precipitation to discover whether you are having macroprolactinemia or not. Now, so verdict, what should be your goal? Normalize the prolactin level, restore the gonadal function, and then reduce the tumor mass. Now, how to do it? Dopamine agonist is a treatment of choice after documenting that you are dealing with prolactinoma. Cabergoline and bromocriptine both can be used. They are both D2 receptor agonist. Head-to-head comparison between them has shown that cabergoline is superior to bromocriptine in terms of galactorrhea resolution, amenorrhea resolution, adverse effects profile, lower adverse effect profile, as well as improved pregnancy rates. So we tend to use cabergoline more often than bromocriptine, except for rare situations where use is done in pregnancy. Now, the galactorrhea investigation protocol, as you can, I'm just repeating this, what I have already said. Patient with galactorrhea, first you confirm milky discharge and rule out pregnancy, then you measure prolactin. If the prolactin level is normal, then you may be dealing with idiopathic galactorrhea, reassure or manage the symptoms. If the prolactin level is elevated, you go for medication review, check TSH, renal function, etc. and then do accordingly. If the prolactin level is remaining high, more than 38 nanogram per ml, even after ruling out these factors like hypothyroidism, PCOS, CKD, CLD, etc., then you order a pituitary MRI, and then you see whether you have got a non-functioning pituitary adenoma or macroprolactinoma or microprolactinoma. Now, so start with obvious, as I said, and then rule out the accomplishes, use an evidence-based trigger, and choose a superior tool. That should be our core way of acting. So I stop my presentation here and the session is open for discussion. Yes, please, madam.
Good afternoon. I'm an ENT surgeon. Recently, I have come across with a young lady, about non-obese young lady, 27 years. She was having a hyperprolactinemic galactorrhea and a pain. The ENT issues were the pain at the root of the nose. So, and the MRI has ruled out any pituitary disorder. Her pain stops here with our conservative management, but galactorrhea persists. So what are the possibilities? And as because she's a receptionist of our hospital, so how should I guide her?
Thank you for the question, madam. If the most obvious possibility which comes in my mind is, since the prolactin level is high and the patient is having galactorrhea, you first need to rule out, and your MRI is normal, so you first need to rule out drug-induced hyperprolactinemia and other factors which I have mentioned. After that, you have to see whether you have done an MRI of pituitary per se or not, because MRI brain often misses microprolactinoma. So if MRI pituitary has been done, we have to check in console the plate, because without dynamic contrast, we may often miss microprolactinoma. So these are the angles which we should be keeping in our mind, madam.
Preferably in a 3
Thank
Tesla
you.
machine.
Yeah.
In a 3 Tesla machine.
Yeah.
Do we really need the dynamic contrast for prolactinomas like we do it for corticotropinomas?
So for Dara, if we are suspecting microprolactinoma, then possibly, yeah, you can say that you may not need it, because even if you don't locate, you can assume that you are dealing with a microprolactinoma.
Right.
Unlike cortisol secreting microadenoma, where you have to pinpoint locate.
Yes.
And I understood the theme of your question, that since it is treatable medically, so even if you cannot locate and you are sure of, then you can go ahead with the
Possibly
treatment.
we often do not write MRI with dynamic contrast
Yeah.
for prolactinomas
Yeah,
per se.
when we are suspecting prolactinoma.
Chairpersons?
Very well presented, Dr. Sur. Most of our queries regarding diagnosis and management of are solved. Thank you.
Thank you so much. Thank you, chairpersons and speaker, for that short and nice presentation on galactorrhea. And every case of galactorrhea with cabergoline without a diagnosis.
Yes, that's the bottom line.
That's what we
That's
face
the
day in
bottom
and day
line.
out. Please, to the felicitation podium. We now quickly move on to one of the very interesting sessions for the day. A thing that is very, very relevant, very important, very preventive, very much part of the community medicine or PSM that we read of, vaccination, but we do not. All our diabetes patients probably need vaccination, but I think less than 10% of diabetic patients are vaccinated. And to do this session on vaccination in diabetes, I'd like to invite one of my teachers, Professor Dipanjan Bandyopadhyay sir, Professor and Head, Department of Medicine, North Bengal Medical College and Hospital, Kolkata. Many of us know him, many of us have been his students, and he is a prolific speaker. And the panelists are Dr. Satyajit Roy, physician from Asansol, Dr. Akash Panigrahi, endocrinologist and a colleague currently in Jamshedpur, and Dr. Piyash Gargari, who has already been introduced, and you will probably recognize him with the hat again. Dipanjan sir will take us through vaccination in diabetes.
Good afternoon, everybody. As rightly mentioned, probably one of the least well-attended issues in diabetology or even in geriatric medicine is adult vaccination. We talk of adult vaccination, we have questions in the PG exam, but when it comes to the prescription, I think most of us physicians, endocrinologists alike, we miss the issue of adult vaccination. And I thank the organizers for keeping some time on the scientific agenda to highlight the importance of adult vaccination. I think we have a very interesting and intelligent group of panelists. On my left, Dr. Satyajit Roy, practicing diabetologist and physician from Asansol, Dr. Akash Panigrahi and Dr. Piyash Gargari, both consultant endocrinologists. And maybe begin with Satyajit to ask him, why do we need to talk of vaccination in a diabetology conference? Or are diabetics more important candidates for adult vaccination?
Yes, sir. As we all know, the diabetes is a leading pandemic nowadays. But diabetes is very closely associated with infection. How? In diabetes, there is impairment of the immunity, both innate immunity and the cell-mediated immunity. So, diabetes patients are more prone to develop infections. Especially the elder diabetes patient, they commonly suffer from community-acquired pneumonia, influenza, and all other infections. That's why the vaccination in the diabetes is very important and the need of the hour nowadays.
And I think to add to what Satyajit said, not only are they more susceptible, they are also more likely to have more serious illness. So mortality and morbidity from the same infection is more in diabetes than in the non-diabetic population. And as many of you will remember, I deal somewhat more with immunocompromised people who are virally immunocompromised, but then diabetics are also a very important segment in society who are immunologically compromised. As Satyajit said, both cytotoxic immunity and humoral immunity are impaired in diabetics. Coming to Dr. Akash Panigrahi, we have a whole long list of vaccines which can be administered in adults. Which of these would you prioritize for your patients as to be administered in diabetics?
Yeah, good afternoon everyone. We know that vaccination is a very important part of comprehensive diabetes care, and more or less we will be going by the guidelines. There are many professional guidelines, but we follow generally ADA and RSSDI. So if we go by the guidelines, COVID-19 was a very strong recommendation. Then hepatitis B with the usual protocol of 0, 1 and 6 months. Influenza, because it affects so many individuals and also repeatedly. That is one disease where we target vaccination. Pneumococcal diseases are again very important when we mostly target the individual for vaccinations. Also, there is Tdap vaccination for tetanus, pertussis, also the herpes zoster virus due to the increased prevalence of post-herpetic neuralgia, and also some guidelines recommend vaccination against respiratory syncytial virus actually. So more or less there is a consensus over the guidelines to vaccinate for these diseases.
That again is quite a long list. But before I move on to the next, may I still ask you once again, would you prioritize 1, 2 or 3 vaccines for your patients? Because I don't think it's possible in the clinical setting to ask for 5 or more vaccines for a single patient.
Yes, sir. Mostly we prioritize the pneumococcal diseases. That may be the priority number 1. And priority number 2 is influenza. These 2 diseases mostly we prioritize.
And then again, we as adult physicians, pneumococcal and influenza vaccines are the 2 most common adult vaccines I think we all of are using. I would just like to harp on why does TD, the tetanus pertussis vaccine come in the list at all? Are diabetics more prone to infections in the form of diphtheria and pertussis? Because these are generally childhood infections.
Yeah, sir, if we see these vaccinations are recommended for everybody actually. So the general recommendation will also apply to our diabetic populations. So that is one area of concern. Plus, we know that we are vaccinating to prevent the disease and also to decrease the severity actually. So the general vaccination guidelines which is applicable for other diseases or a simple adult without a disease are also applicable to diabetics.
So I think the message from the story is, which again the RSSDI has recommended us to follow, is that people are in need of these vaccines. Maybe we are at liberty to choose which one to prefer in which patient, which one to prioritize in which patient. So we are we are clinically allowed to choose and decide, but then this is the guideline recommendation, which includes pneumococcal influenza, hepatitis B, the Tdap vaccine, zoster, and RSV vaccine. Moving ahead, do we have any special considerations for our diabetic patients? Because again, we know that diabetic patients are somewhat at higher risk of developing complications in certain situations and certain clinical settings. Maybe ask Dr. Piyash to take over and tell us whether this group of people need any special precautions.
Thank you, sir. Thank you, sir, for the opportunity. Yes, there are certain contraindications that are stated, likely the hypersensitivity to active substances or excipients to any of the vaccine history, like having chicken egg allergy or something like that. Those patients should refrain from that particular vaccine, number one. Number two is within 6 weeks, if a patient has got a history of Guillain-Barré syndrome, of which we are accustomed recent days, within 6 weeks the patient had developed Guillain-Barré syndrome, we are usually advising the patient to refrain from having within 6 weeks. Yes, sir. So any acute infection, mind it, not just any mild fever. What the guidelines state is any moderate to severe febrile illness should be the contraindication. However, individual vaccine has its own contraindications, like if any patient has got neurological deficit, seizure disorder, that patient probably should refrain from Tdap vaccine, as mentioned by sir. So there is a recommendation from the immunize.org, which patients to get the vaccines and which to not. For time constraint, we should avoid it, but here is a resource which I should ask everybody to give it a read. Thank you, sir.
Well, so there are no very specific indications for the diabetics. I think the general precautions and contraindications applies equally to the diabetic population. We have been telling over the last couple of minutes that the pneumococcal vaccine is the most common vaccine to be used across the board in adults. The problem arises when we have a choice of pneumococcal vaccines. And we already know that we have two types of pneumococcal vaccines in the market. Possibly we are coming up with a third choice in our armamentarium. And it is important to know which vaccine to prefer in which group of the subpopulation. So going back to Shatrajit, may I request you to tell us how to choose the correct pneumococcal vaccine?
It's a very important aspect, and not only the patient, but we are also confused with that. There are several guidelines telling regarding the use of the pneumococcal vaccine. As sir mentioned, we have PCV 13, PCV 15 and PPSV 23. Now, newer generation coming, the PCV 20. Now we are discussing about PCV 13 and PPSV 23. So as per the RSSDI guideline, if a patient is more than 50 years old, so one dose of PCV 13 followed by PPSV 23 1 year later. আমাদের কাছে পেশেন্টলি জানতে হবে সে পিসিভি 13 নিয়েছে কিনা, যদি না নিয়ে থাকে পিসিভি 13 ঠিক তার এক বছর বাদে PPSV 23. Booster dose if needed then after 5 years of previous PPSV 23 dose. এটা হচ্ছে RSSDI guideline. As per the API guideline, if the age is more than 19 years and there is chronic condition, immunocompromised patient, then one dose of PCV 13 followed by PPSV 23 8 weeks later. There is some difference with the RSSDI guideline. তাহলে PCV 13 এর 8 সপ্তাহ বাদে PPSV 23. And if the patient is more than 50 years, one dose of PCV 13 followed by PPSV 23 1 year later. This is the more or less the API recommendation and RSSDI recommendations.
Even within the diabetic population, would you highlight which diabetic you would choose for your pneumococcal vaccine? which are the diabetics which would come up as the top on the priority list?
Obviously, sir, uncontrolled type 2 diabetes mellitus, type 1 diabetes mellitus, and diabetes mellitus along with the comorbidities.
Along with structural lung disease,
structural lung disease,
ILD,
comorbidities.
and possibly
Elderly.
something to mention in this part of the country, we must be having a lot of occupational lung disease.
Yes, sir.
So occupational lung diseases are a priority. In fact, I did not know. I was having an online meeting on tuberculosis with the health authorities of Uttar and Dakhin Dinajpur, that central Bengal is having a spot of silicosis. And silicosis on the rise in both central and north Bengal. I really don't know about your part of the state. So these are the subpopulations which come up as priorities. So we are talking of the vaccines, but then how often do we need to prescribe both pneumococcal and influenza vaccine remains a question. Because when you tell your patients we want to vaccinate you, the patient, number one, is not very enthusiastic. Number two, if you tell him that we want to give you 2 vaccines, he is even more reluctant. So, is it actually essential to administer both pneumococcal and influenza vaccines? Dr. Akash?
Yeah. Yeah, it's absolutely essential that we vaccinate against both, because if you see, diabetics are not only susceptible to pneumococcal diseases, they are also very susceptible to influenza diseases. More so, however, if you see the influenza virus, because it undergoes rapid mutation, so it can repeatedly affect the same individual actually. That's why a updated annual vaccination is the only way out to reduce the mortality and morbidity against influenza infection. If we go by some of the statistics, a diabetic is 6 times more likely to be hospitalized with a influenza infection. They are 7 times more likely to develop a pneumonia. And if we go by the mortality, they are 3 times more likely to die out of influenza infection. And at the end of the day, we want our patients to lead a healthy and better quality of life. So influenza vaccination is also equally important. And more so over, we generally administer both the doses simultaneously. Now, in India, we have the inactivated influenza vaccine. The quadrivalent vaccine is available to us. Because it's an inactivated vaccine, we can use it simultaneously with the pneumococcal vaccination also. It's a single dose annual vaccination to be repeated each year.
Yes, the only issue is you need to give it an annual shot. I know we can use it simultaneously, but can we use it within 1 week of a pneumococcal vaccine? Or do we wait for 28 days? Because that's a usual vaccination strategy. After giving one vaccine, you wait for 28 days.
Sir, if you are using a live attenuated vaccine, then a 28 days gap is recommended. If it's an inactivated vaccine, we can give simultaneously.
So you can use it at any point of time.
Yes, sir.
I think that answers an important doubt. And before we wind up and move to the audience for audience questions and interactions, may I ask Dr. Piyash to highlight what is the rationale for keeping shingles so high on the list of vaccines in the diabetes?
Thank you, sir. So the thing is, we know about the shingles, that is herpes zoster. The incidence is also higher in diabetics as well as the comorbidity. We know the mortality risk from shingles is low, although, but the post-infection morbidity is pretty higher. Like the post-herpetic neuralgia is a significant matter of concern. For that reason, all the guidelines from the ADA to RSSDI and all the guidelines state that the patient should receive herpes zoster vaccination, which is a recombinant vaccine. 2 doses should be given at an interval of 2 to 6 months, although the cutoff years actually varies. The API and RSSDI as well as the ADA guidelines state that every individuals who are diabetic and having an age of more than 50 years should receive 2 doses, and some say 2 months, some 6 months. But the ISN, that is the International Society of Nephrology, state the cutoff as 60 years. So that thing should be kept in mind.
And possibly it is important for us to remember that post-herpetic neuralgia is much more common in the diabetic population. So that I think is also a message from this uh, plenary. I don't know how many of us have a structured approach to this issue, but then let me ask all my panelists that what is your personal take? Are you applying adult vaccination or diabetic vaccination in your clinical practice? Or what are the obstacles you would foresee if you would like to implement this in your clinical practice? Maybe we begin with Shatrajit once again.
Hello. Yes, sir. We are using and practicing the regular immunization in the diabetic patient in our diabetes clinic. But the problem is that number one is the education or awareness of the patient. They think why we'll take these 2 shots. First they ask why 2 shots and then the price. ডাক্তারবাবু এত দাম কেন নিতে হবে এটা কি হবে এবং থার্ড কোশ্চেন হোয়াট দে আস্ক এটা নিলে কি আর আমার নিউমোনিয়া হবে না এটা নিলে কি আর আমার ইনফেকশন হবে না দিস আর দ্য রিডিকিউলাস কোশ্চেন দে আস্ক ডেফিনেটলি দিস ইজ দ্য মোস্ট কমন পিটফলস আই ফেস ইন দ্য প্র্যাকটিস
আমার মনে হয় before the second panelist takes up, COVID has given us a window of opportunity. It has taught the community the importance of vaccination. So I think we can take the clue from another sea and include that COVID taught you what is the benefit of vaccination. Yes, Akash.
Yeah, sir, as Dr. Satyajit has already pointed out, what I feel the patient's knowledge or their vaccine hesitancy, I would say, that is number one. Also, the knowledge at our part being physician, during our busy OPD schedule, short OPD consultations, we many a times keep the vaccine at the end actually. So maybe if the patient is doing too good, then we will discuss the vaccination. So we need a SOP for that. Also the cost issue is real. Second is availability, I would say actually. Even if somebody is really enthusiastic, the availability of vaccine, the absence of, I would say, adult vaccination center outside the corporate hospitals, particularly in smaller areas, is a issue. So plus a protocol, a dedicated team, a reminder system at least to follow up the patient. So these are the actual problems, I would say actually. So lack of
both
adult
physician
vaccination
inertia
center.
and patient hesitance.
Yeah, both.
And again, before Priyash takes up the same issue, me coming from a government hospital and a medical college, we do not have a supply of pneumococcal vaccine in our medicine store. So every time we prescribe a pneumococcal vaccine, we need to have a local purchase and this and that, which takes another 2 days. So it's a lot of difficulty in implementing adult vaccination, even in a government medical college. Akash, Priyash.
Sir, the thing is, as Sarah has rightly pointed out, there has been I just remembered a story. You know, why polio vaccination was made so successful? There was a strange strategy adopted by the government of India. You know, they employed religious gurus to spread awareness about mass vaccination against polio. And that's actually spread to the more nuances and more corners of the society. And thereby, in 2014, WHO declared India as polio-free country. So by overcoming barriers, we mean that there should be a team building where every individual would be a just clockwork, right? And every clock should work just fine. And then should be building rapport with the patient. Trusting the doctor with the patient is the most important thing you should ever achieve. And the routinely asking the patient whether the patient is taking vaccines, or whether the patient has got any more comorbidity, and finally answering concerns, whether the patient has got concerns, whatever ridiculous it might be. So based on these 4 pillars, I think with these barriers can be overcome.
I think the last panelist made a very important comment of including the community. I remember when we were into the first part of the HIV epidemic, and we had a brainstorming session on how to increase awareness. And then there were various icons which were discussed, like Aparna Sen, Saurabh Ganguly could be the icon of HIV. And then it was decided that no, HIV is such a subject, it's such a private issue that people will not feel at home with big shots. So then came Buladi. Buladi was somebody who was somebody living in your neighborhood. So Buladi concept came from that. এমন একজন icon করতে হবে যার সাথে public can correlate. So similarly, I think that is very well related. Any comments from the audience before we wind up? I think the young panelists have done a wonderful job.
A big round of applause for
one comment.
Our panelists and our wonderful moderator. It was an exciting session. Chinmay.
Just one comment.
I'm a pediatrician. Regarding diabetes, and one important vaccine is the pneumococcal vaccine. So after the diagnosis of diabetes, let's say if a person has been diagnosed diabetes at 30 years of age, when will you start vaccination and what schedule will you give? Will you give a PCV 13 followed by 8 weeks followed by PCV 23, or it will be a 1 year gap between PCV 13 and a PCV 23, or when it should be started?
I think I'll answer this question, make it very easy. As we've said, we have PCV 13, PPSV 23, and now we have Prevna 20. So let's make it very simple for everyone. Prevna 20 currently is the treatment or the vaccination of choice. No vaccination after that in a lifetime. Finished with it. So if your patient has taken a 13 or a 23, you plan to give another, give a 1 year gap, give 20 and forget about a lifetime. So pneumococcal vaccine now is a much more simplified picture rather than this confusion of polysaccharide or covalent vaccines. It's just, I'm using the brand name Prevna 20.
That's the only one available.
That's PCV 20. It's a little pricey, costs a little more than 5,000 rupees, but that closes pneumococcal forever.
That's a recent.
Dr. Singhania was raising this issue in many times in our CM India group, and I'm really thankful that you raised the awareness so much. So I think, Satyajit, whatever you showed the RSSDI guideline, that is old guideline that has not been updated. So what Dr. Singhania is saying, that will be the guideline. Thank you.
Shamalda.
Thank you.
It's a simple comment that I want to differ in prioritization of vaccination in diabetes. I think all diabetic patients should receive vaccination as per the guideline. Another one is another comment that when you will give vaccination in diabetes, those patients who are uncontrolled, they will have less immunogenicity. So I think patient, and at the same time they are prone to get infections. Whenever you get, there is no prioritization, nothing to say, give vaccination when patient is otherwise stable. And last one is, whatever your guidelines and your sensitization measures, everything, if government takes up and it gives it free and is included as a program, then it will be successful, I think.
Thank you. Thank you very much.
That is perhaps the biggest barrier. Barrier.
Thank you, Pankaj.
Not a government program. Thank you, sir. And please to the podium for the felicitation. I would also request the panelists to accompany sir to the felicitation podium. Moving on to another very interesting session for this Podecon 2025. We have on ethics in diabetes practice. To chair the session, we have Dr. Ajit Murmu, Dr. Ajit Prasad Murmu, Secretary IMA Purulia, Dr. Asim Sinha, Senior Physician, Medical Officer, Critical Care Unit, Devan Mahato Government Medical Hospital Purulia, and Dr. Shubhendu Mishra. Shubhendu da, are you there? Dr. Shubhendu Mishra, Senior Physician and Medical Officer, Police Hospital Purulia. And to deliberate on this, we will have none other than Dr. N.K. Singh. He is a renowned face in CMEs and meetings, a renowned physician and diabetologist from nearby Dhanbad, and also the National Vice President of RSSDI. He has a long CV, and the chairpersons maybe will allow him to speak rather than read his CV. Sir, please.
Chairperson, can I start? Yeah, so good afternoon. I think for the first time, it is on the request of Dr. Singhania that I am speaking on a topic which usually never talked so far. So I don't know what to talk, but let us discuss what are the ethical problems we are facing in our diabetic cases. So core ethical principles which I understand, number one, the respecting the patient's right to make informed decision. That is why very, very important. We just heard about the issues with the vaccine. And here also there are lots of ethics is coming up. So you have to make or let your patient make the informed decisions. And this involves providing the clear information. So whether if you are not giving your diabetic patient some clear information, there is a problem. About the treatment options, you must say. Sometimes we don't say, oh, this is very costly, you are not going to tell to your poor patients. Say it. Because in my clinical practice, what I find, if I say that this pneumococcal vaccine is 5,000 rupees, well, from a person from the town, he can refuse or she can refuse. But if you give a clear information to a rural patient, what is my experience, they agree. वो बोलता है सर if अगर हमारे स्वास्थ्य के लिए अच्छा है तो please prescribe it. So this is a contrast difference. I don't know what is your experience here, but this happens. So we have to give the clear information, enable the make choices, values and preferences, because these days I don't know that only the poor, we were lots of time we discuss the poor people and poor patients, but I think the scenario is changing very fast. The second thing that avoiding harm to your patient, so this principle guides careful monitoring of the side effects, very, very important. Preventing the hypos, so whether you have given a very clear information. I think in your clinical practice and your diabetic patients, you just take a survey, a new patient coming to you, and you say that whether you are the first physician gave you the full information, what are the symptoms of hypos, and if suppose these symptoms happen, well, how you are going to tackle. The scenario is very, very bad. Even the patients returning from the higher center, tertiary center, they are not aware when the patient is getting sudden sweating, palpitation, restlessness, tremors, what they should do. So this is the thing which is happening. So this is also very, very important that unnecessary suffering we are giving to our patients. Then at least, although you know, ethics is a very, very difficult and not a pleasant subject to talk, because suppose even if yesterday I was at the Kanpur giving a talk, today here at the Purulia, someone has sponsored my talk there, or someone was sponsoring today's my car here. So that point is very difficult to tackle. But still I think that acting in the best interest of the patient to promote their well-being, we should do what we can do after that also. So how to maximize benefits is very, very important. And lastly, the fourth part is ensuring the fair allocation of healthcare resources and equitable access to care in Indian context. So this is again very, very important. So core ethical principles in diabetic care we basically discuss with the autonomy of the patient, the beneficence, that is the balancing the treatment intensity and the patient's well-being, and then first do no harm in all diabetic treatment decisions like other diseases also, and addressing the healthcare inequities and diabetes management. And you know, in our India, our fragmented healthcare system, private sector dominance, and financial impact is doing, you can say here the private sector is here 70%, and the public sector something around 30%. So this is a huge difference which we are getting today. So let us discuss about the burden, the clinical dilemmas, the consent and equity and systemic issues and other things. So there is, I told you, there is a very big gap in the awareness, and diabetes is a disease where awareness is very, very important. So as a first ethical principle, we should think how to raise awareness about the preventive part. Suppose a diabetic patient you are treating, have you asked or have you educated his son or his daughter that you are also in the risk zone? You should take proper exercise or proper diet. And the huge economic burden is the second part, which is when whatever I want, suppose a patient of atherosclerotic heart disease, and I know that, well, here GLP-1 is very, very important, RA, the drugs are so important, but sometimes I'm hesitating, should I write or not? Because it is, the cost is a big problem, so that part is there. And then many times when we are right, people, because you know, lots of the people are today the Google savvy or the AI savvy, they will immediately put your drug in the AI and they will say, oh, here, reject the dapagliflozin. It is called as something like so, and the big picture of hernias gangrene someone putting up there. वो बोलता है सर आपने कैसा दवा लिख दिया ये तो यूटीआई करेगा विल डू द जेटीआई एंड यू हैव रिटन सच ए ड्रग एंड इवन मेनी टाइम्स आई फाइंड कि सर माय सुगर इज 95 but my urine sugar is showing 4 plus. This is a big problem. And lots of, yesterday I got a case, I think 2 days back, from a gynecologist. He told me, Dekho, your sugar is 95, but you are getting urine sugar 4 plus. I don't know what is the problem. So you go and meet your doctor. So I think it will be much better to tell the patient from the very beginning, okay, look, I am giving you a drug. When you will take, even the blood sugar is controlled, due to the mechanism of action of this drug, the urine will be passed, urine have glucose, and it will show 1 plus, 2 plus, 3 plus. So this is the how a clear information should be given. And then the resource scarcity in diabetes care is so much. I think the most important dilemma which we get, persistently high level of HbA1c, 9%. But sometimes we feel, oh, kya problem and no problem. And lots of cases we are getting, sir. 9%, 9.4%, 9. Even the 10%, no problem, you are going, say, repeating the same drugs and same drugs. We are not going to intensify. So there is lots of inertia there. That is known as therapeutic inertia, and that is a very, very great ethical challenge in our part of practice. Sometimes we over-treat, sometimes we under-treat. So how to balance these approaches requires careful consideration of individual's patient's factor and shared decisions. That is very, very important. So see here, a patient coming with HbA1c of 11% and refuses insulin due to fears about its cost. The physician says that the patient's financial constraints and withholds the necessary insulin, and decision ultimately leads to patient developing retinopathy. So where legally we are here bound, you see here, because you have not started insulin. Maybe the reason that you have not properly educated your patient ki this time the insulin is so much required, and only due to the cost factor or needle the fear of needle, you have patient, sometimes we are failing to give some time to our patient that it is so, and here patient developed retinopathy, and suppose someone says ki retinopathy by due to the uncontrolled sugar, maybe even some legal problems sometimes. So how might healthcare system resolve such conflicts is very, very important challenge to us, this affordability dilemma. Then the barriers of informed consent, that 27% of rural population struggles with illiteracy, making it difficult to comprehend complex medical information. Lots of language barriers are sometimes there. So it creates a fundamental barrier to informed consent as patient cannot read or understand, because whatever you are writing in English basically. You are not writing, you are even giving your instruction, you take 1 time, 2 time, before meal, after meal, whatever you are giving in some language which your patient do not understand. So this should be also, I think these days even the EMR this is an era of EMR, that language can be changed, and so, and then our legal framework for the informed consent is also very, very problematic. So special attention to insulin initiation and education should be there. Clear explanation of the hypos I told you, and also discuss why it is important, the long-term complications, explaining medication cost and alternatives. So with that, the socioeconomic disparities I told you, geographic and gender divide is so much there, and public-private healthcare divide is there. And then the pharmaceutical industry influence, this is happening to each and every part of our practice. Remember, sometimes I have read to some medicine only because some pharma has sponsored me to some conference. This is a reality I admit. I don't think you admit or not. So this cycle perpetuates itself, creating a system that prioritizes profit over patient's care. But still, I will urge that patients should be taken first, and marketing marketing-driven prescribing practices should be avoided as far as possible, I will say you. Because you know you cannot run a conference without this pharma-driven help. And even today, after my session, I think lots of pharma-driven sessions will be there. Take the best part of that. But even then, considering that what we can do for our patient is very, very important. Then the digital divide is there. I told you, limited internet access, but it is also going to be ruled. I think even in the rural part now, internet is fully available in most of part in the rural. So this is I think the old data. And then psychological, social care is also important, the mental health that we are not doing. And so that way the patient autonomy is very, very important. And risk-stratified treatment, hypoglycemic audit should be done, and promoting justice and equity in diabetic care. Or where is the problem? Let us see here. The path forward, a call to action, and ethical implications of diabetes complications, because I told you that any complication patient is developing, he can sue you for the legal problems like nephropathy, retinopathy. And sometimes I feel that patient is needing a DAPA or GLP-1 RA and you are not starting, there is a very, very big ethical challenge there. Only due to the cost problem, you are going to do or not. Because even today, the GLP-1 RA, some generic brands have become very, very affordable to our patients. It hardly costs something around 2,000 rupees per month. That is not a big deal now. So that should be taken care. And then many times I find that lots of people are coming with traditional medicine, and lots of traditional medicines are in here. Even from the patients at Purlia, everywhere, people will come use some churan and everything, and leading to the CKD or other things only due to this. Many times at Ranchi, I am aware that when the sample was tested of that Ayurvedic medicine, it was containing sulfonylureas in big quantity. So this is happening. So lots of things are important. So traditional medicine, because sometimes the traditional medicine could be beneficial, but you are not aware, we are not aware for that. And then this part I am showing, when something is needed, you should do it. Let us see. No longer it is ethical and scientific. Let us analyze this part. Today, you are well aware, everyone diabetic is well aware that more than cardio-renal metabolic immense benefits are only with 3 drugs. Remember, you are saving the regimens, like you are giving some patients a RAS blocker, SGL2 inhibitors, and this non-steroidal MRA, all available to you. And if you, today the most recent paper is showing that even in a newly onset diabetic patient, if you are starting these drugs, you are saving CKD more than years of follow-up, you are saving the life by more than 12 years, 15 years. Patient will be much better, will be not develop CKD and other things. But only due to clinical inertia, cost factors, and other things, we are not able to start it. It is a big ethical challenge. So you see here, so I will tell you, you test for albuminuria very early, and whenever needed, whenever there is some albumin or UACR is in abnormal range, start RAS blocker and SGL2 inhibitors. That is the most important part. And if it is possible, add this finerenone without delay, although it is 70 rupees tablet, but in days to come it will be definitely going to be cheaper. So then you can sell this diabetic problem in clinic without unethical challenges. With that, I think we have got only 2 minutes, so it's in clinical research and diabetes is very, very important. Role of family is important, and ethics of diabetic preventive strategy are important, and end of life with diabetes complications. These are so many things to discuss in ethics, but most important part is also with the technology, because we know in many parts even the CGM has become very, very essential for our diabetic patients. But I think the latest, this about Pro, I think they have become become more costly. So it becomes very difficult for my patients too, this digital divide. And evolution of healthcare providers, advocacy and empowerment. But remember, the corporate social responsibility in diabetes is also very, very important. And this insulin market you see, now Mistad is not available to many parts of the India. And people are coming to us. So what is the reason? You know the reason. I think we are well aware of the reason. Because they have GLP-1 market is more profitable, so you are withdrawing the insulin. So this is happening. And then it cannot be a more ethical problem with that. So these are the few things that policy reforms from the government side should be also there, and the ethics committee in diabetes care is needed. So with that, I think most of part I have covered you. We need a systemic reform, professional ethics, equitable care, an integrated approach, and this is the time for action is now. So I think my last message is that in spite of all sponsorship, let us do most of what possible to do good for our patients. And we educate our patients, in all patients, give at least 5 minutes for the diet and exercise consultation. This will not be given by your dietitian and your some physical fitness person. Take 5 minutes, because yesterday I gave my 2 talks at the Kanpur, and there was a big research in the Nature just published that if my grandfather walked for 2 hours or 1 hour, my grandfather, my grandmother, I am protected today. And if I am doing exercise today, my grandson will be protected with the diabetes. A clear research is showing. It is just in the December issue of the Nature. You can read that. So lots of things are happening. Dr. Singhania, thank you very much. I am really surprised. This is a big one, very important part of conferences in India. And this part, thank you very much. Thank you, Chairperson.
Thank you. Thank you, sir, for enlightening us as always. Chairpersons.
Thank you, sir, for your valuable opinion regarding the ethical matter of diabetic treatment, anti-diabetic treatment. You have truly said that most of the problems, not only in diabetes, but in every sphere, if we counsel the patient properly, we give some time, I think a big number of problems, a big percentage of problems can be tackled with. But the problem is that sometimes when we make aware the patients, sometimes there is miscommunication also. It is one of the biggest factors later on. And regarding use of insulin, what we have said, more than 9%, 2 problems I have noticed. One problem arises from when the diabetes is controlled and accidentally or by chance the patient goes to another physician and he changes the medicine.
Exactly.
What you have said. Exactly. Then if anything happens, it goes to both the your doctors. Who is right, who is wrong, is not possible for him to understand. Number one. Number 2, regarding insulin therapy, it's a huge social taboo. In spite of so much publicity and so much use, I have seen high category of patients in police department, big officers, they will not take insulin, but insulin-like medicine injections. And they had a big problem after use of that, but they will not go for conventional insulins.
Exactly.
So it's a big issue, sir.
Exactly.
Thank you, sir.
Thank you, sir. Thank you, Speaker and Chairperson. Please, for the photograph and the felicitation. We, at the end of the last session, we have wonderful high tea. Those of you, I hope you enjoyed the lunch. We have high tea down in the field along with the traditional Chau Nach of Purulia, and for everyone to enjoy. So please stay back for the last few sessions. For the next session, I would like to invite and I'd like to invite on stage Professor Shamul Kundu, sir. Shamul Kundu, sir, is here. Dr. Mahua Mahanti. Dr. Mahua Mahanti is a Deputy CMOH of Purulia Health Department. And Professor Shukomol Bishoy. Shukomol Bishoy, sir, is Medical Superintendent cum Vice Principal of Purulia Deben Mahato Government Medical College and Hospital, and he is the first MSVP of Purulia Medical College. Still, sir. Please, sir. Yes, after starting medical college, you were the first MSVP. That is what I know. Shamul Kundu, sir, please. And I will be doing the honors of speaking on this topic. फुल स्क्रीन कर सर निकल रहे हैं अच्छा ना এটা দেন এটা দেন স্লাইড শো হচ্ছে না স্লাইড শো একটা ওপেন হয়ে আছে ওই জন্য হ্যাঁ
Good afternoon. Thanks from the chairperson side for inviting us as a chairperson in this session. And if I want to introduce Pankaj Singhania, I think the audience will stop me immediately. So, Pankaj, please start.
So let's not waste time.
Yeah.
So
Please start.
I'll be talking about this. We've been discussing obesity, type 2 diabetes, metabolic syndrome, inflammation since today morning. With wonderful sessions, PG paper presentations, a huge, wonderful panel of speakers, chairpersons, everyone. And these are the two molecules in GLP-1 receptor agonists which are currently available. Semaglutide, which is a more older molecule, it is a GLP-1 receptor agonist. And we have another one which has been making headlines in India for the last maybe 6 months or so, tirzepatide, which is a dual agonist to the GLP-1 RA GIP agonist. Let's try to find out how they are different and maybe which scores over the other. Clearly, tirzepatide has made a lot of noise, lot of prescriptions, lot of drastic weight losses, but semaglutide has got volumes of data in its favor also, and we cannot write off semaglutide, either the oral or the injectable one. Recently, Ozempic was also introduced in India. Wegovy was there, and Ribelsus as an oral semaglutide is available in India for almost many years now. So I have no financial disclosures regarding this, but this is a sponsored talk by Novo Nordisk. So obesity is a chronic relapsing progressive disease associated with adiposity, abnormal adipose tissue. Satyanath sir was today talking about white adipose tissue, which is normal and dysfunctional. If white adipose tissue becomes dysfunctional, it leads to production of adipokines, now known as organokines, a lot of inflammation process going on in the obese people and those with diabetes. So this is the obesity picture of India. Look at the staggering number of people, 254 million people living with generalized obesity and 351 million adults living with abdominal obesity, which we know abdominal obesity is equal to visceral adiposity, and that's the harbinger of disease. The complications. Look at the huge list of complications. It's almost everywhere from head to toe. If you start from the head, it's a cerebrovascular disease. Peripheral nerves, arteries, GRD, GI issues, respiratory issues, everything and anything, and maybe osteoarthritis. All those people who come to you with knee osteoarthritis are generally obese, and you advise them weight loss. Many of might not need the knee replacements which our orthopedic colleagues are fondly doing these days. So progressive weight loss has dose-dependent and tissue-dependent biological effects. Like, what do we mean by meaningful weight loss? At least a 5% weight loss is considered to be meaningful. You go to 10%, you get more benefits. You go to 15%, you got more benefits. You go to 20%, you get more benefits. You go even higher, you can have reversal of diabetes. You can have reversal of MASLD. Reduction in all of these will lead to improvement in your metabolic. The term which we use, diabesity. Diabetes and obesity. Mind it, I'm talking about type 2 diabetes only. I'm not talking about type 1 diabetes or gestational or pregnancy associated diabetes. So lifestyle measures, Shubhankar sir today while talking about MASLD, he clearly highlighted in bold that the most important measure for MASLD is lifestyle. Diet and exercise, a hypocaloric diet, a high protein diet, cutting down on sweetened beverages and sugars, restricting your calories in time, reducing your portions, using only water as your preferred beverage, etc. is the lifestyle measure that you're targeting. Exercises, Piash today said 150 minutes of exercise per week, at least 5 days a week, with no 2 continuous days without exercise. That is what we mean by good exercise. And it could be any form of exercise, just simple walking, brisk walking, aerobics, yoga, pranayam, anything that you want to do, exercise, or in a gym maybe. So this remains the cornerstone of management of obesity. Howsoever I may advise my patient, any kind of medical therapy, surgical therapy, bariatric surgery, XYZ. So that will give you a weight loss of 3 to 5%. There was a patient who came to me yesterday whose height was 170 centimeter and that patient weighed 135 kgs. His BMI was 47.5. So as the nutritionists were discussing today, for ideal body weight, you need to subtract 100 from the height in centimeters. So for 170 centimeter, the ideal body weight is 70 kgs. He is 135. That is, he is overweight or obese by 65 kgs. Can diet and exercise help him with 65 kgs? That's a big question. Howsoever I may push, howsoever I may scold, howsoever my dietitian have sessions with him over hours together, he may run the whole day, not eat the whole day, but 65 kgs is oblivious for him without the physician's help. So there comes the gap. 3 to 5%, that person at the best, after all my scoldings, will land up with a weight loss of 5 to 10 kgs. What about the rest? I want 70 kgs. Or maybe I will be happy with 80 or 85. I'm compromising. So that is what happens, is the pharmacological gap. There I need to help the patient get motivated, add some more weight loss to his spectrum, and maybe try to reach the target that I have set, a BMI, an ideal BMI of less than 25, 70 kg for 170 centimeter height. So, and you know, bariatric surgery, especially the diversion bariatric surgeries or the malabsorptive ones, can give a weight loss of 30 to 40%. But bariatric surgery is not everyone's cup of tea. We do not have bariatric surgeons available to all of us. There are complications. There are post-bariatric surgery weight gains. There are complications, and many patients cannot afford bariatric surgeries. Government hospitals do not do bariatric surgeries. So do we now have drugs which can give us bariatric range weight loss? Yes. So that is where we are introducing Wegovy or injection semaglutide, which is a GLP-1 receptor analog. What is exactly GLP? Glucagon-like peptide. GLP is expressed at multiple places in the body, in the brain, hypothalamus, liver, pancreas, even in the stellate cells of the pancreas and adipose tissue and everywhere. The primary mechanism by which semaglutide acts is it has 94% homology to GLP-1. We had a lot of GLP-1 analogs from the beginning. We initially had liraglutide, dulaglutide, albuglutide, and the first one was exenatide, which was extracted from the saliva of Gila monsters. These had to be given as daily injections. There were more problems with the injections, and they had some homology with GLP-1. They did not match GLP-1 to 94%. So semaglutide has 94% homology with GLP-1, and it is to be given a weekly injection because the half-life is 1 week. So weekly injection perhaps is easy to convince to a patient compared to a daily injection of liraglutide or the other ones which had to be taken in the past. So it acts in the brain, hypothalamus. We know the hypothalamus harbors the satiety and the hunger centers. It acts over there through various mechanisms, some of which are not yet clearly known, reduces appetite, reduces craving, and gives a sense of fullness. You feel full even after eating a little. You do not want to binge. You do not have craving for food, and thereby your metabolic profile and your obesity also improves. And there can be drastic improvements in your glucose profile also. So it is very much an anti-diabetic drug also, not just an anti-obesity medication. So semaglutide is available as injections from 0.25 milligram onwards up to 2.4 milligram weekly intramuscular injections. The highest dose is 2.4 milligram, and semaglutide 4 milligram increases satiety, makes your patients feel less hungry.
And hedonic, what is hedonia? Hedonia is eating even you're not hungry. Like, I was not hungry, I decided to have lunch. I ate lunch, then I ate the sweets, then I ate everything, though I was not hungry. This is hedonism, or eating without hunger. This hedonic eating is also reduced with the use of semaglutide injections. That is clearly craving. So what are the various programs, what are the various studies that we have with semaglutide 2.4 milligram? The most important trial is the STEP trial. The STEP trial, as you can see the data from the STEP trial, you can see as the dose was escalated, you can see at the bottom 0.25 milligram gradually. We increase doses every week or longer to let the patient tolerate the dose. These drugs have minimum GI side effects, so we cannot start with a higher dose. We start with 0.25 milligram, gradually going up the ladder up to whatever dose the patient can tolerate. So across the spectrum triad, STEP program, semaglutide was compared with placebo as an adjunct to Wegovy. Placebo, that means no semaglutide was given, but diet and exercise or lifestyle measures were done in both the arms. So what are the weight loss benefits? Up to 18%. Look at what I was talking of. I was talking of 20-25% weight loss with bariatric surgery. A drug is giving us bariatric-like weight loss. More than 20% weight loss in a third of the patients. Another great achievement, more than 20% weight loss. And sustained weight loss over 4 years with Wegovy. But mind it, we are continuing Wegovy treatment. Wegovy treatment or injection semaglutide is not given for 6 months or 1 year. For people with diabetes, you have to tell them it's an anti-diabetic drug, so you have to continue it. There are patients who have gone off insulin. They are no longer taking insulin when they are losing weight and controlling their metabolic profile with injection semaglutide. So 18.2% mean weight loss with injection semaglutide in the STEP trial, compared to the other doses of semaglutide, compared to liraglutide, an older GLP-1 receptor agonist, and placebo. So the weight loss benefits, 9 out of 10 participants across the STEP trials lost weight, 5%. 3/4 of the patients lost 10% of the weight. Half of the patients lost 15%, and a third of the patients lost more than 20% of their initial body weight. So more than 20% weight loss is something great. We are looking for, we send patients for bariatric surgery for these kind of weight losses. No patient can do it with diet and exercise. A drug is there which can help us do this. And these are the various STEP programs, STEP 1 to STEP 7. These compare against placebo and against liraglutide, against various other molecules. You even have the STEP teens program where semaglutide has been tested in subjects which are older than 12 years but lesser than 18 years. But mind it, in India we do not have approval for semaglutide below 18 years of age. So we can use it in all adult patients above 18 years of age for either the treatment of obesity or diabetes. And when we do a DEXA scan, as Ayan was discussing today, DEXA is the gold standard for bone mineral density. DEXA is also the gold standard for body composition analysis. And a body composition analysis done before and after initiating semaglutide also showed significant improvement in terms of lean body mass. The adiposity was also improved with semaglutide. There's always a concern with weight loss medications, weight loss therapies of losing muscle. You lose muscles, you lose fat. I always tell my patients, lose fat, do not lose muscle. That can happen with resistance exercises, that can happen with a high protein diet, and perhaps semaglutide also helps improve lean body mass compared to other forms of weight loss therapy. So plus 4.5 kg improvement in hand grip. Hand grip is another way in which you can measure the muscle strength of an individual among the various measures of measuring sarcopenia or muscle loss. So beyond weight loss benefits, these are the waist circumference benefit, HbA1c reduction, CRP, a very important marker of inflammation. HSCRP is one important surrogate of atherosclerosis. Some of our cardiology colleagues use that. Systolic blood pressure reduction, diastolic blood pressure reduction, reduction in triglycerides. So semaglutide provides benefit across the whole cardio-diabetic spectrum, beyond glycemic control and weight loss in people with cardio-diabetes, with diabetes, with diabesity, and therefore it is also now a very important tool in people who are having pre-existing cardiovascular disease, particularly coronary artery disease. It is now prudent that our cardiology colleagues refer or prescribe a GLP-1 receptor agonist to people with diabetes, to people with obesity and coronary artery disease. This should be the preferred drug in all the algorithms by ADA, RSSDI and ESD. GLP-1 receptor agonists now are among the top of the recommended drugs for the treatment of diabetes or obesity in people with CAD. So that's 20% significant 3-point MACE reduction is demonstrated in the SELECT trial, which is the series of trials for semaglutide and GLP and cardio benefits. MACE reduction, as you've seen. Heart failure. For heart failure, I believe SGLT inhibitors should be the drug of choice in terms of cardiac benefit. Even SGLT2 inhibitors are being used in people who are not diabetic. For Wegovy also, semaglutide, we are also having current data where semaglutide has been also shown to improve outcomes in heart failure, particularly in people with heart failure with preserved ejection fraction, of which we have very little forms of treatment available other than the SGLTIs. So these are some more trials in the CV benefits of Wegovy, the SELECT trial, lot of data, comparing it with tirzepatide, which is a dual agonist. So 57% reduction in 3-point MACE with semaglutide, 57% reduction in 3-point MACE versus tirzepatide. So semaglutide was better than tirzepatide in terms of 3-point MACE reduction in people with cardiovascular diseases. Kidneys, we have the FLOW trial data now. Our nephrology colleagues will agree that semaglutide has been shown to improve albuminuria, improve reduction in GFR, and reduce the number of people who are going to end-stage renal disease. Knee osteoarthritis, obviously, weight reduction, osteoarthritis will improve. And safety is proven beyond doubt. Only the GI side effects have to be taken care of in multiple trials. And semaglutide can be safely, slowly, stepwise, as the STEP trial with proper counseling can be initiated in a lot of our patients with diabetes, with obesity, with coronary artery disease, with HFpEF and with CKD to improve their outcomes and increase their quality of life and longevity. Thank you so much for your patient hearing.
Thank you. First of all, very good afternoon to all. And first of all, I want to just offer a big thanks on behalf of District Health and Family Welfare to Dr. Singhania for such a good, beautifully arranged seminar for the whole day. And we all doctors of Purulia district, we got enriched in such a good topic on diabetes, as we have a program on non-communicable disease, and we all had so many knowledge gap in these issues. Now I have only one query, a simple query.
Please, madam.
On this topic. I just want to know, sir, actually this medicine is a long-term weight management medication. So I just want to know that whether this medication, whereas this is a burning issue, obesity, and this is a burning complication also in all comorbidity, all
Yes, madam.
complication. Now, whether it can be used below 18 years, and if the patient is non-diabetic, in that case we can use this only for weight reduction or not?
Yes, madam, we can use it for weight reduction. Ozempic and Wegovy are two brands of semaglutide by Novo Nordisk. One is for diabetes and one is for obesity. They are the same thing. So it is now approved in India for the treatment of obesity only without diabetes. For children less than 18 years, it is approved in the West. Currently in India, we do not have any approval. No, madam. No. Shatrujit.
Thank you, Pankaj, for your excellent deliberation on the semaglutide. You have told the various effect or beneficial effect of semaglutide on the different systems, but nowadays there is a recommendation of use of semaglutide in the peripheral arterial disease. We had very few options previously. Now, but a STRIDE trial shows that there is the. What is your opinion regarding this?
Yes, as I've already said that semaglutide will reduce inflammation and therefore may reverse or reduce the burden of atherosclerosis. Peripheral arterial disease very much is an atherosclerotic disease beyond the cardiovascular bed. So some data is coming regarding the use in people with peripheral arterial disease, provided they have some amount of vasculature remained which can be recanalized. For people who have a critical stenosis, needs to be going to our cardiothoracic or cardiovascular colleagues for some revascularization. The data regarding peripheral arterial disease is not yet very bright.
Thank you.
Thank you.
Pankaj, one
Yes,
the
yes, sir.
question.
Sir, Shyam sir,
One
could
for-
One question. I have one. Is there any data, or we usually, once upon a time, there was a rumor, or there was such topics or ideas that semaglutide increases the suicidal ideation.
Yes, that's a very recent. It is in Australia. In Australia, there has been a recent data, particularly in the general newspapers, that more than 5 lakh people who were using semaglutide have landed up with suicidal ideations or depression-related issues. But I don't think so that is substantiated in any of the large trials that have been done with semaglutide, whether it is the STEP trial, whether it is a SELECT trial, whether it is the SUSTAIN trial or the FLOW trials. So the data regarding this is missing, and you might counsel or may not be refrain from giving it to a patient who is schizoid, depressed. Like many of our schizophrenia or depression patients also suffer from diabetes and obesity. Have a word of caution regarding this. Counsel the patient and the family members. Keep regular follow-ups and see if these keep a check with the psychiatrist who is treating the patient, and maybe keep a check as to whether your intervention is worsening the psychiatric issues. It's more of a media hype rather than a reality.
Actually, in certain countries, they used to provide some toll-free number.
Yes, yes. We also provide various kinds of helpline numbers and supply numbers for people who are using these drugs. And there are a lot of literature available which we also share with our patients so that they can ask us any queries.
Thank you.
Thank you, sir. Kundu, sir.
One small, whether there is, how far is the risk of NIAN?
NIAN. Non-ischemic optic atrophy. That's also another very discussed topic of late, particularly from the US, where a lot of patients had sued the manufacturing company for non-ischemic optic atrophy of the optic nerve after the use of semaglutide. A causal relationship has been established between the two, but a causal relationship has not been established that semaglutide caused this. There can be various other causes of optic atrophy or NIAN also. This, and the incidence is very, very low. Very, very low, maybe thousands or even more patients taking 1 or 2 cases out of that. So it's like many of the drugs and the various adverse side effects that we go. Like sulfonylureas cause hypoglycemia. They do cause hypoglycemia. Insulin causes hypoglycemia. But there are thousands and thousands of patients who benefit from insulin and sulfonylureas. And so we use them regularly for the benefit of the larger. Obviously, these lesser side effects or these difficult or litigating side effects are being probed into by the manufacturers, and we might have some convincing data.
আমি আর একটা দুই একটা কথা না বলে পারছি
Sir,
না।
sir, sir.
I am very proud, feeling proud that I am the chairperson of such a speaker like Dr. Pankaj Singhania. By default, I am the senior of his same college.
We are both from Medical College, Calcutta. Sir is also an ex-student of Medical College.
এই টোটাল এন্ডোক্রিনোলজিস্ট এবং এন্ডোক্রিন রিলেটেড ম্যাটারটাকে এইভাবে ইন্টিগ্রেটেড ওয়েতে হোল ডে প্রোগ্রামটা করেছে, এটার জন্য ডেফিনেটলি স্কিল দরকার, এবং সেই স্কিলটা কতটা আছে এটা আমরা মানে পেয়েছি। আমরাও তো বিভিন্ন পাবলিক হেলথ প্রোগ্রামের সাথে রিলেটেড এসেছি। তো যাই হোক, আমি আদার দ্যান দিস একটা জিনিস এই পুরো প্রেজেন্টেশনটার থেকে একটু অ্যাড করতে চাইছি, যে মানে ইট ইজ মাই এক্সপেরিয়েন্স সিইং এ পেশেন্ট অন সেমাগ্লুটাইড। Once semaglutide started, the patient needs no further management, like no physical exercise, no dietary restriction, and no anti-diabetic drug, because the patient is not in a position to do physical exercise or to take dietary রেস্ট্রিকশন। এই পজিশনেই সে থাকবে না, এমন একটা পজিশন হয়ে যায়, তার আর কিচ্ছু লাগবে না, বেড ইজ
মানে স্যার তিনটে কথা, অ্যান্টি ডায়াবেটিক কথাটা ঠিক আছে, ইনসুলিন বন্ধ হয়ে যাচ্ছে, ওরাল ড্রাগস বন্ধ হয়ে যাচ্ছে, কিন্তু ডায়েট এন্ড এক্সারসাইজ করা উচিত।
স্যার করা উচিত, মানে আমি বলতে চাই
নালে দুর্বলতা হয়ে যাবে, উইকনেস হয়ে যাবে, এতটা উইক হয়ে যাবে যে প্রোটিন না খেলে, ফিজিক্যাল অ্যাক্টিভিটি না করলে ওই লিন বডি মাসটাও থাকবে না।
স্যার আমি ওইটা বলছি না, আমি বলছি যে পেশেন্ট এমন পজিশনে থাকছে, আমার দেখা পেশেন্ট সে এক্সারসাইজ করার মতো অবস্থাতেই নেই, সে আর ডায়েটারি কিছুই খাচ্ছে না, রেস্ট্রিকশনের প্রশ্ন আছে কোথায়? কিছুই খাচ্ছে না, অ্যাপেটাইট এরকম জায়গায়
একদম 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 না এবারে এবারে obviously
কোনোটাই তার মানে কোনোটাই লাগছে না।
there has to be the proper selection of patients. We have to properly select patients to do that, and proper diet and exercise counseling has to be done before initiating on these drugs. Thank you.
That very gradual increase of dose is also
Very important. And obviously cost is a factor, though now the cost has been reduced
drastically. As well as selecting the patient.
Yes.
This is very important. Okay.
Thank you. Sir. Thank you, sir. Thank you, chairpersons.
Quickly moving on to the last two talks, which will be chaired by Dr. Abhishek Kundu. Dr. Abhishek Kundu is District Tuberculosis Officer and an acquaintance of some time. Dr. Prabhat Pawan Kumar. Dr. Prabhat, are you there? Dr. Prabhat is Medical Officer at Custard Block Primary Health Center, and Dr. Shomik Bauri. Dr. Shomik is a BMOH of Banda Block Primary Health Center. And there will be two talks in this session, which will be by friends from allied specialities from cardiology. The first talk will be given by Dr. Kshatrendra Nath Datto, who happens to be the son of soil of Purulia, currently practicing as an intervention cardiologist at Health World Hospitals, Durgapur. Sotten will be talking on spectrum of heart failure in diabetes. Diabetic patients get recurrent hospitalizations for heart failure, HFpEF, HFrEF, etc., etc. Let's see what Sotten has to tell us about heart failure.
Very good afternoon, everyone. So from the dawn of a lot of academic extravaganza, we are now at the dusk, and I would like to shorten my presentation to a minimum possible slides and make it interesting if I can. So heart failure, it's a deadly thing. It's almost 1 in 3 people who are sick are now having some degree of heart failure symptoms. It progresses despite every treatment, and 5-year mortality rate is also higher than some usual cancers, slow-growing cancers like prostate cancers. And the cost burden of the therapy has an immense cost burden on the budget of health care therapy. So what is the association of heart failure along with diabetes? As you can see in the chart, diabetes is the most common comorbidity faced in heart failure patients, going hand to hand with hypertension. Almost 50% patients nowadays having diabetes who are having heart failure symptoms. So how are the Indian heart failure patients different? The projection is that heart failure patients number are going to increase day by day in our country. Because of aging population, because of rising coronary artery disease, still the prevalence of rheumatic heart diseases and persistence of untreated congenital heart diseases. So these are also morphologically and clinically different from other heart failures, because Indian heart failure patients present earlier than others. The male-female ratio is hazardously raised in case of males, and RHD is one of the most major contributor to the heart failure patients. So 50% chance of a diabetic to develop heart failure in his lifetime. The mortality rate is alarmingly 10 times higher than a non-diabetic, and 5-year survival is 12.5% compared to a non-diabetic patient. So these are the mutual associations. You can see known risk factor, diabetes is a known risk factor for heart failure, and heart failure, because of heart failure, sustained renin-angiotensin system activation can promote metabolic dysfunction and insulin resistance, leading to impaired glucose tolerance and diabetes. this is the pathophysiology. I am not going into details. The basic problem is that due to diabetes, there are vasculopathy and endothelial dysfunction leading to coronary artery disease, ischemic cardiomyopathy, MI, leading to heart failure, mainly with heart failure with reduced ejection fraction. And these inflammation and endothelial dysfunction may lead to diabetic cardiomyopathy with normal coronaries without any atherosclerotic involvement of the coronary arteries, both leading to heart failure symptoms. Another concept is a heart failure with preserved ejection fraction, where you can see visceral and adipose tissue increases, and type 2 diabetes mellitus, kidney disease, hypertension, heart failure with preserved ejection fraction. So the development of heart failure in diabetes may be mainly attributable to three mechanisms: coronary atherosclerosis, associated comorbidities like hypertension, dyslipidemia, CKD, and diabetic cardiomyopathy. These are the non-modifiable factors, where increasing age and development of ischemic heart disease. So modifiable, we can modify these things: hypertension, obesity, uncontrolled hyperglycemia, and dyslipidemia. So why are we talking so much about heart failure in diabetes? Heart failure is one of the most common cardiovascular complication of type 2 diabetes, most disabling and deadly complication. Most patients with heart failure have their diabetes or pre-diabetic dysglycemia, and diabetes is one of the most disabling comorbidity complicating heart failure. So patients with type 2 diabetes are mostly, first presentation of heart failure is younger in cases of diabetic patients. When we compare it to non-diabetic patients, it's almost a decade earlier the patients with diabetes presents with heart failure symptoms compared to non-diabetic patients. As we can see, the presence of diabetes increases the risk of 1 year adverse clinical outcomes in patients with heart failure. As you can see, 1 year all-cause mortality, all-cause death is significantly higher in diabetics compared to non-diabetic, with a statistically significant p-value. So heart failure and diabetes, with each 1% increase in HbA1c, there are 8% increase of risk of heart failure. It accelerates the development of CAD, often associated with hypertension, promotes development of fibrosis, and increased autonomic dysfunction, worsening renal and endothelial function, and neurohormonal activation. So this is a ESC guideline showing the treatment, GDMT-based treatment module for diabetes, where there are 4 pillars of treating chronic heart failure, including beta blockers, ACE inhibitor, ARB, ARNI, MRA, and SGLT2 inhibitors. We are going to talk about 2 of them, which are related to diabetic patients. Firstly, ARNI is a psychobacterial valsartan. As you can see, it's a wonder drug. After discovery, it has shown that in paradigm heart failure study, which is a once in a decade or once in a 50-year study, we can say, which has shown overwhelming results and has been stopped midway of the study, which shows significant reduction in all-cause mortality when the patients were being treated with sacubitril valsartan compared to historic data of enalapril treatment for long-term in heart failure patients. So irrespective of the presence of diabetes or not, as you can see, 34% of these patients had diabetes at that time of enrollment, and the benefit was well equally distributed among diabetics and non-diabetic patients. So the primary outcome, there were 20% reduction in CV death and heart failure hospitalization in ARNI when compared to enalapril treated patients, 20% reduction in CV mortality, and 21% reduction in heart failure recurrent hospitalization. Secondary outcomes, we can see 16% reduction in all-cause mortality with ARNI, and ARNI was supposed to be superior than enalapril in this study. And there are no significant adverse event like atrial fibrillation or renal dysfunction. As you can see, when we compare 3 renin-angiotensin system modulators together, we can see angiotensin receptor blocker, ACE inhibitor, and ARNI. We can see there are added 20% reduction in all-cause mortality when compared to ACE inhibitor. In this study, that was enalapril. It added to the benefit of enalapril about 20%. So this is a landmark trial, that paradigm heart failure, and this drug has been included as a class 1 medication in treatment of heart failure. It's been almost a decade now. So as you can see, CV death and hospitalization the patients with diabetes, undiagnosed diabetes, pre-diabetes, normoglycemic overall, every patient had a better outcome with sacubitril valsartan when compared to enalaprilate therapy. Same thing shown here. This is an interesting thing. This was a post hoc analysis where the patients having diabetes are being treated with sacubitril valsartan and enalaprilate have been compared with their HbA1c trajectories. As you can see, with time, the HbA1c reduction with same therapy, the ARNI group has a significant reduction compared to enalapril in reducing HbA1c over time, as you can see, and this effect persisted for time from 1 year, 2 year, 3 year with long term of therapy. So, patients receiving sacubitril valsartan were more likely to have an improvement in HbA1c category at 1 year compared to those receiving enalaprilate. As you can see, the net change has been shown in the graph. So, this is a post hoc analysis where this has been studied. Fewer subjects in the sacubitril valsartan and enalapril group were initiated on insulin therapy. During the therapy, fewer patients had worsening glycemic control. Those for that they have to start with insulin, and 0.13% decrease in HbA1c in patient with ARNI compared to those receiving enalaprilate. So, effect of sacubitril valsartan, we can see patient with diabetes and HFrEF enrolled in paradigm heart failure who have received ARNI arm compared to enalapril had a better outcome with glycemic control as well as HbA1c reduction. These are the therapies which you can see. This is a list where we can see the above all drugs, the so ADA also have advised using coming to SGLT2 inhibitors now. So ADA 21 recommendation, SGLT2 inhibitors are now preferred OHA in diabetes patients with atherosclerotic cardiovascular disease, heart failure and CKD. As we know already, a lot of speakers told about SGLT2 inhibitors. SGLT2 inhibitor has a different role in our therapy. It's now a heart failure drug along with a diabetes drug. We use this irrespective of the glycemic status of the patient, and it has shown drastic result in a lot of studies. These are the main studies used for empagliflozin, EMPA-REG trial, CANVAS trial, DECLARE, and all these DECLARE, TRIMIC trial, everybody, these are atherosclerotic and non-atherosclerotic arm, both arm has been covered by these trials, and all these trials have shown that worsening heart failure and CV death have been significantly reduced with use of SGLT2 inhibitors compared to those who have been treated with placebo in DAPA heart failure trial, DAPA HF trial. So this is another empagliflozin used trial, EMPA-REG trial, where we can see both patients with low EF and preserved EF have been taken, and empagliflozin was randomized with placebo trial, and after 3 years of study we can see them also there is significant reduction in primary outcome when compared to placebo. So this is the recommendation for ESC 2021. We can see that SGLT2 inhibitors are being advised as a therapy for heart failure, heart failure without diabetes or with diabetes, and also the patients with diabetes who have major cardiac events or are at risk of major cardiac events in future. So this is the summary. To summarize, heart failure is a common complication of diabetes, and ARNI group of drugs are more effective in diabetes heart failure patient and additional benefits of glycemic control. Thank you. Thank you very much.
Thank you. Thank you, Sotten. And one thing which I gathered from your presentation is SGLT inhibitors are a heart failure drug. We believe
now very much heart failure
we
drug.
believe they are anti-diabetics. You
But
believe they are
believe
heart failure drugs.
That's very much now a heart failure drug.
And in many presentations I've heard the 4 pillars of heart failure management: ARNI, SGLTI, GLP and finerenone. These are the 4 pillars of heart failure management, as we learn from many cardiologists. Thank you, Sotten, for that wonderful presentation. And we can have the question answers after the next speaker, who also is another cardiologist, Dr. Tuton Das. Dr. Tuton Das will be talking, we have discussed the spectrum of heart failure in diabetes, We will now discuss the spectrum of arrhythmias in diabetes, because many of our diabetics succumb to sudden cardiac death because of arrhythmias, and then we wonder, how did the patient die?
Hello everyone. First of all, I would like to thank the organizers, especially Pankaj sir, for giving me the opportunity. I am proudly the last speaker of today's exhaustive academic discussions. Not much audience, but still we'll be discussing. I'll be trying to cut short my presentation, and of course discussing the important things. Now my topic is arrhythmia in diabetics. Why this topic is important? First of all, it is underlooked in our practice. We don't screen for arrhythmias, or we don't give much importance to this. Second thing is, in many conditions, it is preventable. So, and the third thing is, sir has already chosen this. Sorry. So arrhythmia and diabetes. Arrhythmia has, I'm extremely sorry, I need some water. So coming to arrhythmia, either it is tachyarrhythmia or bradyarrhythmia. Sorry, I'm not feeling well. Just taking one time. I'm not feeling well actually. I'm sorry. Will take some time and don't mind. These I am feeling like a viva. I am the last candidate during my MBBS and exam days. So when I am the last candidate, I used to feel like this. So in any patients who is having diabetes, risk of arrhythmia is usually increased. So why? These are the 1, 2, 3, 4, 5, 6 mechanism it is mentioned here. But the most important thing is inflammation. Any chronic disease is an inflammatory state. So these are,
can relax. We are all, you know, all of
yes,
us.
Sir,
Just relax
yeah,
and tell us what you want. Give us a message. Just relax.
This is what, sir, I am trying to say, but I am not able to say. Just
no one is judging.
No, it's not a judgment, sir. Of course. What I have, what I have. In diabetes, what happens? There are many mechanisms by which arrhythmia occurs. One of the thing is electrolyte imbalance. The other thing is this atria get fibrosed. AF is the most common arrhythmia in diabetic patient. AF, VT, AB block is also commonly seen. Usually is due to ischemia of these electrical connections. And some drugs also increase risk of arrhythmias, like even insulin. Then some drugs like albiglutide, which was one of the first GLP-1 receptor agonist. Then arrhythmia, we need to understand, we need to do a Holter in many of the patients, because all the arrhythmias are not symptomatic. So these are the medications I was discussing about. So these are the acute conditions. In acute conditions, we have to see what is the cause of arrhythmia. Mostly it is electrolyte imbalance or other hemodynamic conditions. VT, of course, all these things are there. These are, I'm not able to discuss in details. So these are the things what we should be doing in acute conditions. Few misconceptions we are having in arrhythmia and diabetes. If you control your sugar very tightly, whether is it going to help or not? The answer is no. Not all arrhythmias. But if you control your sugar properly, then many of the arrhythmias can be prevented, but not all the arrhythmias. So those patients having CKD, CLD or heart disease, it is advisable not to do very strict control of the diabetes. Then atrial fibrillation symptoms always present? No. If you ask me what is the most common arrhythmia, it is clinically it is atrial fibrillation, but if you do a ECG or a Holter, then it is ventricular premature beats, VPCs. So in most of the cases, as I have mentioned, we need a Holter for that. With anticoagulation carries equal risk in diabetes. Now, in AF patient, you are giving anticoagulation with CHA2DS scoring. This anticoagulation is going to work equally or not? Yes, it is effective equally, but the side effects are little more in patients with diabetes. In patients with diabetes, there is more chance of bleeding with anticoagulation. So next time, screening, monitoring and prevention plan, immediate actions, whatever this thing, like one of the things we commonly underlook is QT prolongation. So some of the drugs we are using in diabetes, they usually cause QT prolongations. So those drugs should be avoided, especially in case of hypokalemia and hypomagnesemia. So I have not also, I don't know, I have not been able to make you convinced, I don't know, but yes, after this whole day presentation, I'm also like this, and I think your brain is also like this, blank like this. So extremely sorry for the problem initially. Thank you.
You need not be sorry about anything. There's nothing blank. We are all full with knowledge. And I put this topic primarily because I, as an endocrinologist, sometimes face difficult situations in the ICU, and also many diabetic patients, at least maybe one every 2 to 3 months, who suddenly dies at home. One admitted diabetic patient suddenly dies in the ICU. And we generally believe that these are because of arrhythmias, underlying arrhythmias which happen in some of these patients, or these sudden cardiac deaths.
Yes, sir.
What are the explanations for this sudden cardiac death in a, not a normal or a healthy, but an apparently normal diabetic patient who was not supposed to die?
Yes, sir. So I think long back there was a dead in bed syndrome. There is something called dead in bed syndrome. So patient is extremely fine, just sleeping, and next day he found to be dead. And many of the patients are having diabetes. So one of the cause is, of course, I will say hypoglycemia is one of the cause. If the patient is not having arrhythmia, that is one of the cause. Second thing is, even the patient is hypoglycemic, hypoglycemia itself and the chronic changes because of hypoglycemia, like autonomic neuropathies, the drugs we are using, those drugs can changes to autonomic neuropathy, like it can cause autonomic neuropathy. So these are multiple things. Usually atrial fibrillation, hardly patient dies. Atrial fibrillation makes initially, if it is acute, it will either cause some symptoms because of the high rate, or what it is going to do, it is going to produce some complications like stroke or CB, like MI or anything. So atrial fibrillation, hardly patient dies in acute condition. The second thing is ventricular tachycardia or ventricular fibrillation. Now the ventricular tachycardia and ventricular fibrillation as such in a normal structural heart is very rare, unless they have some channelopathies. Of course, we cannot, in Indian setup, we cannot screen for all the channelopathies. But if it is a structurally normal heart, patient is not having CAD, we have done angiogram or cardiac MRI. In such cases, if someone is dying, then we have to think of the causes which is causing the VT. And one of the causes is hypokalemia. Many of the drugs we are using in diabetes causing hypokalemia, including insulin. So that hypokalemia or hypomagnesemia, it triggers VT. So that is one of the explanations.
But I must point out that it's a misconception that insulin causes hypokalemia. IV insulin causes hypokalemia. Subcutaneous insulin generally does not cause hypokalemia, but obviously SGLTIs can cause hypokalemia. The number of diuretics that the patient is on can cause hypokalemia and various other reasons. Thank you so much, Tutan, for that presentation. I'd request both our speakers, Shotten and Tutan, to the felicitation podium, and our chairpersons, please, to felicitate both our wonderful cardiologists from Durgapur who have made to this endocrinology conference to take care of the heart. Obviously, cardiac causes are the most common cause of death in patients with diabetes. We thank you all for being part of this wonderful conference for this whole day. We promise to come back with more next year with your heartfelt cooperation and suggestions, if any. The high tea is open right behind you with the traditional Chow dance of Purulia. Please join us for some tea and snacks and enjoy. I wish you all a happy journey back home. Good night and take very good care of yourselves. Thank you so much.